activity of daily living scale, general health, general physical health, cognition, mood. And of course, we have also to ask patients about their activities like crunchman, hunting, hooking, etc. And to take account also for some individual specificities like astigmatism or myopia or hypermetropy to choose the good IOL. So with this, we very important before surgery, before to speak with patient and to ask them what are the visual demands. And with that, after that, we can, of course, we have the exclusion criteria, like for multifocal lens, we cannot, it's not good for nice driver because we have to allow. And we have to take account also for anatomical criteria like myopia. It's not very nice for high myope to do multifocal or toric lens because the lens is not good centration and can turn, and we can have a tilt. And also psychological criteria like to avoid demanding patients. And also we have to take account of pre-existing ocular condition like diabetic or retinopathy or glaucoma or macular degeneration. What are the preoperative examinations?
Download.
First, we have to develop the operative strategy for both eyes. And during the consultation, we have to take acquisition of the image and to check the ability of and order the IOL, and of course, operating room programming. So in slit lab examination, very important. And also the first case, we see the topography and if our patient has the astigmatism or not. Of course, we have to take account if cataract is easy or not. Biometry, of course, new formula with biometry, macular microscopy. And as I told you, we have to manage astigmatism and type of astigmatism, regular or irregular, the axis of astigmatism, and the importance of astigmatism. And with this pre-op evaluation, we can propose to the patient some IOLs like monofocal IOLs or multifocal IOLs for bifocal for near and distance, trifocal for intermediate vision also, and the more and more head-off IOLs for extended range of focus, and of course toric IOLs to manage corneal astigmatism. So to resume, we have 3 steps: acquisition, planification, and guide during surgery. 3 steps, very important to be reproducible in these 3 steps. Pre-op evaluation, of course, biometer optical is better than ultrasound, and new formula like Barrett is very important. If we have some reference unit to have for planification, like Varian machine from Alcon or Callisto from Zeiss, we can do planification and have a good idea about pupillometry and keratometry, and we can have reference images, and then we can do planification. Here it's a small video to see the acquisition by the optometrist, or it's very easy to have topography. Then after we have biometry, and after that we can check make the analysis of the lens. Good centration here. Very important to have the good exam, good centration, good images. We can do a lot of exam, change the topography, to topography or to biometry. And after that, we can have the lens and proposition the lens from the machine, like here for toric lens. And it's very personalized technique and depend of each surgeon. So planification here, I am using with Varian platforms, very, very good, very nice, very easy to use. And you have the target here, the target refraction, and also the expected outcome, the refraction after surgery. And it's wonderful. We always be at outcome. So the current process, it's very important to have a good, to avoid error, to be reproducible in each step during surgery. So also during surgery, you have to make, of course, it's not like a normal cataract. When you have a premium IOLs, you have to take anesthesia. If we have exigent patients, we can do local anesthesia, not topical. We can also choose the blue vision or not, micro incision. And of course, with digital marker, we can use femtosecond laser or cataract surgery. And this digital marker, it's in the surgery room. We can have an incision guide for capsulorhexis guide and centration guide. This is here are some photos about incision mode. During surgery, we can have capsulorhexis mode and centration mode, toric lens, and with the alignment of lens and final lens. Here, for me, I always do 3 incision, 2 main side ports, and 1 main incision for 2.2 millimeter. And this is my surgery, and it's very nice. It's very easy to do surgery with the image in the microscope. And of course, we can also do a regular rhexis for 5.5 millimeter. More easily with the Varian machine or with the guide than without. And also with toric lens, we can here with bimanual irrigation aspiration, we can place the lens in the good, fix the lens in the good position. Here we have the graduation during surgery, and we can put the lens in the right axis and also remove viscoelastic on the lens and behind the lens. And after that, in the end, we have to check the lens position if it is the good position or not, and good access. So in post-operative control, it's very important to do the verification of the lens without dilatation with machine or in the slit lamp. And also we can do some statistic automatic evaluation after a few cases and optimization for future results. What are the post-op results? Of course, we have better visual acuity and visual function cataracts that improves functioning in everyday life with respect to vision-dependent activities. We have decrease general function, decrease in the rate of falls after cataract surgery. Second, eye surgery can be important in improving binocular vision. And of course, we have better health-related quality of life and better cognitive and emotional well-being. So here are some cases for some lens. Here, VVT, standard-off lens, before surgery aids with astigmatism after surgery. Topography biometry. Here we are an example for bifocal acryl bifocal lens for pre-op and post-op. Very nice results. And trifocal lens, toric lens, trifocal toric lens. We had trifocal toric lens for this patient, both eyes. We have 10-10 without glasses. And toric, okay. So, well, video of panoptics, it's also easy to, it's not so important to show. Is the VVT IOL. I'm very happy with the VVT. It's give me great satisfaction for me and patient. And of course, we have to know each IOL, the limits for each IOL. For example, multifocal lenses are not good for driver because we have the halos, and we have less halos with head-off. Multifocal lens require a good light for reading, and also for head-off lens we have to put the lens for reading. It's good for intermediate, but not for reading. And also from time to time we have some patients who will not have a good acuity from so far with multifocal lens. And of course with bifocal lens we not have the intermediate vision. So in synthesis, always think about refractive lens surgery, suggest the intervention as soon as possible, choose the IOL.
We are already behind the time, if you can.
Yes, we have to choose the appropriate selection of the IOL for surgical procedure. And with the advent of this new area of artificial intelligence, it's our diagnostic and measurement devices that will be able to compare the anatomical data of our patients with their lifestyle habits to propose appropriate intraocular lens for each individual. Thank you very much for your attention.
Thank you very much, Dr. Abdulrahman, for this excellent presentation. Maybe we'll have some question at the end of the sessions. So because we are a little bit behind the time, so at the end we will have a few minutes for discussions. Now we will move to my dearest friend, Dr. Khalid Aish, and he will give us a talk about biometry in extreme eyes. Dr. Khalid, the mic with you. Unmute yourself, please. You can share screen, Dr. Khalid.
Okay, yes. Okay, can you see my screen?
Yes, Khalid. Yes, please. Go
Yes.
ahead.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Thank you for this invitation. For the sake of time, I will start my talk. It's about biometry on the outlier eyes. This means that we are talking about the long eyes, which has diameter of more than 26 millimeter. Short eyes, when we have diameter less than 22 millimeters, including the nanophthalmic eyes, which are the very short eye and the very shallow anterior chamber eyes. The guidelines in 2011 was in short eyes, the recommendation was the QOIC. In long eyes, when we have 24.5 diameter to 26 holiday 1, and in extreme long eyes, SRKT was the recommendation. Is this guidelines still valid in 2023? I think no, because there are a lot of drawbacks about the formulas at that time, because these formulas are based on an eye model, and therefore they need to estimate the implant position for the IOL calculation. And these third generation IOL, like the QOIC, the Holiday, or the SRKT, they estimate the lens position based on the axial length and K measurements, and they assume that long eyes as well as steep corneas have a deep lens position, and short eyes or flat corneas have a short or a shallow lens position. So this assumptions is why all of these formulas provide weak performance with extreme eyes, because the vast majority of long eyes as well as short eyes show normal anterior chamber dimensions and are not deep or shallow as assumed by these formulas. And this table we can see that a lot of short eyes have normal anterior segment size, and a lot of even normal eyes can have a shallow or a deep anterior chamber, and also many of the long eyes have even a shallow anterior chamber. So what this explains why these formulas perform bad in the extreme of eyes. And these formulas are based on only two variables, but they are based on axial length and in K readings, and they do well in average eyes. But the new formulas, they have an additional parameters like the lens thickness and the optics, and they do better in these eyes, such as long eyes with shallow anterior chamber or short eyes with deep anterior chambers. What is the problem with myopic eye? The myopic eye, the standard refractive index is no longer accurate because there's increased optical pass through the vitreous, and this gives that the axial length is overestimated in these eyes. So this leads to hyperopic surprises. And what are the options to save these problems? They came out with a one-Koch method, which an adjustment for the axial length. And what the one-Koch adjustment, it's compensate for the overestimation of the axial length with the standard biometry. So they reduces the axial length by a formula-specific coefficients. And this, at first, was the guidelines for one-Koch adjustment. Then they have an updated adjustment methods, like they can be used only for SRKT or QOIC, Holiday 1, and these are the guidelines that updated recently. But the problem with this is that they avoid the hyperopic surprises, but on the contrary, they increase the myopic errors. And this one Koch is not required for Haigis, and recently they do not advise to be used also for Holiday 1. And these should not be used with Barrett, Olsen, or Hill RBF methods, and should not be used post-refractive surgery. So the second option is that some other formulas, the newer formulas, that they do not require the adjustment, one Koch adjustment, like the Barrett, the Olsen, and the Kane, and the Hill RBF. So these formulas can be used without axial length adjustments. If we look at this table, we can find that the Barrett formula do well. This is the diagram showing the axial length. This is the axial length, and if we can see here that the Barrett formula performs very well in long eyes, in contrast to the SRKT formula, for example, or all the Holiday 2 formulas, or even the Haigis. They perform good in average eye, but in long eyes they do not perform that much well. So to summarize, in long eyes, the top 3 options are the Olsen, Barrett, Haigis. Unadjusted one is doing well, but one to avoid is the Hoover Q and the Holiday 1 formula in long eyes. One Koch adjustment is not great because a lot of eyes becoming myopic rather than hyperopic. So using formulas without the one Koch adjustment is a better options. Kane and Evo also are good options in long eye. So the outcome in long eyes are better because we are dealing with a lower power IOL, and expected lens position has low impact on the outcome, in contrast as we will see in the short eyes. Now for the short eyes that are less than 22 millimeter diameters, Douglas in 2017 came without a line of this, where the best outcome was with the Holiday 2 of around 77% of eyes within a quarter of a diopter. The Hoover Q formulas was not performing well. So where is the error in hyperopic eye? The error is in the expected lens position, because in these eyes we are dealing with a high power IOL like 30 or 28 or something, and even a small shift in the position of the IOL will lead to a high refractive change, in contrast to long eyes where we put a low power IOL. So any shift in long eyes will not affect the outcome as much as the hyperopic eyes. And everyone now, if we say short eyes, then okay, Hoover Q is the ideal formula. Where this came from? This came from a study done in 2011, and they studied around 8,000 eyes with only 134 eyes of axial length of 21.5. And at that time, in 2011 or 2010, when they did this study, they only used the third generation formulas like the Hoover Q, Holiday, and SRKT. And at that time, the Hoover Q was the best formula to perform compared with the other versions formula. Is this still valid nowadays? No, because now we are having better formulas, and the evidence supporting Hoover Q in short eyes is out of date. In 2016, 2018, Kane and Mills came out that Hoover Q is one of the poorest formula for short eyes, and they came out that Barrett and Holiday 1, they even perform better in eyes with 21 to 22 diameter range. And this is, as we can see here, in short eyes, where we can see the Hoover Q formula is performing the worst among these when compared with the Barrett or Olsen formulas. In another study, they found that the Kane formula was more accurate and even better than Barrett Universal to Haigis, Hill RBF, and Holiday, and Hoover Q. And Kane is another formula that is good to be used in short eyes. So to summarize, the top 3 options in short eyes, we have the Barrett, we have the Hill RBF 3, and the Kane formula. But we need to note that Hoover Q is good when compared to Virgin's formula, but it's not good when we compare it with the newer formulas we are having now in 2023. And the performance of these formulas is a little bit worse or weaker than the performance in long eyes, because we are dealing with a very high power lenses, and any shift in the position of these lenses will affect the outcome much more. So when we are dealing with an average eye in terms of axial length, in terms of anterior chamber depth, in terms of keratometry, most of the formulas, they perform well. But when we are going out of the average eyes in any of the three of these parameters, they found that the barriers retains the greatest consistency across all variables, and eyes with very short axial length, no formulas did that much well. Thank you very much.
Thank you very much, Dr. Khalid, for this excellent presentation. And you make the things that difficult in a simple way. Very nice.
Thank you.
This topic is very difficult. Most of the time, nobody like to hear, but you make it very easy and very concise. And you make it in a very short. Thanks a lot. So we will keep, so if there's any question till the end. The third topics, Dr. Walid available, Dr. Walid Zabiba. So Dr. Walid, he will give us a talk about IOL fixation.
Yes.
What's new?
Okay.
Let's summarize. So thank you, Dr. Walid, for being with us.
Thank you. Okay, I will share my screen.
Please.
Okay. So it's okay.
Yes, please. You can go ahead. We
Okay.
ask my colleagues to mute themselves, please. Okay, thank you.
Okay. So first, let me thank you for Dr. Amri for the invitation. My topic today is about will tackle two main techniques that I have used, and I will mention the benefit and the drawbacks of each one of. So as you well know, the loss of capsular bag is a challenging issue. The surgeon to decide the type of the IOL he should use. This situation could be the complicated cataract surgery, IOL exchange, and substituted IOL. Several techniques and IOL are supposed to correct this condition. In order to settle a stable IOL, maintain the normal eye anatomy, be a good functional outcome and decrease complication rates. We do have three options for implementation. IOL, iris fixation implantants, and the well-known scleral technique. Today, we're going to focus only on commonly used option, which are the scleral fixation, since it seems to physical state, because to the eye nodal point, and there is a minimal endothelium cell loss. And that reduces the risk of the ocular hypertension in the outcome. The rapid rise in technology and wide degrees in fixation have been cited, but when shed light on worldwide used Yaman modified commonly performed and the recent one Carloval technique. The Yaman technique was in 20 modified in 2017 with different varieties. We use three-piece intraocular lens, the one with the helix gives the finest stability in the sclera insertion. Called this kind of carbogize mention. Now let's make a look. We don't need an expensive tools or instruments for this technique. First of all, we make cornea for introducing the forceps. and passed the needle transconjunctivally 2 millimeters posterior to the left, 180 degrees apart. Okay. After that, we docked into this needle. We got the haptic in the needle of each needle. After that, we draw and the two haptics in the side. Exercised haptic ends are melted with a cautery, created a bulb shape enter the conjunctiva tunnel. According to my experience, the IOL via the introducing of the facilitate the monitoring of the both haptic and needles. There is this like the absence of a contraindication of this and with the standard IOL, no complication related to the suture or the glute, and there is a minimal UV with the IOL. Now let's move on the Carloval IOL, which is the lastest method of the.
Dr. Walid, can you hear me?
Yes.
All the presentation there is an interruption in the internet, so most of the things we are not hearing very well, unfortunately. I thought it will make me. Hello, can you hear me?
Don't hear you very well. Yes, now yes.
Okay, because you have a problem in the internet. We cannot hear you. Most of the presentation we are not able to hear very well. We can, you know, I don't know, because most of the time interrupted, we are not getting the idea or the things that you want to pass to us.
So
if you can, we can have it as a recorded at the end. If you can record, yeah, we are not able because it's very difficult.
Okay. Yes, I can send the
recorded, please. Yeah, I advise to send us the recorded to the email. They will play it from here. Is better. Okay. So I will, if you allow me, I will stop from here and I will ask the other presenters to be given. Okay. Thank you very much.
Okay, we'll do it. Sorry.
Okay.
Sorry.
Thank you.
Sorry.
Thank you. Yes. So we are sorry that I thought maybe it will be improved in a time, but it seems there is a lot of problem in the internet with Dr. Walid. So we can move now to dearest Dr. Mohsen Al-Baqali, his presentation. And his presentation, it will be tips and tricks in pseudo exfoliation management. And it is a pre-recorded presentation. Can you please, the team, share Dr. Mohsen presentation?
Bismillahirrahmanirrahim. Hello, everybody. I would like to thank the Mayom Academy for honoring me twice by associating me with the Mayom board and by inviting me to participate to this session. My talk today is about a common association between cataract and pseudoexfoliation, which can complicate the cataract surgery. We will review some tips and tricks in order to avoid and or to manage the difficulties inherent to this association. It must be emphasized that the cataract and pseudoexfoliation are both age-related pathologies whose frequency and severity are age-related. The combination of cataract and pseudoexfoliation its definite risk factors for cataract surgery, as the complications are at least 10 times higher. The first aggravating factor is the zonular fragility, which can seriously compromise the outcome of the surgery. The preoperative assessment is of utmost importance, whose purpose is to analyze all risk factors, namely the pseudoexfoliation spreading, the poor iris dilatation, iris sphincter atrophy, endothelial cell degradation, phacogenesis and iris donysis, the anterior chipped variation, especially when we have before surgery decreased anterior chamber, and the narrow angle and the eye hyperpression. And the key of these assessments is to deeply analyze the association to associate zonulopathy. Moreover, the preoperative assessment has the triple goals: to analyze the cataract, to analyze the associated lesion of all anterior segments, and to be prepared to different surgical scenarios, simple or complicated, phaco, and in some situation to be to do phaco and anterior vitrectomy. The screening of the zonulopathy should be done before or during before and during the surgery. Before the surgery, a big attention should be given to the above mentioned element: the material exfoliation spreading, the poor iris dilatation, iris atrophy, and we have to focus to assess before surgery the anterior chamber depth. The zonular fragility can be noticed at the beginning of the surgery with the famous sign of the capsular touch, which consists in noticing an abnormal mobility of the bag as soon as we start the capsulorhexis. It's very important to notice this sign when starting the capsulorhexis because we give us an idea about the bag stability. The preoperative precaution consists mainly to those objectives: to protect the ocular surface, to maintain a good iris dilatation up than 5 millimeters. If not, we should use iris retractors, OVD, or other devices, and to protect the capsular bag and the zonula when doing this kind of surgery. The protection of the zonula and the capsular bag is achieved through the following measure: using the OVD to maintain the anterior chamber stability, dispersive and cohesive, to maintain very iris pupil dilatation more than 5 millimeters, to do gentle hydrodissection, and to avoid nucleus rotation in some cases. The main novelty that we describe in this presentation is to show how to carry out of safe phacoemulsification without nucleus rotation. This is done by sculpting sculpture of the nucleus into stages. At the beginning in the central, which is classical, everybody will do the kind of when we start to do phacoemulsification in the axis, as shown in the picture number 1, and a lateral sculpting as shown in picture number 2. This can be done by making a rotation of the headpiece without the rotation of the nucleus. This maneuver it's very helpful to solicit and to make the bag and the zonula more fragile and more weak. This maneuver of rotation of the handpiece avoid the solicitation of the capsular bag, so the handpiece will move laterally as wall clock. And I highlight the fact that it's very helpful in very hard cataract with no stable bag and capsular with the zonular with the zonular fragility. It's very helpful to do this maneuver. Besides protecting the capsular bag, we focus on the fact that we should maintain a constant good anterior chamber by constantly injecting the OVD and the add of sculpture and the add of irrigation aspiration. I mean, we have seen in the video before to go out of the eye, the handpiece or the AI we should make deeper the anterior chamber by injecting the OVD. Sometimes, despite all the measures taken, the capsular bag is clearly damaged, and it is necessary to act quickly in order not to aggravate the situation. The measures to be taken are as follows. Avoid a flat anterior chamber by injecting OVD and using and injecting a CTR capsular tension rig as soon as possible and in the correct side. I mean, all the time we should inject the CTR in front of the weak zone of the back, as I show in this video. The choice of the intraocular lenses is imposed of the state of the back and the zonula. I personally advise in this situation to use the 3 pieces IOL MA60. This kind of IOL we can use it in and put it in the bag or in the sulcus, and even we can use this IOL by scleral fixation. The take-home message is that in this kind of surgery we have to be able to be faced to some complication, and the situation of this kind of surgery. We have to take caution before the surgery, during the surgery, and after the surgery. Before the surgery, we should be prepared to be and able to face up of those 2 elements: poor iris dilatation and zonular weakness. During the surgery, we have to maintain anterior chamber stability by using OVD, and to maintain very good iris dilatation, more than 5 millimeters, to do gentle hydrodissection, and in some situation to avoid to do a nucleus rotation. After the surgery, the follow-up after the surgery is essential, and we should focus on the iron stability and inflammation and the eye pressure. My take-home message at the end: this situation, I mean cataract and pseudoexfoliation, it's a very challenging situation, and it's a really very risky surgery in risky eyes. Caution should be taken before the surgery, during the surgery, and after the surgery. And in these cases, all information and all scenarios should be given to the patient. And at the end, I would like to thank again all the Mayom Academy, and wish you welcome to our meeting in Rabat at December. And before this meeting, of course, we have appointment together to the next Mayom Academy in October. Thank you very much, and see you soon.
Thank you very much, Dr. Mohsen, for this excellent presentation, and very nicely showing all the steps for this critical, actually, situation that we are facing most of the time. I think we can go to any questions. Is there any question from the attendees here? We didn't receive any questions, so I will start with Dr. Abdurrahman. Dr. Abdurrahman, you present a very nice topic as usual, but if you want to summarize in 2 words, what is the message, the key message in this presentation?
In 2 words, we are doctors, so we have to, when we speak to the patient, we have to know exactly what's his demand, what's the problem. And after that, we have to choose the good hours for each patient. And now we can choose and we can have a good, precise vision after cataract surgery with premium IOLs. And we have to choose which IOLs for which patient.
In another things, well, also there is something, I mean, for example, we are as a doctor facing some patient, they are highly demand. And at the same time, they are having something like, you know, in another presentation, as Dr. Khalid mentioned, high myope or very high, I mean, hyperopic patient with small, short eye. So how you can manage in this way in passing the message for this patient?
Yes, of course. Of course, we have to take account some individual specificities for each one. And for high myopia, for example, for me, I don't use multifocal lens, either no toric lens for high myopes, because the lens is not good centration, and you have the big capsular bag, they can make rotation. For hypermyope, they are very happy with multifocal lens, for example. So we have to take account some specificities, anatomical specificities, and we have, of course, we have to take also for our experience with each lens. But in general, essentially, I am very happy with the premium lens, and also I am very happy with the Variant platform. I am not using Callisto platform yet, but I think that it will be like the Variant platform. It's very precise. We can have a very predicted acuity, visual acuity in post-op.
So now we can say the cataract surgery is not a normal surgery as we used to say before.
Yes, it's not normal surgery. And there's a point, very important point, we have to be honest. Sometimes we have some complications during surgery. So if you have, we can change the strategy during surgery for piggyback IOLs, for artisan lens, for subluxation lens during surgery. We can choose to put another lens, but no problem. We can propose to the patient the bioptic treatment with the refractive laser surgery after. But before surgery, we have to make a good planification, and we have also to have a good acquisition of all the exams to have the good choice. And you know, you have to, if you make the good indication, we have less complication.
Thank you very much, Dr. Abdulrahman. Dr. Khalid or any others, I mean, Dr. Mohsen or Dr. Khalid, if they have any questions for Dr. Abdulrahman.
I have a question, please.
Yeah, please, Dr.
For Abdulrahman and for the panel. My first question, do you have any experience about multifocal IOL in childhood and for kids? And the second question, we have many patients with one eye surgery with monofocal IOL, they are not happy. Can we plan for multifocal IOL in patient with monofocal in one eye and multifocal in another eye?
Personally, I prefer to do multifocal in both eyes, and in the short time, 3 days before surgery. And multifocal for me is not for child, because child change their vision with growing. So it's for hypermyope, epimetrope, and less not good high myopia. But two eyes with the multifocal, not only one, not monofocal, not mix and match with the monofocal. If you have a patient who is not happy with monofocal lens, we have to make the good question why he's not happy. And we can change the lens in the same mode. We can change the lens easily, but no, I prefer multifocal in the both eyes. I'm very academic, both eyes, and monophthalm, of course, why not? But both eyes, not one monofocal and other multifocal.
Can I have a question?
Yeah.
If you have a chap like 30 years and he came with a cataract in one eye and the other eye is normal and he can see near, do you recommend multifocal for him or trifocal for him?
No, if he have only one cataract, unilateral cataract, he's 30 years, I will do monovision, and with the monofocal lens with a little myopia, microvision, minus 25 or 1.50, and you will be very happy to see for reading. Or I will put sorry, this is case for people who are over 45 years, but he is less than 45 years. I will do emetropia lens with monofocal lens. Now we will see the near vision with the other eye, though no problem, monofocal lens. Because we have to take account with the quality of vision. And monofocal will have a good quality.
Thank you.
Okay, so now for question for Dr. Khalid. Dr. Khalid, okay. If we want to summarize, so your advice, what is the best formula for long-sighted, and what is the best formula for long-sighted?
For me, I usually depend on the Barrett formula, because Barrett formula is a very good formula, and it's just one formula that you can use in different eyes, so that you do not want, oh, I will look at the biometry, check the biometry, and then I check which formula to use. Barrett formula is in general is the most consistent formula in different situations: long eye, short eyes, long eye with short anterior chamber, short eye with long anterior chamber or deep anterior chamber. It's the most consistent formula. So I usually recommend Barrett formula in different scenarios, because it performs well in these different formulas. The problem is the very short eyes. The very short eyes, we still get some surprises. So I may use Barrett formula, I may use the Kane formula in these eyes, or we don't have the lens star, but the Hill RBF3, where they add a lot of eyes with short axial length, also performs good. So Barrett formula is a very good formula. If you want to also to add another formula, maybe Kane and even Olsen perform well in long and in short eyes.
Any question from Dr. Abdurrahman or Dr. Mohsen for Dr. Khalid?
Any one question, please?
Yes.
Yeah, please.
Dr. Khalid, أهلا بك. You highlight a very important point to focus about anterior chamber depth when doing biometry. And I share with you, I agree with you totally, we can have high myopia with anterior chamber very, very, very small. In which cases you will be to do laser iliac iridotomy before to do surgery, which the amount of the anterior chamber you will that the surgery will be very risky in a small anterior chamber.
Actually, I don't do peripheral iridotomy even in very short eyes, because once you remove the lens, even if the axial length is 20 or if the anterior chamber depth is 1.7, last week I had a case with a 1.7 anterior chamber depth, and the second day after we removed the huge lens, then the anterior chamber came deep. So usually after surgery, these eyes get a deeper anterior chamber, and now one of the treatment options of angle closure glaucoma is to remove the lens, even if it's a clear lens, because once you remove the lens, you debulk the anterior chamber, you will get a deeper anterior chamber. So routine, I don't usually perform. This is for my experience. I usually do not perform peripheral iridotomy.
We have a short time, so because the second session it will start. Okay. I don't want to interrupt you, but we have 1 minute, so we will. If you have a short answer for any questions, we have also one question to Dr. Mohsen regarding: is there any, a very different categories for pseudo exfoliations, or they are all the same, whatever the pseudo exfoliation you are seeing?
No, certainly not the same. I think the bad situation, it's pseudo exfoliation with meiosis. When with dilatation, it's very poor. It's like we told for young ophthalmologists, small dilatation, big problem.
Yeah.
Any other question from Dr. Mohsen?
Mohsen, one question. What do you think about hard cataract and syndrome exfoliative? I think to have a hard cataract very hard cataracts, it will be a more problematic than normal cataracts with exfoliated syndrome. I think
Sure.
Yes.
That's why I focus about the endothelium. We have to keep in mind that hard cataract will be very long time surgery, and we have to keep in mind which the amount of endothelial cells, and in some cases not to be to go directly to extracal.
Can we have one question to Dr. Khalid? We have
Yes,
time?
please.
Okay,
Yeah, we have only a few seconds, please. Yeah.
A few seconds. Dr. Khalid, thank you for your presentation. As I told before, for high myop, I avoid toric lens and multifocal lens, but from time to time, some patients are demanding to have precise acuity with toric lens. So in this time, I have a look on the thickness, crystalline thickness, lens thickness, lens thickness before surgery. If it's less than 4 millimeter, I can do toric lens.
Toric lens, yeah.
I will have an idea about the capsular back. That is my idea. Is it true what I'm doing or not? Do you have an idea?
Okay, we are almost done. Within 1 second, Khalid, yes?
1 second, yes. I think with the new formulas, they are performed very well, even with toric IOLs. But in these situations, you need to worry your patients that the outcome might be not as expected, but usually they will get a very good outcomes, and they will be very happy, even if they have even 1.5 diopter of astigmatism at the end. They will be very happy, these patients.
Thank you very much.
Sure.
Thank you, Dr. Mohsen. Thank you, Dr. Abdurrahman. Thank you, Dr. Khalid and Dr. Walid, for these excellent sessions. We hope to see you in the other or in future. And we are going to conclude and pass the mic for Dr. Barol. She will start the glaucoma in this hall. Thank you very much.
Thank you very much. Thank you all. Goodbye. Take care.
Thank you. Bye.
Goodbye. Sorry, can we have the participants for the glaucoma session? Can you please make them the panelists?
Ma'am, they are already made, sir.
Wonderful. So without much ado, I would like to start the glaucoma session 1 for the 8th Qasimi Ophthalmology International Conference. And our first speaker is Dr. Sohaib Mustafa. Dr. Sohaib, are you there? Dr. Sohaib? Well, today's session is about potpourri of challenging cases. We all learn from each other's experiences when it comes to dealing with challenging cases. So here we have a huge panel of well-established glaucoma surgeons who practice both adult and pediatric glaucoma, and they were sharing with us their challenging cases. So our first speaker was Dr. Sohaib. Are you there? Yes. Dr. Mohammed Sohaib Mustafa is trained
Yes, I'm here. Thank you.
At UK, and he's currently a faculty at the American Hospital, Dubai. And we are indeed privileged to have him with us. And he would be presenting a case on an interesting case of myopia. So over to you, Dr. Sohaib.
Thank you very much. Can you all hear me? I'm just going to be sharing my screen. Can you hear me?
Yes, absolutely.
Can you still hear me?
Yes. But cannot
Okay,
see
great.
you.
Thank you very much. So basically, we're going to be presenting great. Thank you. So we'll be presenting a case, quite a complex case of myopia and primary open-angle glaucoma. So no financial disclosures. Essentially, this patient already had advanced glaucoma when he presented to me now a couple of years ago. And he was a high myope with pressures of 32 in the right eye. Left eye was 21. And he's previously had a trabeculectomy with mitomycin C and needling with 5-FU. He was on maximal medication, not so tolerant on acetazolamide. He was on all the topical medications and his pressures were at the level of 32. So what we had planned essentially is to do a Bervelt tube 250 with a scleral patch graft and the use of fibrin glue, and to put a supramid in situ as well. After all this was done, the right eye pressure was around about 10 on no drops, and the left eye we managed to get down to 14 with some changes in the medications. But you can see that from the field of vision, he has already had quite advanced loss. So how did we go about doing this? Let me just advance my slide here. So I have a video of how we exactly did the surgery. So there are various tubes that we can use, but essentially with any glaucoma surgery, it is good to be in a situation where you are under control of the surgery rather than the surgery be in control of you. And you know, with all what we have available to us, it was felt that Bervelt was the best option because it gave us the maximum control in terms of bringing the pressure down. Because what we're dealing with here essentially is the high risk of hypotony, and we want to be able to bring the pressure down in a piecemeal fashion, as you know, when we want it. In regards to when we look at the healing ability of the person. So what we did here is that we implanted the Bervelt, and you can see here we're doing that 10 millimeters back with nionoproline sutures. We have a supramid in situ. What we did here that was a little bit different is essentially we did 10 nylon ties. So one is on top of the supramid, which was the tighter of the stitches, and then we did another one that was proximal to it, which essentially was another safety stitch when we release the one that is above the supramid. So these sutures, which are nylon sutures, we can suturelize them at any point in time. So this gives us good control. And of course, the supramid allows us to prevent any hypotony when we do release these stitches with the laser. So essentially, this is what we did. And we use here we're actually titrating. So what we're doing is we're using a Lewicki infusion about 25-30 centimeters above the patient's head, which equates to roughly around 14 or 15. So we're seeing what the, with the resistance, how much resistance do we have with the tube? We can advance or detract the supramid. So if we advance the supramid, we get increased resistance. And if we detract the supramid, we get reduced resistance. So essentially, we're able to titrate the amount of flow that we're getting, because we don't want a high pressure in the beginning. We saw the field of vision, so we have very little leeway in terms of pressure control, especially with his intolerance to Diamox. So here we've actually coming to the end of the surgery, we've used fibrin glue in the area of the scleral patch graft and also the conjunctiva. You can see that we have the Lewicki infusion. So these are all the nuts and bolts, or crossing the T's, dotting the I's type of surgical technique that one can use in order to get maximum control out of the surgical procedure and also post-operatively. So what we did essentially was we suturized the initial stitch around about 2 weeks, and then another one around about 4 to 6 weeks. So we managed to get the pressure down, like I said, in a piecemeal fashion. And the patient has actually ended up with a good result. And over the last couple of years, he's only on one medication at this point. And he's also developed a cataract, which we did extract as well. So he has maintained his field of vision since then. So essentially, you know, the take-home points really are that when we are dealing with these type of complex cases where there is a chance of increased risk of complications or documented complications, we have to actually plan ahead when we're doing the surgical techniques, and also have careful planning post-operatively. So I'd like, thank you very much.
Thank you, Dr. Sohaib. Would you have preferred using a Ahmed glaucoma valve, or is a barreled a valve of your choice?
Yeah, you see, now this is the point. Now we wanted to have, see, if you remember, the pressure was 32. So, and that was on maximal medication. You know, he was taking some acetazolamide, but of course he was intolerant to that. So we are looking for, you know, this is, again, this goes into the planning phase where, you know, you have all of these tubes available to us. You know, we have now the pole tube available to us. At that particular point in time, we didn't have the pole tube, but I guess in hindsight, you know, if I went back to doing such a case now, I would be using a pole tube, which has a little bit more control. The lumen size of the tubing is a little bit less. But essentially, see, Ahmed tube has its role. There's no tube that is out there that is superior to the other. It very much depends on the type of case that you have. So, for example, I do use Ahmed tubes, but I use it mainly for example, cases where I need a, you know, an immediate pressure reduction. For example, in say rubiotic glaucoma, where the patient cannot really go back and forth, follow up maybe an issue, etc., etc. The problem we have with the Ahmed tube essentially is that we have the, of course, the hypertensive phase, and then you also have the higher chance of what we call encapsulation. So
yeah, your voice is breaking now. Well, I'm sorry we lost Dr. Sohaib at the point that he was about to make about AGV. But I guess what he really wanted to say was that the chances of a hypertensive phase or an encapsulated bleb are high with an Ahmed valve. So using a non-valve valve is a better way to go, especially it gives you the control that you want to have and have a phasic release of the sutures of the tube, and then, you know, open up the lumen in a phasic manner. So without much ado, we move on to our next speaker, Dr. Ali Al-Sheikh. Dr. Ali Al-Sheikh is a glaucoma specialist with international experience in Germany and Syria, and he's faculty at the Muscat Eye Laser Center, Oman. Over to you, Dr. Sheikh, for your case.
Yeah, thank you, Dr. Barol. I will share my screen. First of all, I want to thank for this kind invitation. Can you see my screen?
Yes, it's visible.
Super. Yeah. First of all, thank you for this kind invitation. My presentation, unexpected causes for AGV complication. No financial interest. This young patient, 26-year-old male. 26-year-old male came to the emergency complaining from pain at the left eye. IOP 20 at this eye on timolol. Right eye is prosthetic eye. When you see this is here, the picture for this patient is there is congestion. And when I see this picture, I thought this is clear, it's exposure tube. But if you look here, maybe you see this is here, all the AGV moved anteriorly at this, and this is my first expectation. I start an antibiotic and a short steroid, but the patient, for goodness sake, I have a report for my operation from many years. I asked to bring next year. Let's see, this is here the history for this patient. This patient has congenital glaucoma at both eyes in age of 6 months. Right eye had surgery at the age of 6 years with lost this eye and now on prosthetic eye. The history on the left eye, sclera buckling on April 2012 outside the country. All the other surgery in the same center outside the country. 2 months later, go back to the same center with the recurrent RD and BVR and did vitrectomy with silicone oil. 10 months later, go the same center with silicone oil removal and AGV implantation. Only 3.5 months later, go to the same center with the history of AGV tube extender fixated with fibrin glue, as mentioned in the report. I will start from the end. Why we use a tube extension? Usually, there is 2 indications for the more common complication. This is the retraction of the tube and exposure of the tube. And there is many techniques for tube extension. When this is the traditional is from the tube extender from the company, from the same Ahmed Glaucoma Valve company. And this is the tube extender. And this is slightly expensive. And there is another technique. This is less expensive as you to use angiocatheter 22 gauge or a Crowfold tube, or this is trimmed the tube from a second glaucoma drainage device as seen in this video, in courtesy from my dear colleague, Dr. Ahmed Mustafa Abdurrahman. See, this is use this part of the tube and make extension on this fixed on the patent. We test here. He tests the tube and find this is patent on the strong and can use for as a tube extender for as this case, make extension and can you insert inside the eye. This is the main technique for tube extension. Let me go back to my case. This is was my first expectation for the tube movement when I see the patient, but when I see the report, I said maybe this is all both is move anteriorly or otherwise the AGV blade go posteriorly and this is the tube extender move anteriorly. For that, I go to the surgery. Let me see what I found. This is here. I start with the surgery. I open. This is not moving. Maybe goes very slowly. Oh. Sorry for this. Now start the tube. See here, I start with the surgery. I open the conch and see this is what I found here. Look here, I open over the tube extender here. And this is the tube extender, all moved. This is only 3-4 millimeter from the limbus. But look here what I found. All the AGV blade over the lateral rectus is not in superior temporal. It is over the lateral rectus. And the surgeon make this is as L shape. See, this is here, the picture. And this is what I found. This is here what I found, the picture here for this. And this is here the situation as I'm seeing. This is here. Look, then the exact mechanism is the AGV blade move from superior temporal to the temporal side. And this is this is here short inside the eye. Or maybe this is why the surgeon go and make a tube extender. But I think the surgeon here found the AGV plate over the lateral rectus, and this single eye, he didn't need to touch the blade because over the lateral rectus or make this L shape the tube. But why is moved anteriorly? I make this animation as expected. This the movement of the lateral rectus make this movement of the tube extender inside the eye. And for that, I decided to cut this movement from the AGV blade to shift to the tube extender, because if the tube and the blade is working very well, I didn't like to remove that, and maybe I have big problem over the lateral rectus. And for that, I fixated the tube. See now, I fixated the tube and the tube extender very well with the Brolin suture. Look here, I tested, is patent working. And here I fixated, go back, this is more 7 millimeter back from the original position. And I fixated the blade. Here I found this is there, I didn't need any irregular surface. I made this is more smoothly. And after that, I put this is the tutoblast on fixating very well. Also two layer of tenon and conjunctiva, and close the wound. And this is here was what I had done. This is here fixated with many suture to stop any movement from the AGV blade to the tube extender, and to avoid any more complication in the future. And this is here the picture for the eye. 4 months later, I will be 12 millimeter mercury on timolol. Then see, this is here my first expectation. The second expectation this is the real reason, is the movement for the AGV blast superior temporal to the temporal side. And what was I found, this is the current situation. To take home message before that, only I want to see this case. This patient, young girl, come with this uncomfortable from the left eye. When I see anyone sees this is the tube slightly long at the right eye, but the patient comfortable, the tube not touch on the cornea or the lens, but the patient complain from the left eye. When I see, I thought there is a tube extended and touched with the iris and make iris atrophy, or maybe the surgeon trimmed the tube. But before I take the decision, I asked the patient to look to the superior temporal situation and see here. Always the AGV blade move anteriorly or make touch the tube with the iris, and this is make this eye uncomfortable for the patient. For that, please use tube extender in case of retraction of exposure of the tube, but please fix the tube extender and AGV blade very well. And thank you, and welcome to the Muscat International Conference in combination with the Miyako at the end of November this year. Thank you very much.
Thank you, Dr. Sheikh. It was really a wonderful case, and the way you have beautifully documented it with the schematic diagram made understanding very clear.
Yeah, welcome.
What's your experience with the different valves when it comes to silicone oil filled eyes? Would you choose one valve over another?
No, this is when I felt this is anyone felt. I prefer not to touch. Before, I prefer that is to remove, make first if it's capsulated to remove the capsule. But unfortunately, I found this is totally unacceptable. No result. The capsule will form again. If I want, I will implant another tube. If this is very rare. But I didn't prefer to at least to implant a new tube in the same position of the first tube.
If you have to do a tube implant for a patient with silicone oil filled glaucoma, which implant would you
silicone oil? Oh, you mean in silicone oil?
Yeah, an eye with a silicone oil induced glaucoma where the oil has been removed but the pressures are high. Which implant would you prefer?
This is in this situation, I will prefer to implant at least inferior temporal position, because superior, at least here in our patient, if the silicone eye removed very good, still there is particle of the emulsified silicone oil in the retina on the and the angle. For that, it's better to implant away from that, either to implant this is very long inside the anterior chamber, superior temporally, or better to implant inferior temporally.
Right, right. Fair enough. So we will get back to you with the audience questions at the end of this session. And with this, we move on to our next speaker, Dr. Elizabeth Cretera. She is an assistant professor in the Department of Ophthalmology and Visual Sciences at the University of New Mexico Health Sciences Center. We welcome Dr. Elizabeth.
Hello, thank you,
Cretera,
Dr. Perot.
Yeah, welcome.
Thank you. I'm going
Over to
to share my screen. Are you able to see that?
Yes, visible and audible as well.
Thanks very much. Thank you so much for the opportunity to speak today. I'm going to present an interesting case from our glaucoma clinic. This was a 52-year-old male who had severe primary open-angle glaucoma. He'd undergone a Barrevelt tube shunt in the left eye. He also had a known history of steroid response. He had chronic CME after cataract surgery. He'd already undergone a PPV with a membrane peel, actually in both eyes. Ophthalmic medication at the time of presentation included 4 antihypertensive agents, as well as non-steroidal and mild steroid. And then the patient also had some interesting complaints at the time of presentation, which included severe physical exhaustion, syncopal episodes, dysphagia, and sinus congestion. For the examination, we could see that the eye pressure in the left eye is elevated to 23. And in the past 2 years after the Barrevelt tube shunt, his pressure had been stable at 8 to 14 range in this eye. It was noted to have facial plethora on exam. And then his slit lamp exam, he had mild chemosis and hyperemia in both eyes. And in the left eye, we could see this Barrevelt position supratemporal, it had a normal blood morphology. And then the tube was noted, the ostium was patent in the anterior chamber. Otherwise, his exam was unchanged from prior exams, just for severe glaucoma. On that same visit, he did a visual field, which was showing worsening progression in the left eye, consistent perhaps with this elevated eye pressure. So question for our audience members, what would you do next? Would you consider discontinuing the fluorometholone drops? Would you do a systemic workup with chest imaging? Would you add notarsidil in the left eye, or would you do another non-valved shunt in the left eye, maybe with a micropulse laser? These were all things that could think about. We're going to make the case that you should do a systemic workup in this patient with chest imaging. And the reason is that we have to keep in mind his other complaints, which are not consistent with the tube failure, which his other choices would have made more sense. We know he's I'll go back one slide. He has a steroid responder, so you could consider stopping a steroid. Notarsidil could be added to his other classes of medication. And a second tube shunt might be considered if you thought this was a tube failure. But taking in mind his other complaints of syncope, sinus congestion, dysphagia, and then this facial plethora, along with that elevated IOP and chemosis, we should think about a venous obstruction, which is not something that we think about very often. Elevated episcleral venous pressure, we know can elevate the IOP. And so we have to consider that in this case. Just a few words about the EVP. So we remember from the Goldman equation that the intraocular pressures calculated by this equation. So F will be the aqueous production over the C, which is the aqueous outflow, and that is combined with the EVP. So EVP we know is determined by vascular tone and gravity. It is independent of IOP as well as aqueous production. Exam findings that we see in elevated IOP include dilated tortuous episcleral veins, chemosis, and blood in Schlemm's canal. And you can see this picture. This is from the iWiki. Differential diagnosis is pretty broad, so you should think about anything that can cause congestion of those episcleral veins, such as orbital varix, Sturge-Weber as a classic example, direct and indirect carotid cavernous fistula, cavernous sinus, syndrome and superior vena cava syndrome. And then there are also reports of elevated EVP transiently with specific behaviors, such as playing the high resistance wind instrument, wearing a tight necktie, or doing postural inversion, where you invert to gravity. So in this particular patient, his findings kind of more consistent with a superior vena cava syndrome. And superior vena cava syndrome classically will present with the plethora of the face, and this is due to the distension of the jugular vein because of compression of that venous return to the heart at the superior vena cava. As far as the ocular findings, you can have orbital congestion, proptosis, as well as elevated intraocular pressure that is with recumbent positioning. The mechanism of elevated intraocular pressure is related to the retrograde congestion from the jugular vein back through the ophthalmic veins and to these episcleral veins. And the differential for this specific cause of elevated EVP will include neoplasm, aortic aneurysm, and then central venous stasis that could be due to indwelling catheters or stents. And so in this patient, he was already talking to his primary care doctor about his complaints, and they were the ones that initiated the CT scan. And this shows in the yellow, you can see is actually a large mediastinal mass, and that is encasing the great vessels of the aortic arch, as well as that superior vena cava. And then the white arrow is pointing to the right jugular vein, which appears distended, and then the left jugular vein in blue is actually appears stenotic in this image. And then the inset image down here is actually showing after 6 months after his treatment course of chemotherapy and radiation, and then we can see that reduction in the size of that mediastinal mass. And so, as I already mentioned, the patient had a CT scan showing this large mediastinal mass with stenosis of the left more than right jugular vein. He underwent a cerebroclavicular lymph node biopsy, which was consistent with a diffuse large B-cell lymphoma. The patient underwent chemotherapy and radiation. And after that, his intraocular pressure was better controlled. It returned to that range that it had been after the Barreveld tube shunt. And so I would like to thank my collaborators on this case, as well as our patient who agreed to have this case presented. And this case was published if you're interested in referencing it for teaching purposes. But we thought it's a very important case because we have an opportunity not only to save sight, but also to diagnose or help to diagnose a disease that can actually kill the patient as well. Thanks very much for your attention.
Thank you, Dr. Elizabeth. It was really beautifully documented, and it just made us reconsider the fact that we have to go beyond intraocular pressures and findings of the imaging. We are often so obsessed with the pressure, the disc, and the imaging findings that we overlook a lot of systemic features. What's your experience otherwise in patients with Sturge-Weber syndrome, those who have elevated pressure, other than the cause that you just showed to us?
Yeah, so Sturge-Weber is certainly, I think of it with congenital glaucoma or pediatric glaucoma as a common cause of elevated EVP. I don't actually treat too many pediatric cases in my practice right now. But in training, I certainly saw that as a cause. I think it's quite challenging to treat, actually.
Yeah. So I've just had a few patients of Sturge-Weber, and those adolescent patients, they are very refractory to treatment. They might, whatever modality you give to them, that'll work for a year or two. And again, you are presented with a resurgence of the pressure, and it's really difficult to control patients with elevated episcleral venous pressures. So we'll take up the questions at the end of the session, and I would request you to please hang on. And with this, we move to our next speaker, Dr. Ahmed Mustafa, who is the founder and president of the Egyptian Society for Continuous Ophthalmic Education. He's professor of ophthalmology at Cairo University, and he's operating in Libya today and is joining us despite poor connectivity. And I'm really thankful to you for sparing your time despite a busy schedule. So over
Thank
to
you,
you.
Parul.
Hearing from you. Yes.
It's my pleasure. It's my pleasure. Do you hear me, Parul, in the first place? You hear me?
Yes, absolutely. I do.
Yeah, good. So let me share the screen. Okay. Okay, good. My case today is just navigating a case with the multiple difficulties that we can meet in everyday practice. Just a male, 36 years old with previous glaucoma operation. The vision is 360 and the pressure is 30 on full treatment. The disc is not bad, actually 0.5. And this is the anterior segment imaging. You can see the patient had a valve, and the valve actually is too much in relation to the cornea, causing a lot of troubles and peaking of the pupil. And besides that, the patient is having posterior cortical cataract. And again, the pressure is not controlled. And another problem that the tube is exposed, so that it seems that the patient is having still glaucoma and ocular surface problem with exposure of the tube and posterior cortical cataract. The patient is young and is definitely not satisfied with all of those. So I just consulted the patient for what shall we do, and then the rest of the conjunctiva was good, and this was the kind of a gift for these patients that we still have a place for another glaucoma operation. And now this is the operation that I planned with the patient to go through. This is first the inferior corneal traction suture, and now you can see the posterior cortical cataract is very obvious, and this is the quadrant where the valve is. So I'm now working on the other quadrant. Then I injected diluted the mitomycin solution, and the concentration is 0.04 milligram. I injected 0.1 milli. And then I'm planning to go for glaucoma operation in the other quadrant, and then preparing the first flap. Yeah, the eye is a bit congested because of the multiple operations, but again, it wasn't a big problem. Dissection is carried forward to the periphery of the cornea. And actually, my plan here was to do a deep sclerectomy because I think the patient's conjunctiva is healthy and still can benefit from a regular operation. So I prepared the first flap, and then I'm preparing for removal of the cataract. The pupil wasn't enough dilated, and I need to have better visualization. You know, I want to avoid as much as trouble in this patient. So after placing the incisions, I want to go for a kind of assisting this pupil to be more dilated. And I think iris hooks could accomplish this mission, so that I'm placing hooks. This is the second hook, and the view is much better. And then this is the third hook. Then at that time, and I think the valve area is working like the fourth hook, so that I don't need a fourth hook at that time. Cataract wasn't a problem. And then the IOL was placed in the back. Then I'm thinking of relieving the iris tissue that's incarcerated at the site of the tube. Because the pupil is a bit irregular, I want to get more regular pupil. That wasn't possible, actually. So I thought of cutting the pillars of the iris. I want to have a kind of regular pupil, so to minimize the aberrations, you know, that the quality of the vision is important as well, like the visual acuity. So again, I'm able now to repair the pupil and to get a better appearing pupil, actually. And I left some of the residual iris tissue that wasn't possible to remove the whole iris from the surgical site. But again, after placing 2 sutures, I think the pupil is better. And then I'll go back to the deep sclerectomy area to complete the deep sclerectomy, because I believe that this valve, it is not possible to make use of this valve anyway. And then the percolation is good, and the eyes is still filled with healing, so it's okay. Now with the deep sclerotomy, one of the standard operations, the trabecular meshwork started to percolate, and this is the excised D flap. Removal more of the peripheral cornea to give more filtering area. And then afterwards, I tend to place a suture, which is published, thanks God, under my name, which is Ahmed Suture, under the scleral flap, with the aim of placing the proximal limb of the suture over the trabecular meshwork in case I want to do goniopuncture and assist my operation. And at the same time, it acts like a spacer, an economical spacer. The knot is buried, and then I'll reposit the superficial flap. And you can see I'm just pointing out that the suture is overlying the trabecular meshwork. The flap here was closed with some sutures because of the filtration. It was too much, actually. And then going back to the third problem, which is the tube here, so that I'm dissecting the conjunctiva around the tube, and I'm quite sure that the valve is not doing anything good. It's only causing some harm to the patient by irritating the eye all the time by the exposed tube. And it might be a conduit for intraocular infection, so that I'm now getting the tube out of the eye and thinking that this will protect the cornea. Again, no more further damage to the cornea as happening here. Removal of the body of the valve would be a big problem, and actually I don't need it, so that I left the body itself of the valve. It would be a hell of operation to go after this, so I left the body, and then I'm closing the defect of the tube by 10-0 nylon sutures, a couple of sutures. Usually the opening is a kind of circular one. It needs to be properly closed to avoid filtration through this side. And then after burying the knots, and then I thought, why not to make use of the deep flap of the patient for adding extra support to the surgical side, so that this is the deep sclerectomy flap that was excised from this area. And then I went for removal of the viscoelastic, and the superficial flap was, sutured, that of deep sclerectomy. So that's almost the conclusion. The surgery, deep sclerectomy here, and the flap was transferred to support another area after removal of the valve. And I did a kind of release to the conjunctiva to avoid too much traction, because I'm just leaving the body and I'm covering the cornea as much as possible with the conjunctiva. Now, this is the postoperative picture. The eye is relatively quiet. The pupil, yeah, it's not perfect, but I was satisfied with this. And we can see that this is the old valve area, and this is the new deep sclerectomy area. And actually, the operation, it's here, I'm saying 6 months, it's now even. We're coming to 1 year, and the vision is really good, 6/9, and the pressure is 9. His deep sclerectomy is really working very well. He is on low therapy. He comes every now and then for a check. And this is the valve that I actually left, so it's not working, just surrounded by scarring. And this is the deep sclerectomy area. Again, it's working. So I think in those cases where you have a lot of difficulties, you need to just sit with yourself. You might consult your colleagues to plan ahead, because you are having multiple difficulty how to solve one after the other, instead of managing the patient had like uncontrolled glaucoma, exposed tube, and catheter. So how to navigate between those difficulties? And actually, I was satisfied with the outcome at the end. And thank you very, very much.
You have made the very complicated surgery look so easy. The outcome is just so beautiful, despite all the interventions that you carried out. So it's really important to address and give respect to each tissue as if it was the physiological state of eye. And repairing the iris was equally important as just controlling the intraocular pressures. Any comments from our other esteemed speakers as regards this case? Would you have done anything differently?
You know that Parul, correcting the pupil with a kind of just minimizing the aberration, so that one of my colleagues have said that in this operation it was just a complicated cataract operation, glaucoma operation, refractive surgery. It's a mix of everything actually. So that I'm quite sure that the colleagues might have a different plan to come up with something that's new, because the situation is very extraordinary.
Yeah, many times. Yeah, please.
Sorry. Why Dr. Ahmed not remove the tube from beginning on testing the tube if this is working? Maybe that's the AGV plate already still working on now only closed with the tissue. For that, maybe can we stay safe if the tube is still working? Can we implant in another place and correct the position or make extension on the implanted?
Thank you, Ali. You know that the problem that the tube was exposed, so that I have to correct this as well, and I have correct the overlying conjunctiva. Then I have to take the tube to another path, which we could do actually. But I think the problem here that I found that the patient's actually optic nerve was really very good, and I thought, why in the beginning to do a valve for a patient with a kind of healthy optic nerve, and he can benefit from regular operation. But again, the option of getting the tube out and then adding something to lengthen the tube and then to change the path of the tube, this could be another option, of course. Yes, I totally agree with you that there could be another option. That's why when you plan ahead, you can come up with different ideas that could solve that patient. But again, I was not happy at all with the appearance of the response of the cornea to the implant.
For that, maybe this is for the audience. Plan ahead here is more important. It's not to implant AGV or any tube for this case, because it's still patient faking, young patient, and still the conj is very good.
Yes, yeah, you know that I just kept thinking, why this patient received a complicated valve? Because you know he could benefit from something which is less invasive. Yes, I totally agree with you.
Dr. Ahmed, go ahead.
أهلا دكتور باسل. Yasmin, hello.
I'm
sorry for the...
We have time. Yeah, we still have time for discussion at the end. So Dr. Bessie, please go ahead.
Dr. Ahmed, my question was, in this case, you used the deep sclera, which is cut from the sclerotomy, and you covered the side of the tube. If you don't have this deep sclera, will you use sclera graft patch for covering the side of the tube, which you remove it from, or you can cover just with the conjunctiva after suturing the entrance by sutures, the nylon sutures?
Dr. Besser, thank you very much for this nice question. I was satisfied with the closure of the tube with the suture, but at the end of the day, you know that the entry is a bit rounded. So that if I don't have enough sclera, I may think of adding something, but also if I'm satisfied with the closure with the sutures, I would just drag the conjunctiva and cover. But in this case, I was just happy that I have something at my hand which I can make use of it. Yes, yes. Yes.
Do we have to move on? I can postpone the question for the end. I wanted to congratulate you, Dr. Ahmed, for a wonderful case, a very challenging case that you managed so beautifully, as usual. My quick question is on the effect of cataract surgery on deep sclerectomy. Is it similar to when we think of combining trabeculectomy, for instance, with phaco, or is it because it doesn't rely on the conjunctiva? You have a lower threshold for operating for cataract, at least in your hands. Do you withhold from combining cataract surgery with non-penetrating glaucoma surgery, as you probably do for combining it with trabs?
So let me just rephrase the question to make sure that I understand this carefully. That you are asking about combining phaco with the deep sclerectomy as
yes.
the one
Do you think
operation?
It has some adverse effect on the IOP control, like it does for trabeculectomy when combined with phaco?
You know that Actually, when you combine both, you don't know how much the magnitude of IOP reduction by the cataract itself. So the combination is always beneficial. And might be some few patients could use like one medication, but actually it is just from my observation, combining phaco-deep sclerectomy in open angle glaucoma is actually, for me, it's a much better option than combining with trabeculectomy, because I have seen that trabeculectomies, they usually do scar. But I think the results are better, at least in my hands, when I combine phaco-deep sclerectomy.
Right.
But another point, Yasmina, that there is an incidence of, the complication when you go just for TRAP. I think like 40% will develop cataract like in a couple of years, so that the incidence of cataract is high. I don't see this incidence is the same in deep sclerectomy, which gives another advantage for this surgery.
Very good point. Thank you.
Thank you so very much. And in the interest of time, we move on to our next speaker, Dr. Basil Al-Fawri. Dr. Al-Fawri is a renowned international surgeon with interest both in adult and pediatric glaucoma, and he's currently working in Al Garhoud Hospital in Dubai and also operates in Sharjah. So over to you, Dr. Fawri.
Thank you very much. I will share my screen. Okay, indeed, I will go quickly with my presentation. First of all, thank you very much for the invitation for this session. Indeed, I will share with you this case. One patient, 43 years old, male, Asian, referred to me with a complaint of left eye pain with blurry vision. Started 1 week ago. This patient treated by one of my colleagues with maximum medications, but the pressure is still high in his left eye, and so he referred him to me for surgery indeed. So when I examined the patient, I found the left eye vision 0.7 with the cornea mild edema, pupil mid-dilated with poor reaction. The pressure was 43 in the left eye with full anti-glaucoma medication. The right eye was normal in pressure and in vision. When I examined the patient carefully, I noticed that, yes, this eye pressure is so high, pupil dilated, poor reacted, but on slit lamp examination, I noted that the anterior chamber deep in the center, but in the periphery, as seen here, it's shallow. It's notable that it's not usual to see a shallow anterior chamber in the periphery with deep anterior chamber in the center. So this raised a mark for me that the diagnosis should be put carefully before going for the surgery. So I did a gonioscopy for the patient, and I found the angle closed, but it's a positional. Yani when I apply indentation, the angle opened a little bit. So all my plan changed from surgery to another thing, because in this case, as seen here in the OCT also, the right eye and the left eye have the same criteria. I mean, narrow angle, a positional angle in both eyes. So I here put the diagnosis as a plateau iris, and we have, just to go a quick review over plateau iris. It's often seen in young patients, equally between men and women. It was relatively common, 6 to 20% of eyes with angle closure. This can occur spontaneously or after dilation by medication. If not diagnosed and treated properly, a pass can happen and closure angle, permanent closure angle can happen. We have to pay attention to differentiate between plateau iris configuration and the plateau iris syndrome. So just to put in mind that to say this case is a plateau iris syndrome after putting the plateau iris configuration, deep anterior chamber and narrow angle. We have to do a peripheral iridotomy. If the angle is still closed and the pressure is still high, that means it's now a plateau iris syndrome. So that's what I did for the patient first. I did a laser peripheral iridotomy, but it is the patient peripheral iridotomy by OCT, anterior segment OCT, but the pressure still high. So what I have to do later, after 2 days after peripheral iridotomy, the pressure is still 31 with maximum medication. So I did for the patient iridoplasty. I did it for both eyes. I prepared the patient with pilocarpine, 1 to 2%. Then with iridotomy contact lens, I applied with 500 micron spot size, power 200 millijoule and the duration 0.5 second. After the procedure, I put the patient on primidine immediately and steroid for 5 days. Days post the procedure, now the pressure become normal. It's 11 in the right eye, 13 in the left eye, but with exolamol. And the cornea became clear, the anterior chamber deep in the center, and become more deeper in the periphery. And here we can see the photos of the patient after iridoplasty. We can see here the scars of the argon laser in the periphery of the iris for the left eye. This is the eye before the iridoplasty in the right and after the iridoplasty in the left. We can see the change of the size of the pupil before and after. And here by OCT, the angle of the left eye in the nasal side and temporal side. And here is the angle after the iridoplasty. It's much, much better. Here we can compare the angle of the left eye before iridoplasty and after iridoplasty. And the same, which we can see for the right eye before and after iridoplasty. The angle much, much better. So in this case, we can say that the proper diagnosis will help us to choose the proper treatment for the patient. And instead of doing surgery for this patient to control the pressure, by iridoplasty, argon laser iridoplasty, we overcome the attack of the eye, the high eye pressure, and to put the patient in the safe side. And at the end, we can see, if something isn't working, don't try harder or do more, do something different. Thank you very much for your attention.
Thank you so much, Dr. Alpauri. And without much ado, we'll go on to our next speaker because we are running short of time. Last but not the least, we have the very wonderful Dr. Vanitha Pathak. She is a surgeon who is practicing in the southern part of India and Center for Sight, Hyderabad. Her forte is not just mixed, but otherwise refractory glaucoma surgeries. And over to you, Dr. Pathak. Thank you for joining us today.
Thank you very much. Dr. Basil, can you unshare your slides, please? Thank you. Thank you, Parul, and thank you, Dr. Amrit, for this invitation once again. It was wonderful being part of the same meeting a couple of years ago. Today I'm going to talk about narrow angles, shallow AC, and my job has been made very easy by Dr. Basil. I'm going to talk about a patient who presented to me a while ago, just after the first wave of COVID. I don't have any relevant financial disclosure. So this is a 56-year-old female who was complaining of left-sided headache and blurred vision for 4 months. In her past history, she's already had a laser peripheral iridotomy 22 years ago. And following that, I don't know, someone guided her to have LASIK for hypermetropia, and this was done 11 years ago. And at that time, the CCT was recorded as 480. Before she was referred to me, an LPI, laser peripheral iridotomy, was done once again. She didn't have any significant systemic, family, or ocular history. She wasn't on any medication at the time she came to me. So when she came to me, she did have 20/20 vision, but as you can see with the hypermetropic correction, and she had 3 patent PIs. AC was extremely shallow, and a pupil, though not on pilocarpine, were very, very small, almost like senile meiosis, although she hadn't reached that stage yet. And both eyes, she had very early cataract, and her pressures were 20 and 18. As you can see, there are 3 PIs on both sides that were patent, but extremely, extremely shallow AC. And of course, on gonioscopy, when I did it, it was a post PI occludable in both eyes. I wasn't sure whether any pus were present because the indentation was quite difficult, and undilated disc examination was more or less normal. I did want to move on to a UBM, also wanted to do an ASOCT in biometry, but unfortunately, she didn't want it on the same day. And when she did come back, she was complaining of pain during the UBM itself, which had to then be abandoned after the axial scans, and her IOP at that moment was recorded as 39 and 17. She was given pilocarpine stat, and 2 hours later, her pressure came down in the right eye. So this is her UBM. Not the best, sorry, but you can see features of plateau iris syndrome. You can see that the ciliary bodies are all anteriorly placed, as well as no iridociliary sulcus. And you, together with it, you can see that there's very significant lens vault in both eyes. Biometry, very small eyes, very shallow AC, as we all saw clinically too, and lens thickness 5 millimeters at her age, and significant lens vault. I'd like to do lens vault measurements on ASOCT. Unfortunately, I had to do it on the UBM itself. So of course she is a post LPI occludable, and she has both plateau iris syndrome as well as increased lens vault, contributing to her angle closure. So in view of the recurrent angle closure, a sequential cataract extraction was recommended. She was counseled for a argon laser peripheral iridoroplasty as well, but because she's had 3 lasers in the past, she decided that lasers are not going to help her anymore. Anyway, so she was advised in the interim, before she underwent surgery, pilocarpine to be discontinued a day before surgery. And when surgery was planned, no pre-op dilatation, we discussed that we will do it on the table, and a pre-op mannitol was also given. Of course, given that she had LASIK, there were lots of issues with IOL calculation, which is beyond the remit of this particular talk. On the day of surgery, again, she complained of right-sided headache of 6 hours duration, and her IOP was recorded as 32 and 17. So she was given mannitol once again, and pressures of obviously preoperatively were measured under adequate antibiotic prophylaxis. On the table, she was dilated with intracameral, what we call phenocane plus, but basically this is a concoction of lidocaine as well as tropicamide and phenylephrine. And intraop mannitol had to be repeated, as AC was still shallow and was not not deepening even after cataract was removed and IOL was placed. And even with sodium hyaluronate, it wasn't deep. So with a recent, very recent, and I've published this, management of a patient post cataract surgery with aqueous misdirection, I approached this patient in the following way. So here we are. This is a brief surgery of that patient. She wasn't dilated prior. Phenocaine is being used here. You can see it instantaneously dilated. A very careful rhexis was done because of increased lens vault. You can always run out. And a little bit smaller than what one would like, but that was acceptable. Think, you know, when phaco was started, you can see very, very thick layer of cortex, but other than that, it was absolutely uneventful. However, the AC remained shallow, even with sodium hyaluronate injection. So mannitol was repeated intraoperatively, and it still did not deepen the AC. So after placement of the IOL in the bag, what I did was use an anterior retractor to enlarge a pre-existing peripheral iridotomy, and then used an MVR blade for a vertical entry, just overlying it, inserted a retractor vertically down to do zoniolectomy, and then turned the retractor to face anteriorly to do a complete anterior hyaloidovitrectomy, all within anterior retractor. And I like to do a primary posterior capsulectomy because that tells me that the anterior hyaloidectomy is complete. And then after that, she formed even with an air bubble. So this actually is a schematic of the same that I did. I enlarged her PI. I went through her through a corneal incision. I inserted a retractor. Anteriorly, and then come up right up to the lens and do a primary posterior capsulectomy. And you can see a postoperative picture of that primary posterior capsulectomy. This I have done now through various incisions, corneal, ostial, pars plana, and I have reported it. This is actually a very satisfying procedure that helps to resolve aqueous misdirection, should it happen either intraoperatively or postoperatively. So she did very well postoperatively. You know, I don't need to go through it, but you can see how deep she became, and you can see her primary posterior capsulectomy as through the retroelimination. Left eye surgery was still pending at the time. Believe it or not, she had recurrent attacks in that eye too, severe headaches 4 days prior to the scheduled surgery. She was given intensive pilocarpine and controlled with oral carbonic anhydrase inhibitor. She was still 26. She underwent a very similar surgery on day 1. Here she did slightly better. As you can see, deep AC, and you can see her primary posterior capsulectomy in the left eye as well. And just as a reminder, you can see how shallow she was before. So now I have a follow-up of more than 2.5 years. She is best corrected 6.6 N6 with a very deep AC, controlled IOP. And just to summarize, I'd like to tell you that this was a case of plateau iris syndrome with increased lens vault, and all this diagnosed post PI. She was getting recurrent acute attacks, and therefore she underwent both eyes lens extraction with iridozonular hyaloidovitrectomy, along with a primary posterior capsulectomy. She had unaided 20/30 N8 vision, which I think was way better than what her LASIK managed to achieve. Nonetheless, what was most important to me was that she had deep AC and controlled IOP after surgery. So the key points here is that every patient who is undergoing YAG-PI really needs a post-LPI gonioscopy. Once relative pupillary block element is eliminated, doing another LPI really does not help. And under these circumstances, UBM is the investigation of choice. And you can use pilocarpine because that is what breaks the attack. So the double trouble that I had in this shallow AC was not only the recurrent attacks, acute attacks that I was getting, but also the fact that she had developed aqueous misdirection intraoperatively. Of course, appropriate measures should be taken based on experience and confidence. And in my personal opinion, LASIK should be avoided in these kind of glaucomatous size. Thank you very much for patient listening.
Thank you, Dr. Vanita, and thank you very much for such enlightening cases and a wide variety of cases. In the interest of time, we will not be able to take any questions because the next session is awaiting and it's in the same hall. I would also like to thank my co-moderator, Dr. Yasmin Al-Said. She is a professor at the Cairo University, and due to some technical glitch, I couldn't introduce her earlier as her video wasn't streaming. Thank you, everyone. Thank you, Dr. Elizabeth. Thank you, Dr. Basel, and for sparing your time and joining us today evening. Thank you, Dr. Ali Al-Sheikh. Thank you. Have a wonderful day.
Pleasure. Thank you very, very much. See you. Have a great day. Thank you. Bye-bye.
Thank you very much. Thank you very much.
Bye.
Mute, Habibi, unmute. Okay, done. It was in my mind to ask Dr. Vanita, but she left, Muhammad. Dr. Muhammad. Assalamu alaikum. Dr. Muhammad, you are mute. Yeah. Thanks God that Dr. Muhammad.
هلا ومرحبا كيف حالك؟ السلام عليكم.
أسأل عنك وعليكم السلام. Hello, Osama.
Can I start the video because it doesn't have on. Yes, go ahead, please.
There's no video connection. Need to reopen from your side, Mohammed.
I will start. Let me share. Osama, let me share. Osama.
Yeah, please, yeah, go ahead.
Let me share, and I will. 1 minute. I will share, and I will open my video. So, in a way that we can see whether the video will work or not.
I'm sure it will work.
Why are in this way? No, sorry. Okay, so this is the video. It's working now.
Specifically designed to target a source of.
It's fine?
Yeah, it's fine.
Okay, done. That's all. So I will go out now. Stop sharing.
Keep sharing in the video.
Okay, Dr. Osama, the microphone's for you.
Mohammed, we start?
We should start earlier.
Yes, you can start, yeah. You can start as soon as possible.
Live now?
Yeah.
It's really a pleasure to moderate this session, and thank you, QOIC team and Dr. Mohammed and Novartis for this symposium, which basically it's a pleasure to have Dr. Safwan Bayati, colleagues and friends, eye consultant, and he will going to talk about the dry eye disease and unmet needs and management, and I'm sure we're going to learn a lot from him about this session. It's all yours, Dr. Safwan.
Great, thanks, Dr. Osama. I just need to thank Novartis and MIOM, and on top of them, Dr. Mohammed Al-Amri, to give me this opportunity to present such an important subject related to the dry eye. Now, we are all know that the dry eye is a complicated subject. It's a complicated syndromes that we are facing now daily, and I think me and my colleague Dr. Osama, we are contacting daily for how we improve our management for those patients, especially as an assessment for pre-refractive surgery and post-refractive surgery, or in other surgery, cataract and so on. And why we are facing this problem? Because the new lifestyle that it makes them using the phone and using the computer and all devices, more frequently and they are not able to use it in a proper way, then we will end up with what we call a vicious circle that we will see it. And here the rule of the subject that we will talk about it in this presentation is how to use this new type of anti-inflammatory, that's the Zedra, and this use it should be on a proper way. Now, if you will go epidemiologically, the reported prevalence of dry eye disease range from 5 to 50%, whereas the reports prevalence of MGD varies widely from 3.5% to nearly 70%. So MGD has been reported to contribute to 60% of all dry eye disease. An additional 20% of cases of dry eye disease are caused by aqueous deficiency. So we can imagine that aqueous deficiency start to be only at 20% of all what we are talking about. So mainly it's an MGD and the deficiency of the mucin through death of the goblet cell. Now, this means that we need to return back again to the vicious circle. And if we are looking to the vicious circle, which is the key mechanism of the dry eye disease, this vicious circle throughout, it's creating an inflammation. And this inflammation, by its action to create and release the cytokine release from the MMP activation, and then apoptosis of the main cell that secrete the mucin, which is the goblet cell. And then we will end up with deficient and instability of the tear on the cornea. And that's one of the important issues that here, because we need to break this vicious circle by an anti-inflammation. So treating this patient with artificial tear is not enough anymore, because here we have a deficiency of the main cells that can secrete the mucin. So that's what we call instability of the tear. So instability of the tear film, we need to test it. We need to see it not only by testing the deficiency of the tear by Schirmer test. So Schirmer test here is not the guidelines, because Schirmer test here, it might be normal, but the stability of the tear on the cornea, it's not normal. That's why I'm saying that we need to understand what we are concerned in this vicious circle. Now, if we will go to what we said, that additional effect in this vicious circle that lead to MGD, and then that will create a small circle in the vicious circle that add to the instability of the tear on the cornea by deficiency of the mucin. It adds the deficiency of the meibomian gland secretion, and then we will increase the evaporation. Then we will have the effect that will affect definitely the tear film by reducing the tear amount because of the evaporation. All these, it's coming together as a consequences of the inflammation. Now, if we will go to what we call the immune synapse that promotes the inflammation, and as we know that LFA part on the T cell bind to ICAM1 on the antigen presenting cells, forming the immune synapse. That's what we concerned that. So the immune synapse is a combination of LFA1 to that on T cell to ICAM1 on the antigen presenting cells, which result in migration, proliferation, survival, and mutation of the T cell through increased expression of ICAM1 to bind more LFA1, and T cell recruitment to ocular surface, and T cell migration into ocular surface, T cell activation, release of pro-inflammatory cytokines, and T cell binding of antigen presenting cells. Now, what the liftigras is doing is that it has not only a preventive, no, it will break the existing binding. So it's it's designed to block the LFA1 and to prevent the T cell from binding to ICAM1 on the antigen presenting cell. Leftigrast demonstrates significant, if you excuse me, just to remove that side, then I will return back. Leftigrast demonstrates significant and dose-dependent blocking of immune synapse formation, disruption of existing immune synapse, and interruption of downstream T cell function. So Leftigrast inhibit T cell recruitment and activation and reduce pro-inflammatory cytokines release. And that shows clearly that how the LFA1 that on the T cell, when it's bind to ICAM1 on the antigen presenting cells, it activates the T cell and it releases the cytokines, and that creation of the inflammation, which create apoptosis of the goblet cells and create the inflammation in the meibomian gland. Now, this movie will show exactly what I was talking about. So let us hear and let us see.
Specifically designed to target a source of inflammation in dry eye disease, it is thought that Xiidra targets both inactive and active T cells, thereby helping to disrupt the continuing cycle of inflammation. Xiidra blocks LFA1 on inactive T cells from binding with overexpressed ICAM1 on the ocular surface and may prevent formation of a specialized cell junction between specific immune cells, which may inhibit T cell activation. Xiidra is thought to inhibit migration of activated T cells to the ocular surface and may reduce cytokine release. Xiidra is a first-in-class prescription therapy thought to target both active and inactive T cells in order to interrupt the chronic cycle of inflammation.
So, when how to or why we are choosing Xiidra, FDA approved prescription eye drops to treat both the sign and symptoms of dry eye disease. So it's thereby improvement from baseline in a sign of a dry eye disease. Nearly 8 out of 10 patients didn't use artificial tear at day 90 after the treatment, not during the treatment, because this is an important issue, that during treatment we need the artificial tear, and that artificial tear, the type of the artificial tear, it will depend on the sign of the patient that have. Xiidra was well tolerated in a clinical trial in the first 2 weeks, which is the most symptomatic part of the trial, because patients, they are coming complaining, and that complaint is redness, stinging sensation, and that complaint, it need a treatment, and that treatment definitely will start with artificial tear that's compatible with the condition of the patient. Novel and unique therapy with the onset of action as early as 2 weeks. Now, 2 weeks, we found that within the treatment, within that period, the symptomatic relief and symptomatic relief definitely with the sign improvement of the breakup time. Now, if we will go to sign, most dry eye testing methods, such as that tear breakup time, and I put it as a first because actually we need it more than Schirmer test, but 100% Schirmer test is a part of the testing. Corneal staining, tear osmolarity, and diagnostic imaging, like, for example, meibomiography and interferometry. But even if we don't have the meibomiography, which is now available in most of the tomography, we can depend on the breakup time. However, the presence of corneal and or conjunctival staining that definitely indicate of inflammation and directly correlate to the level of inflammatory mediator MMP9. In spite of that, the MMP9 is not specific to the dry eye. It shows non-specific inflammation in the eye. So we cannot depend on it as a guideline for the treatment, but we can depend on it when the level of the MMP9 reduced. Tear film osmolarity of 316 milliosmol, it's considered as a high osmolarity. And when that happens, definitely because of the reduction of the tear and instability of the tear. And that osmolarity is very toxic to the goblet cell. So when we consider anything above 316 is very toxic to the goblet cell, so it means that we will keep losing the goblet cells as this osmolarity is high. And the one that can correct, we can correct it by returning back the stability, by returning back the reducing the inflammation, and gives the chance to goblet cell to grow up, but during which time that's required. For that, we need to provide the patient with a proper tearful, artificial tear that can contribute to or compensate to the mucin deficiency. And that's what I was talking about, that MMP9, it's not specific, it's an inflammatory marker produced by stressed epithelial cells that is consistently elevate in the tear of a patient with a dry eye, definitely, but it's not specific. That's right, it's very easy to test, but still we need to test it because we need to follow the patient according to the reduction of the MMP9. But if it is not there, it's not affect our guidelines for the treatment. Now, if we will go to CDAR's guidelines for the treatment, we will see that the liftigrast present in all the three kind of the deficiency. That's what we are talking about, the tear film deficiency and the blepharitis, MGD deficiency of meibomian gland, and the goblet cell deficiency, mucin, what we call mucin deficiency. Definitely, it's not in the third part because these part is not including only the medication. It includes other issues that other than the liftigrast. Now, personally, when I need to use the Xiidra, now 50 patients of 9 months, the tear breakup time, it should be less than 10 seconds. Schirmer test less than 5 millimeter, corneal staining, and MMP9 positive. That's guideline where I'm following it. So if my breakup time is less than 10 seconds, that I will start directly. So one of them will be positive, I will start. But in MMP9, if it is positive and the breakup time is more than 10, this is very rare because someone will ask me, so okay, if we did an MMP9 and it was positive, but the breakup time is more than 10 seconds, it's very rare. This means that there is an inflammation which is non-specific, but it's not affecting the mucin secretion. But I didn't see such a patient. Most of them, they have less than 10 seconds, and most of them, their Schirmer test is affected because the meibomian gland function will be affected. But yes, we can have a breakup time less than 10 seconds while the Schirmer test is normal. The answer is yes, because the stability of the tear on the cornea is not good. So that's why patients suffer. But the amount of the tear till now is not affected. Yes, we can find a patient in this level. Now, what's the proper tear film that I should use? Now, when we will go back to the breakup time less than 10 seconds, here we need a tear that having a material or artificial tear that having material mimic to the natural tear. And all of us, we know that our tear having the lipid, which is the outer layer, and aqueous component, which is the intermediate layer, and the mucin that is contact to the corneal epithelium, changing it from the hydrophobic to hydrophilic. So here, the artificial tear should contain the three, because in such a patient that has, breakup time less than 10 seconds, and we are adding only hyaluronic acid, which is the fluid part, here the patient, the symptoms of the patient will not improve, because this patient is not only in need for aqueous, he is in need for a part of the artificial tear that protects the tear from evaporation. So their artificial tear should include the lipid, and it should include either carbomer or methylcellulose in a way that it can make that tear stable on the cornea, or in other words, it can change the hydrophobic to hydrophilic part of the epithelium. So the tear will stay on the cornea, like for example, when we are using carbomer, it will stay on the surface of the cornea more than 3 hours. So the tear should contain all these in a way that we can improve the symptoms of the patient, addition to the use of the Xiidra. Now, personally, what I'm doing, I'm using the tear that having these component hyaluronic acid in 0.24, and in my opinion, humble opinion, that I will not use concentration over more than 0.24. And carbomer, glycerol, carbomer or methylcellulose, glycerol, medchine triglyceride. So this content is there in our in some of these artificial tear, because when patients coming suffering that, well, the doctor gives me the Xiidra, but Xiidra, it's creating a redness to my side, and when I'm looking to the artificial tear that he start with, it's only hyaluronic acid. This here, 100% the patient will not get a benefit from the Xiidra, because he reached to a level of inflammation that any medication, it will create additional redness and increasing the existing symptoms. So I'm using the tear that having this component, and I'm using those tears 15 minutes before use the Xiidra, which is used twice a day, and then the Xiidra, then 15 minutes again, I will use the same tear film or artificial tear. That's morning and evening, and asking the patient to blink, and definitely I'm explaining to the patient how he will have some test that he can testing the medication, and if he will use it. Some of the patients, they have this experience, but if he will use it in this way, the tear film 15 minutes before the use of Xiidra, and tear film 15 minutes after use of the Xiidra twice a day, then there is no redness, and this will be within the first 15 days, and then after that we can reduce the use of the artificial tear frequently according to the response of the breakup time. And this is one of the components of the artificial tear that I'm using. Now, as a study that presents 5 clinical trials, 2,400 patients included, and 4 for 2 weeks, 1 year. Those 5 clinical trials, 4 of them they did it for 12 weeks, and 1 of them they did it for 1 year. The study for those 4, the first 4, evaluated efficacy and safety of Xiidra versus vehicle. Those that the one that continue for 1 year study, they evaluated and safety for the Xiidra versus vehicle. Now, Xiidra shows a relief from eye dryness as early as 2 weeks in 2 of the 4 studies that studying the issues for 12 weeks. And that's very important, because this anti-inflammatory drugs, it's the only drugs that we can use, and it can as quick as 2 weeks can relieve the symptoms of the patient and can change the breakup time. Now, in 3 of 4 studies, Xiidra shows improvement in inferior corneal staining, and that's another issue that we are seeing on the patients when we are staining the fluorescein. Definitely, the fluorescein is one of the important tests that and it's the easiest and the most available test that we have it in our clinic. So when we are staining the cornea, we are seeing that inferior corneal staining, and this staining with the regular use of Xiidra, it shows that disappear or improvement of this staining within 12 weeks in 3 of 4 studies. Sorry, I'm just stuck that I'm not able to move the slides. If someone can help me. Yeah. I need someone to please, if someone, because I'm not able to move the slide. Anyone?
Hello.
Yes,
I'm not
my
sure
dear.
if our tech colleagues are here to help.
I don't know whether because it is stuck and I'm not able to escape, or yeah, now I can escape. So I will return back to the yeah. I will yeah, sorry. Now most
again.
Yeah, now I return back. So most common adverse effect in the 5
You're not sharing it. There's no share there.
Sorry. I will go to share again. Sorry. I don't know what's happened. It's not because of me. Now it's shared?
Yes.
Okay. So going back to the studies, the 5 clinical studies with over 2,400 patients shows that most common adverse events in 5% to 25% of patients, as I said, that the irritation at the site of the installation and some taste sensation that can be felt of them and reduce, but those it's carrying a very low in my practice. And I'm covering it, as I said, when we are using the proper artificial tear before the Xiidra and after it, then this sensation will be reduced. Now, if we'll go to the first movie, shows that the first patient had, it was 45 years male with a breakup time less than 5 seconds and a Sherman test less than 5. And this patient shows here, it's very clear how the breakup time, it's very low. And this is a real time. Now, if you need me to repeat the movie again, sorry. This is again, and you can just concentrate here and you can see the real time. This is a around 5 seconds, the breakup time started in this area. Now, if we will go to the patient, the same patient, 2 weeks after testing on Xiidra, then we will see that the breakup time improved to 16 seconds. And this is a real time. You can see this area, the breakup time improved in a very good way. Now, if we'll go to here in this patient, the breakup time was 0, means that it's whatever you are doing, there is a defect in the tear film. And the same patient, she was a female, 36 years, and the breakup time, well, I put the 2 seconds, but in my opinion, it was 0. Now, the same patient, after use, 2 weeks after use of the Xiidra, and you can see it's around 8 seconds. See, with a very good improvement. Definitely, she was not able to open her eyes, and with a severe photophobia and after 2 weeks later, her condition improved, and it's continued to improve.
We had 3 minutes, Safwan, okay?
Yeah, I'm almost done. You can see that here, the same, and if the breakup time is clearly appear directly, and this is the same patient. It's improved in a very good way. Now I will skip all these to go to the conclusion. And dry eye is a disease in which inflammation play a key role in its causes, include also the MGD. It is important to treat the inflammation in dry eye disease and stop the vicious circle of the dry eye development. Steroids are very potent anti-inflammation, but cannot be used for a long term. Xiidra drops is safe and effective anti-inflammatory to treat the dry eye disease. Different anti-inflammatory medication can be used to control dry eye disease alone or combination. Thank you.
Thank you, Dr. Safwan. That's very good. Common question, Safwan, we will ask. When you started, I know you expected some improvement after 2 weeks, but when you decide to stop the Xiidra?
Now, that's definitely, Osama, you are pioneer in how to ask, pioneer in a dry eye. Well, let me tell you, for me, I will not discuss the stop of the Xiidra before 3 months. That's primarily. After 3 months, in all my experience with my patient, they start after teaching them how to improve their lifestyle by adding. There is an application. Unfortunately, I didn't show it here. This application called Eye Protector, and that application is present in Android and in Apple, and they can download it, and it will remind them about blinking. And I found that blinking is one of the important factors that they need to learn. They need to blink 20 times every 20 minutes using of the devices. If they learned how to do it and the breakup time condition improved in a very good way, then I will stop it after 3 months.
But majority of people prefer to wait longer. And one thing I found that's the longer people use, the better their dry eyes control it.
That's absolutely right. But sometimes, Osama, those patients, they are coming in an acute form, and once they will improve their lifestyle, you cannot imagine that how much their condition will improve. And you can notice it from the 15 days, as I said, and then the improvement will continue. And once they reach the 3 months, I feel that they can discontinue. And I discontinued. I have few patients that it's been discontinued for 2 years, and now they are fine and still continue fine if they continue to have or improve their lifestyle.
Thank you very much. Yeah, so patient education is very important, and you have to treat all aspects of dry eye. Thank you very much, Dr. Safwan. I think the time for us allocated is finished. Thank you, and nice to learn from you, and leave it to the next panels for the next session. Thank you very much, everyone.
Welcome. Most welcome, Sam. Thank you very much for you.
Hello. Dr. Al-Amri. Am I audible? Dr. Mehdi?
Yes. Hello, Dr.
Osama?
Farzad. How are you?
Hello. Hello.
Great to see you all.
Hello,
Hi.
everybody. Hi.
So nice. Very happy to see you all, friends. So, Dr. Al-Amri, shall we start?
Yeah, please. The mic with you. Good evening, everyone. Thank you very much. Go ahead.
Hello.
Dr. Amri. Happy to see you all.
Sama, Dr. Mahdi,
أهلا دكتور
everyone.
عمري. أهلا.
Walid, marhab.
Yes, sir.
Okay, Farzad, the mic with you.
So, good evening, and thank you for joining us in the oculoplasty session 1 in QOIC conference. Thanks to Dr. Mohammed for being at this wonderful meeting. So we are going to start the oculoplastic session today. And so the first speaker is me, and I may start my presentation. So in this session, each of our dear speakers will show us some cases with some learning points. So please let me know if I'm visible.
Yes, Dr. Farzad, yes, please, you are okay. Just I request all dear others to mute themselves. Thank you.
So I'm going to start my presentation. This is a case with some interesting learning points in it that I hope that our colleagues enjoy. And after we have all presentations, we have some time for discussions and answering the questions. So here I would like to ask all my dear colleagues and friends to keep the time. So I will start my case. I have no conflict of interest. My case was a 32-year-old man with a before and discharge in both eyes. He had a history of acute lymphoblastic lymphoma 11 years ago that was treated with chemotherapy and no recurrence after that. He's a known smoker. He had history of external DCR in both eyes last year for a before and discharge, but after a while, he developed again the symptoms of discharge and a before in both eyes. So in the last month, he had history of acute dacryocystitis in the left side that was treated with QOIC and resolution of the cellulitis. This is the basic ophthalmic examinations. You may see that the positive points that are highlighted as red shows that we had positive irrigation tests in both sides, and we had a slight limitation in adduction in the left side. So as this was a young man with epiphora and discharge in both sides, I asked for CT scan, and in the CT scan, you may see that we have ethmoid sinus opacification and loss of the bony architecture of the both ethmoid sinus and the medial wall of the orbit in both sides. We have enlargement of the medial rectus muscles on both sides. And we have clinical features of recent actually cystarenostomine on both sides. So based on that, I decided to perform a sinus biopsy. And although in my practice, it's essential to do endoscopic nasal examination for every case with epiphora. And so you may see that when I enter the nasal cavity, I'm seeing inflamed mucosa, I'm seeing retained silicone tube from the previous surgery there. You may see that we have crossed and actually pus overlying swollen and brittle nasal mucosa over there. And we have loss of septum. You may see that when I touch the septum, it's just mucosa. There is no bone under that. So based on that, I assume we are dealing with some necrotizing inflammation. I asked for pathologist report on that. You may see here in H&E staining, we are seeing a mixed lymphocytic and polymorphonuclear infiltration. If I can show you here, you may see we have vasculitis in the center of the actually scene. We have inflammation of the vessel here, occluded vessel here, denoting its small vessel vasculitis over here. So this is another part of that tissue sample. You may see that we have mixed lymphocytic, and some area we have polymorphonuclear lymphocytes. And actually, it's a background of the fibroblastic activity over here. So it's highly suggestive for PGA. formerly known as Wegener's granulomatosis. So I asked for more lab tests. You may see that we had PR3 positive titer here. So we could confirm the patient has GPA, Wegener's granulomatosis. We started more actually evaluations. You may see that in the chest CT scan, we have cavitary lesions on the right side of the lung here. And we asked our rheumatologist to start treatment. He underwent treatment with methylprednisolone pulse therapy and cyclophosphamide. So then after a resolution of the actually active inflammation, we did endonasal endoscopic DCR for the patient with resolution of all symptoms in the next 15 months. So a few quick learning points here. In a young patient, especially when it's bilateral, we need to work up the patient for secondary causes of nasolacrimal duct obstructions, although we have no actually systemic or ophthalmic feature of any other disease. So for GPA, it's essential to understand that this is a multi-system disease. So we should look for any site that can be affected by this disease, not just upper inflammation or orbit. We should look at the lung, kidneys, or other regions. So we know that about 50% of patients with GPA may develop some orbital actually involvement. And among them, we know that in about 7% of patients, nasal lacrimal duct or lacrimal excretory duct system may be affected in these patients. And amazingly, this can be the first feature of this disease. So every ophthalmologist should be familiar with these symptoms and actually think about that. Otherwise, you cannot actually diagnose the patient on time. So usually lacrimal surgery in the early stages is associated with high failure rate because of the inflammation. After the inflammation is subsided, we can go for duct recystal rhinostomy. My preference is endoscopic job, and although we can do both external and endoscopic things for these patients. So thank you for attention. We'll be happy to have your questions in the actually at the end of the presentations. Thank you very much. So I may invite our colleagues to share their slides.
Good afternoon, everybody. So I guess I'm next in line. So I will share my screen now. I'm logged in from my laptop and also from my desktop, but I will use the desktop because of more stable connection. Another issue we can discuss, or we might have discussion during the case, because this is a strange case that I faced last year. So let's start, okay? So is it really a dacryo seal? So my patient, or this patient, is a 55 years old male patient, previously healthy, who was presented for the first time for me in the 1st of August.
Sorry, Dr. Osama. Sorry.
Yes.
We are hearing some echoes, Dr. Osama. I'm not sure if you have two devices on. I mean,
yes, I have two devices.
Can you please mute one of those, please? Thank you.
Is it better now?
Yeah, it's better now. Thank you.
Okay, sorry. The other device, the laptop, was the second device. Okay, so a 55 years old male patient, previously healthy, presented for the first time to our clinic 2 years ago almost, complaining of right eye tearing of a few months duration. His best corrected visual acuity was 6.6 in both eyes. Anterior segment examination was normal, except for an increase in both eyes. So the patient was treated for blepharitis. The tearing was minimal, and was instructed to do lid hygienes and return for follow-up. The patient came 7 months later, early last year, in 22nd of February, complaining from a right medial canthus swelling for the last 2 to 3 weeks duration. The swelling was not tender, not inflamed, and upon pressure on this proposed lacrimal sac, no regurgitation of mucopurulent material came out. So we assumed the diagnosis here is the mass lesion again, or the swelling again. So we assumed the patient to have dacryoceal, and he was given an appointment for right DCR 3 months later. So as we see many patients like this every time and then in the clinic. So on the day of surgery, the surgery was done under general anesthesia. The patient was draped in the usual manner. The skin incision was marked 11 millimeter medial to the medial canthus. Local anesthesia injected into the surgical field, and nasal pads were inserted into the nose. Immediately after skin incision, here is the skin incision, I noticed a whitish mass underlying the skin. So I stopped and said, what is this mass? This doesn't look normal to me, as I did too many external DCRs, and this is the first time I see such a thing. So I continued the dissection, and later on, I found a mass lesion overlying the lacrimal sac. Here we can see the mass lesion, a well-circumscribed mass overlying the lacrimal sac. So I elected to take this mass out and did complete excision of this lesion, as we can see here in these. And then I managed to take the whole mass completely out. I did not know what this mass is. And of course, I didn't have a preoperative CT scan or any imaging study for this patient. So at this time, I stopped a little time and started to think, what should we do next? We need to remember the patient's chief complaint was tearing for almost half a year, and the patient is under general anesthesia. A lot of ideas came into my mind, including closing the wound and waking the patient, because this might be the cause of his tearing problem, or send the specimen, which we don't know what is the nature of this specimen, for frozen section and wait for the results, or continue as conventional external DCR as we planned for the patient, or excise the lacrimal sac, which could be the source of this lesion, or do probing and irrigation despite the patient is under general anesthesia, or any other options from we can think. I don't know if any of you has an idea what will be the best thing to do in such a case, if we would like to discuss it now or at the end of the case.
We can share very quickly, Dr. Osama, like 30 seconds if you like. Do you want to ask somebody specifically?
Yeah.
No, anybody. Yes, please.
Yeah. I think you should have done probing before you incise. I mean, you were not sure this is a mucosal, but probing would have given an idea if you have the probe inside the sac or not.
Yeah,
I mean, it's a deceiving case, of course. Yeah.
Okay.
But
thank you, Dr.
But at this, thank you. At this situation now, I think you should have this mass that you extracted examined pathologically, and not necessarily through frozen section. Maybe later on, and you decide on it on a second session. Thank you.
So you might close the wound and wait for the results, which is choice A.
Yeah. This is what I would have done.
Okay, thank you.
Dr. Osama, I may add just a few seconds. Sometimes a brave surgeon is the surgeon that decides a brave surgeon sometimes is a surgeon that decides to stop the operation rather than continue the operation.
I
So
agree.
it needs more courage actually there than continue the operation.
Continue.
And
Okay.
we know that if you think during a DCR, if you are seeing some unexpected mass lesion over the lacrimal sac, it's essential to stop the operation and not just continue and do actually osteotomy. It's a rule for all colleagues here. And I believe probing irrigation test is helpful at that moment when your patient is under anesthesia. So we would hear more about this case from you now.
Okay, so what I did let's go back. What I did as you both said, I did the probing exactly, and I found the proximal lacrimal system, the upper canalicular system, is totally patent. So after that, here is the probe. So after that, I did irrigation, which showed early sac distension. Then the sac opened with a mucopurulent discharge. Now the sac is open. So what we do next? Here is the mucopurulent discharge coming out from the sac. And as I said, the sac after irrigation, it enlarged in size. Okay, and after that, later on, it ruptured or it opened with me during the surgery. So what to do next?
Do you want to continue, Dr. Osama? Because we have now just 3 minutes. And I feel we need to finish it in 3 minutes.
Okay, so what I did actually is I take the excise the lacrimal sac. Why? I was not sure about the nature of the pathology of the patient. So I took the lacrimal sac completely out in toto. And then here is the picture after total excision of the lacrimal sac. And then I continued as an external DCR with intubation. Here are the tube, as you can see, both tubes, Surgicel over the tubes, and skin enclosure. Of course, I sent the pathology. Here is 3 weeks after the surgery, no problem. The histopathology came a week later, and here is the report. It was a single round mass measuring 1 centimeter by 6.6 centimeter by 0.3 centimeter. It was formed from a mixture of spindle cells mixed with inflammatory cell infiltrate composed predominantly of plasma cells and histiocytes. So, and here is an important note in the histopathology. Ziehl-Nielsen stain was negative for acid-fast vessel line. It was not TB. Here, a low power magnification showing the total excision of the mass with the capsule intact. And here another stain. So the diagnosis came back as benign spindle cell pseudotumor. Actually, I looked at for this tumor or benign pseudoinflammation in PubMed and National Library of Medicine, and unfortunately, I did not find anything around the orbit, periorbital islet, orbital benign spindle cells. No results were found. I found one article from Lewis Jr. in the head and neck pathology saying that it is a variety of disorders that can vary from malignant or others are simply benign or reactive, but most spindle cell pseudotumors reported in the literatures are associated with Mycobacterium, a variant of TB. In our patient, we had a negative Ziehl-Nielsen stain, so it is not a TB. The patient is doing, here is the lacrimal sac biopsy, and it showed features of acute and chronic inflammation with no evidence of malignancy. The patient is doing well after 9 months of the surgery with no complaints. And as we can see, the DCR tube is still in place. Patient is happy, and we solved his tearing problem and also took out this rare tumor. So I would like to thank my colleagues in the hospital, Professor Musa Labadi, he's the professor of pathology, Dr. Tal Arach, he's a pathology resident, and our ophthalmology resident, Dr. Isra Asfour. Thank you all.
Thank you very much, Dr. Osama. So we'll be back to you. And I would like to ask our next speaker, Dr. Walid Abdullah, for starting his presentation. So I would like to ask our audience, please write your questions in the chat box or in the Q&A box. So we will come back to your questions after all presentations. Can you stop sharing, Dr. Osama, please? So.
Yeah. Yes. Okay. Sure.
Dr. Walid, please.
Just a second. Can you share?
Yes, yeah, we
okay.
can see.
Okay.
Okay, perfect. So,
hello,
Dr.
everybody. You can hear me?
Yeah, we can hear you.
It's okay. How can I? Hello, everybody. I'm very honored to be with you all. I have a case here I want to share with you, which is a multiple cranial nerve affection. So this case, as we are all facing cases with cranial nerves, we're usually familiar with the third, fourth, and sixth, but also when we have an affection with the trigeminal nerve for the facial sensation and the facial nerve for the motility of the face and affecting the corneal sensation and corneal closure, at that time it will be a bit more tough. So my case here is an Omani guy. He is 35 years old. He has a benign big brain tumor, and this brain tumor was excised about 8 months ago. He is complaining now from redness, some pain in his eyes, inability, photophobia, and he cannot close his eyes, and he has also diplopia. This is the patient. We have the whole face. We got the consent of showing the whole face because he has symptoms in his face as well. As you can see, the big esotropia, the redness, ciliary injection, and also he has diminishing in the facial sensation, motility. You have this deviation of the face toward the left, and he has sensory hearing loss as well on the left ear, so he can hear only with one side after the surgery. So by examination, the visual acuity was affected, not only by the refractive error. Ciliary injection was there, punctate epithelial erosion in the middle 2/3 of the eye, the lower 2/3, with exposure keratitis, corneal hypothesia with the starting neurotrophic ulcers as well. The pupil was, but everything else was normal. So this is how he looks when he tries to close the eye. Even with force, he cannot close properly the both eyes. So away from that, the motility also was affected. Esotropia, distance more than near, showing bilateral 6 nerve palsy as well, with fixation of the left eye. This is the orthoptic evaluation. And going after that with the fully investigation, the neurological surgeon was approached also. He said that everything is stable, no more things to be done for the patient. So the patient is totally stable from the neurological point of view. Diagnosis was made that now we have affection of the 5th, 6th, 7th, and 8th cranial nerves, and the 6th cranial nerve was affected for both eyes, with more toward the left eye, as you can see in the photo. So lid lag was there, exposure keratitis. We prioritize to correct, of course, the most dangerous one, which is the lid lag. Conservative treatment was done already, so, and even temporary tarsorrhaphy was done. So the gold weight was chosen to be the next step. So now we went for sizing of the proper size, when the proper weight, which is going to be making the eye closed. The proper weight was chosen. This is the sizes, the different available sizes with 3 holes, which is used to fix the gold weight to the tarsus. The patient has problem with sleeping with general anesthesia, so both procedures with the gold weight, which is normally done under local anesthesia, was done under local anesthesia, and also the procedure for the squint was done under local anesthesia as well. So lid crease was done, and the gold weight was put on the tarsus directly, fixed with non-absorbable sutures through 2 holes to the underlying tarsus. Orbicularis oculi was sutured, so subcutaneous was done to prevent the protrusion and also for cosmetic purposes. Then the skin was closed properly. This is how he looks, proper closure. This is just immediately during surgery, and this is after surgery with almost 1 week, and this is the 1 month follow-up after. So the squint surgery also was done, and again, absorbable suture was rejected, recession and resection. And this is the picture after doing the squint surgery with, he has a very small desirable overcorrection, and the face turn was much less. And this is you can see the ciliary injection subsided, and all the signs of exposure was not there after the procedure. He can close properly, and he doesn't have any double vision with complete closure. As conclusion, so 6 nerve palsy can come, showing on the nuclear level multiple cranial nerve affection, when multiple causes can cause that, when they are affecting the pons level of the nuclei, with the pontine paramedial reticular formation and the fasciculus of the 7th nerve. This is a case actually of acoustic neuroma, as it was shown with bilateral 6 nerve palsy, was affected also by the raised intracranial pressure. Can be also a differential diagnosis of nasopharyngeal tumors or intracavernous part if it will be affected. This case was affected the 6th nerve, so esotropia was there, limitation was there, and face turn was there, and the head posture, facial muscle weakness was there, and the facial sensation was subsided. So we're supposed to manage all those through the 2 ways, which is fix first the lid lag with the gold weight after using the conservative measures till he will be ready for fixing the gold weight, and then fixing the alignment as the lid lag is the priority. Thank you for, I hope that I didn't take so long time, and I'm open to any discussion.
Thank you, Dr. Walid. Great presentation. So I was just curious if you have any MRI to show us.
Actually, he did that. He was coming from a different country, and this MRI was there as a CD, but no, it's not here in the presentation.
Okay, thank you very much. We will come back to you. So I would like to ask our next speaker. I'm not sure if Dr. Feiruz is here. Maybe our Dr. Muhammad, can you inform us if we have Dr. Feiruz with us? Otherwise, I may go for Dr. Mehdi. Dr. Fenry, can you please unmute and share your slides? Hello. Dr. Fenry.
Okay, it's okay.
Yeah, we can see your slides now and your voice.
Yes. So thanks everybody. Thanks Dr. Muhammad, thanks Dr. Fazler. My case is a case about acute exophthalmos with the history of vascular orbital anomaly. So as you know, vascular orbital anomaly is very polymorph, and we have the last classification would distinguish vascular malformation and vascular tumors. And our case is about lymphatic malformation with the assessment, with the clinical, radiological, and histopathological examination, with the particularity of risk of hemorrhage. So my case is 20 years old. He has a history of surgery of orbital vascular anomaly in 2000, and with no details for the anatomopathology. And in 2017, he was exophthalmos treated medically. When he comes to our office, he had a very severe visual acuity loss with exophthalmos and chemosis, with corneal ulceration, with reduction of ocular motility, with very increased intraocular pressure, and dependence with normal, with no papillary edema. So when we asked the patient for his picture just before the exophthalmos, he was almost normal. And for this patient, we start with medical treatment by antibiotics and steroids. And we ask for imaging, urgent imaging in emergency. And this for this patient, the first question, should he do TDM or MRI? With the history of vascular lesion, of course, we prefer to do MRI. And when we look to the MRI, we have multiple diffusal infiltrating cyst, which is very typical to the lymphatic malformation. And here is in the coronal section, the multiple cyst was evident, but the particularity of this case, when we look in the deep on intracorneal lesions, we show that we have a big cyst with a fluid level, which explain the acute exophthalmos in this patient and explain all the symptomatology. In this case, the second question, should we continue with the medical treatment? Should we decide for aspiration of the acute hemorrhage cyst with the surgical approach, or should you do it with non-surgical approach but with radiological control? Should we decide for aspiration and do injection of sclerosant agent at the same time, or should we decide for the surgical removal of the cyst? This is the first question that we ask with this kind of patient. The second option is, should we decide to manage the effect of the hemorrhage and not to treat the hemorrhage itself, manage the effect of the hemorrhage that causes hyperpression, the equivalent of orbital compartment syndrome, or should we decide for this case orbital decompression? If we decide for the orbital decompression, which ward should we decompress and which kind of approach? We decided for this option to do orbital decompression in emergency with a conjunctival approach. We decided to do medial ward decompression with a conjunctival approach with no access to the lesions, and the evolution 1 week postoperatively, we have improve of the exophthalmos and the reduction of the chemosis, and the evolution was going too slowly. To improve the chemosis, we decided to do blepharophy, and only 15 days postoperatively, we have the improvement of oculomotricity, and only after 1 month, we have the improvement of the visual acuity and a better improvement of the exophthalmos. And she had only at this second month, the total recovery of the visual acuity, of the oculomotility problems, and the increased ophthalmic pressure. And for this situation, after 2 months, another question, that we can ask for this patient. Should we go with the sclerotherapy, or should we stop in this for this patient with no sclerotherapy after 2 months and after the total recovery, as we see compared with the photo before the exophthalmos. So for the discussion, I think the location and extension of the lymphangioma, mainly lymphatic malformation, is very important for the assessment and management. As you know, the management is based on observation, sclerotherapy, systemic therapy, or surgery. For the deep lesions, it's the most challenging situation with the risk of functional complication and the risk of the surgery, the risk of sclerotherapy, because the excess of the lesion is very difficult, and we should decide between conservative approach or treatment. Of course, part the emergency, and in case of emergency such as this case, what's the best therapeutic protocol? This is the main point to discuss together. So in conclusion, lymphatic malformation is sometimes very challenging, the deep lesion mainly, and orbital decompression, in my experience, is very helpful in case of complication. And also we developed a new concept of sclerotherapy with low pressure sclerotherapy based in a simultaneous decompression at the same time as sclerotherapy. And this is for the complication is very important and very helpful alternative for this kind of problem. Thank you.
Thank you, Dr. Mehdi. So we'll come back to you. And now we will go to Dr. Sharif Elwan. Hello, Dr. Sharif.
Yes.
Dr. Mehdi, can I ask
Hello?
you to stop sharing your presentation so we can have Dr. Sharif's presentation? Thank you. So I believe we have good time for discussions.
Yeah, sure. Thank you very much for the invitation and for moderating the session. And I am going to go through 3 cases, if you allow me. I remind you all that common things are common, and this is what we've been taught as young medical students, and all through our careers, we've been teaching our students and fellows to think of common things first. However, this is my first case. A young girl of 22 presented with protruding eyes with history of bilateral 3 periorbital steroid injections with the doubtful protrusion progression. She was an emmetrope with visual acuity of 1 bilaterally, high intraocular pressure, exophthalmos, as you can see, more on the left side. Otherwise, she was normal. This is my patient from different views, and she had no symptoms of hyperthyroidism, no neck signs. B-scan and MRI showed thickened extraocular muscles, and here are the measurements. When we investigated her, she had a normal free T3, normal free T4, normal TSH, normal anti-thyroglobulin antibodies level, and normal TRAB, which is the thyroid releasing hormone antibodies, which is now known as the major player in Graves' disease. These are the investigations. So it came to my mind the rare or very rare diagnosis of euthyroid Graves' disease in the absence of all classic signs of Graves' orbitopathy, with normal thyroid profile and no signs of hyperthyroidism. The management is controversial. Systemic steroids have been used, systemic monoclonal antibodies in particular, tocilizumab, which is Actemra, used in treatment of the COVID, periocular steroids, other systemic immune modulation And finally, some of endocrinologists suggest thyroidectomy. So this is the first case, which is euthyroid brevis orbital. My second case is a gentleman of 57 who came complaining of deviated globe of long duration. He was living with pets and with a history of motor car accident 20 years ago, a neurosurgical intervention to restore his frontal bone. On examination, he had a very big cyst, medial, pushing the left lobe laterally with severe diplopia. In the OR, I aspirated this cyst for decompression and a bloody fluid came out. The CT showed this very big cyst, which is almost 1.5 times the diameter of the eye globe, with this squaring that you can see, with bone resorption in 3 of the orbital walls, indicating long duration. And I went in transconjunctivally, and after decompression, I excised this cyst. Of course, I thought of hydatid cyst due to the history of living with pets, but when I aspirated, I started to go into other ideas. The pathology came up with a surprise, a fibrotic wall with lining of cuboidal, partly flattened epithelium, with underlying stroma, with aggregates of lymphocytes, foci of vascular channels, and the aspiration content was hemorrhage. It's a hemorrhagic fluid, microscopically showing no scolices, only blood. And this is the report. And the report concluded that this is a pseudoreferous cyst, which is a mole cyst, as we all know. Mole pseudoreferous cyst is regularly presented due to blocked apocrine sweat glands found on the margin of the eyelid, a solitary dome-shaped papules filled with clear fluid, trans-eliminated well. So this is a rare case of gigantic pseudoreferous cyst. And my third case was a 7-year-old young girl who came complaining of a lid wound and a very other strange complaint that one of her color pencils disappeared. This was the report of the parents. On a 3D CT, I found the pencil, and this is the surprise. This is the site of wound where the parents were complaining with some upper lid cellulitis. And here's the pen. It starts in the orbit, pierces the floor, goes into the pterygopalatine fossa, and goes near to the second vertebrae, second cervical vertebra. This the pen. We went in, I widened the wound, and I extracted this pencil. And I remind you that intraorbital foreign bodies have an individualized decision to operate. We don't have a consensus on this. However, the risk of surgery versus the risk of intervention, as you could see, this could have threatened their life going into the upper vertebral column. Possible complications like infection and inflammation, being chronic fistula formation, neurologic compromises, and mechanical restriction. It depends also on the nature of the foreign body. Being organic, you have to remove. Inorganic, if it is anterior in the orbit and accessible, it's okay. If it is posterior and organic, probably you have to observe. And this is what I found, an intraorbital pencil. So the unexpected apple that I cut to find it an orange was euthyroid Graves' disease, gigantic pseudoreferous cyst, and intraorbital pencil. The take-home message from my presentation is number one, never rule out a rarity. Consider common diagnoses first, think of rare alternatives afterwards. Patient history telling is sometimes missing significant events, and the investigations complement examination. Thank you very much.
Thank you, Dr. Sharif. Great presentation and very interesting cases. So we can now go for question and answers. I'm not sure if we have any questions. I'm not seeing a panel for questions. Maybe our tech actually colleagues can inform us. Do we have any questions from the audience, or we can go to the panel and ask our questions? So I will start from, if you let me, from my talk on Sando, secondary to GPA. If there is any comments from our colleagues here, I will be happy to answer. Otherwise, I will go to next talk.
I have one question for you, Dr. Farzad.
Sure.
I read that Wagner's granulomatosis has changed name into granulomatosis with polyangiitis.
Yeah.
It's not anymore called Wagner's granulomatosis.
No, it's GPA.
But I don't
now.
know why. We've long known that there is angiitis with granulomatosis. Why the change of name?
I'm not that much sure, but we know that now we classify this type of the vasculitic lesions under the umbrella of GPA into 3 types based on the actual staining of the anti-nuclear antibodies. So maybe one reason is not the reason is that what we understood from the triad of the Wegeners is not for all of these subtypes. Although all of them have angiitis, but some of them have, more distant lesions, and they have different kinds of ANCA actually presentations.
Thank you.
Any more questions? So, Dr. Osama,
Yes.
it was interesting to actually to understand how to deal with an unexpected lacrimal sac mass during operation. So we understood one take-home message as if you suspicious or you find some lacrimal sac malignant lesion, you may stop the operation. And I'm not sure if you find something that persuaded you to do for dacrocystectomy and then for osteotomy. This is my first question. And I will go for the next one, that's for the diagnosis of that lesion.
Okay. For the first question, there was no signs of malignancy. The lesion looked totally benign, circumscribed, well demarcated, not allangiectasia. So I thought this could be benign rather than a malignant lesion. So that's why I decided to take it in total and continue the procedure or continue the surgery. If it was malignant or if there are malignant signs or symptoms, yes, of course, I would take an incisional biopsy and abort the surgery or discontinue the procedure. The other thing, the origin of this lesion, I even talked to the pathologist, whether it was the lacrimal sac or the surrounding area, namely the orbicularis muscle. We could not define the origin of this benign lesion. So even though I decided to take the lacrimal sac out because it could be the sign, or the source or the origin of this lesion. So combining, taking the mass out in total and taking the lacrimal sac and also sending it to pathology. And the pathology came as just acute and chronic inflammation with no malignancy, was reassuring for me after the surgery. So basically, this is what I thought at the time of surgery. I had the option to stop the surgery and come back for later on and wait for the biopsy. But I thought first, this is a benign lesion, best to take it out and then to continue. The other issue, the patient symptoms started before the onset. As I said in the beginning, he came after 6 months with this mass, but he already complaining of epiphora. That's why I also elected to continue with the conventional DCR.
Dr. Farzad, I have a question.
Yeah, sure, Dr. Mahdi.
Yes. Of course, we discussed about the per-operative situation is a difficult situation, and this point is very important to discuss. But I think another learning message is the assessment of this patient. For me, if there is any abnormalities in the examination or in the history of the patient, imaging is very important.
Yes.
As you know, I'm very attracted to CT-DCG.
Hello, Dr. Muhammad.
For this patient, it was probably very helpful to have pre-operatively a CT-DCG for a better decision per-operatively. This can be very.
Yeah, well, Dr. Mahdi, for me, as if you see the pictures, it looked typical as a dacryoceal. There was nothing different to suggest a dacryoceal other than there were no reflux of mucopurulent material, and this could be due to a patent internal punctum or valve Rosen-Miller. Otherwise, his examination, his medically healthy, his presentation, the color of the skin, nothing to suggest that there is a mass underneath the skin. So it was just once we opened the skin that I noticed there is something that doesn't look right.
One point, probably, in my experience, when I have this kind of situation with a good exploration of the dye test and irrigation test, if there is no obstruction, no dye test retention, and a very good irrigation test, for me, it's a good indication for imaging before deciding the surgery. I know that is a typical situation, but sometimes some details start to be with some question we should answer. It's better to have a better assessment before surgery.
I have one more question to Dr. Sama as well. Is the palpation didn't make you feel something different from the cystic feeling, like firm to hard, since if palpation of the mass itself?
No, just felt smooth and round and compressible also. You can compress it, but nothing came out from the lacrimal sac. So even palpation did not give me any clue that could be an underlying mass. It was really strange for me that I found this mass just after I incised the skin. Nothing in the history, nothing in the examination. Otherwise, I would go further for imaging and evaluate him with further testing, MRI or CT scan, but nothing at all in the examination suggested that it could be a mass.
So we understood that we had a challenging situation. So although I would like to emphasize the importance of the pre and intraoperative diagnostic procedures to make sure that everything is like a usual case. In any case with atypical presentations, or we cannot actually interpret why this is like that, why it's like firm. So imaging is very helpful in these situations.
Yes.
And in the case that we found everything was normal, but during operation we find something is inside or overlying the lacrimal sac wall, as Dr. Osama showed us, it's really critical to decide how to proceed. To me, if it's like a tumoral mass inside or overlying the lacrimal site, I will start operation and will just take a biopsy. I think Dr. Osama considered that, but when he found that we have a problem with the lacrimal site, it's like open, and there is a risk for cellulitis or something, and he realized we need to do something for repair or removing that. So I think it was because of that, and we know that if we have tumor of the lacrimal site, DCR is not a good option. We should do dacrocystectomy. But I will do that just after I have received the pathology confirmation of what kind of a tumor I'm dealing. For example, if you have lymphoma, you do not need to remove the site. You don't just go for radiotherapy and chemotherapy. But if you have other tumors that I would like to open the discussion here about the diagnosis, you beautifully showed us how it's difficult to interpret the diagnosis based on the pathologic report. So I'm not sure if it was like a mycobacterial solitary, actually pseudo-inflammatory lesion, because for this type of lesion, we need to confirm it's mycobacterial. And I didn't see anything to confirm it's like a mycobacterial infection.
No.
So based on the description first, because of the spindle cells, and despite it was CD30 minus, it was not positive in this tumor, but solitary fibrous tumor would be a good consideration. We know in some cases with solitary fibrous tumor, we have CD34 negative situations. I would like to ask if you checked for BCL2 or CD68 or other actually markers for SF?
Yes, I think we did, and let me share my screen again if I can.
So while you're sharing, I would like to inform my dear friends and colleagues that fortunately Dr. Mohammad gave us like 10 more minutes at least, so we have good time for discussions as far as we have good messages for our audience here. So yeah, I think the diagnosis is critical for this patient. If it's like a sarcoma, we know that this is a picture for some kind of sarcoma, so it's not, we cannot actually
Is my
just,
screen
no, we cannot see your slide here.
Can I share it? Just 1 minute.
Yeah, take your time. So while you are sharing, do we have any other comments for Dr. Osama's here? So after Dr. Osama, we'll go to Dr. Walid.
Yes.
Yes. Yeah. Can you see it now, I think?
Yeah, we can see your slide here.
Okay, so let's go to this slide first. Okay. So here is the histopathology. CD68 was positive in this patient, and the spindle cells were focally positive for the smooth muscle actin, and they were negative for CD34. They were also negative for the neurofilament. They were negative for CK7 and negative for ALK. I reviewed the histopathology with the pathologist who I mentioned at the end of my presentation, actually twice, at the time of reporting and the second time before deciding to present this case to you. So we at both times we reviewed this case. He still insisted on the diagnosis of spindle cell inflammation or pseudotumor. Ziehl-Neelsen stain, which is associated with spindle cell pseudotumor, were negative. Yes, if you go to the literatures and search for spindle cell pseudotumor, all the reports, as I said, they were associated with mycobacterium, but no clinical features or no systemic features in this patient to suggest TB. So it could be just an isolated spindle cell proliferation. And if you, and here are also other stains that I came. These are also the positive CD68 immunohistochemical stains that highlights the histiocytes. And here are another higher magnification view. So the pathologist has no question that this is a spindle cell pseudotumor. What is the source of this pseudotumor? We cannot tell. What is the source of origin? Was it the surrounding tissue or the lacrimal sac? Still, if it was from the lacrimal sac, I will be happy because this could be reported. I looked into lacrimal sac tumors and there is no spindle cell pseudotumors coming out from the, at least there is no reported cases coming out from the orbit or the eyelids or from the lacrimal sac area. So unfortunately, we couldn't localize the origin of this. It could be arising from all the trauma or all minor infection. We don't know the origin actually.
So based on the intraoperative photos you showed us, I assume it's like a lacrimal sac tumor, because when you remove the tumor, your lacrimal sac was open. So I assume it was like that. And I would like to mention that your pathologists assume that the inflammation is because of the nature of the disease. To me, I've seen lots of cases with, lacrimal sac tumors, including SFT, solitary fibrous tumors. I've seen many of them. So the inflammation is not for the nature of the tumor. It's because of the nature of the location of that actually organ. Yeah, because when you have chronic inflammation, chronic stasis of the actually tearing over there, you will have some chronic inflammation. It's not because of the tumor. So we need to focus on the, we need to focus on the,
continue to Farad,
No, I'm done.
And this patient, there was no history of, in this patient, there was no history even of inflammation, no skin tenderness, no redness, nothing.
Exactly.
Just the swelling coming up over
so
2-3 weeks.
It's not like a pseudotumor. It's like just a tumor. So one of our colleagues
just
wanted to
small comment.
Yeah, Dr. Sharif.
Yeah. To my mind, if you can share the histopathology photo once more, the swirls of spindle cells looks to me like a rhabdomyoma, and being chronic inflammatory this one
The first one, second one,
the one with silver stain.
Okay.
You see the swirls look like a mass from the skeletal muscle, like a rhabdomyoma. I wouldn't say it's a sarcoma because of the clues that the pathologist gave, but it could be originating from the overlying orbicularis muscle, especially with your comment.
Exactly. This is what I had in mind. It was not originating from the lacrimal sac, but I took the lacrimal sac just in case it was a source of the region.
Okay, thank you very much.
You're welcome.
Thank you very much. It was very interesting, Dr. Asama, with many interesting points in that. So we can go to Dr. Walid for the interesting case with multiple cranial nerve pulses.
I have a question, Dr. Walid.
Yes.
Yeah. Thanks you for your result. Very interesting case, and you have a very good result. In my experience, when you have 6 nerve palsy and 7 nerve palsy, it's very difficult to manage. But for the esotropy and the strabismus, how do you operate it with recession and resection muscles? And what's the improvement of the oculomotricity in this patient?
For that, we are behind the time. If you can just have the last question, this one.
Okay.
I didn't go deeply with the,
Yes,
I didn't go deeply with the correction of the strabismus as the part is more toward the oculoplastic part, but there is a rule, of course, of putting the patient for transplantation of the transpositioning of the whether half tendon or full tendon of the if the eye will not cross the midline. But if it is crossing the midline, we do resection for the medial rectus and lateral rectus and see how is it, and aiming for some little overcorrection. As you saw, there is a very small exotropia. So this is going to make him fuse. The idea is to overcome the binocularity. His general condition is tough. He is not tolerating the general anesthesia. He cannot do adjustable sutures because he is wheelchaired, by the way. So the condition was more tough towards correcting and leaving him with single vision. This is the aim, and some small overcorrection was aimed, but it was good that the motility, once it is correct over the cross, they can cross the midline. We are going for resection and giving the chance first and see how it's going to be. I think this was the question, right?
Yeah.
So, Dr. Mohammed, how much time do we have, if any?
We don't have any. We already crossed the time.
Okay, so we have used all the time that you gave us, yeah?
Yeah, and 15 minutes more.
Okay.
We started late, dear Muhammad.
Yes.
Very generous, Dr. Muhammad. Very generous. Thank you.
This 10 minutes already taken from Dr. Fairuz. She didn't be there. That's why.
Okay.
Thank you, Dr. Farzad. Thank you, Dr. Sharif, Dr. Mahdi, Dr. Walid Abdullah. Thanks, Dr. Walid.
Thank you for all.
Very much.
Thank you, Dr. Farzad. Thanks a lot. Thank you, everyone. Thanks a lot.
Thank you.
See you soon.
Bye-bye.
Bye-bye.
السلام عليكم دكتور سامح، مساء الخير.
نور دكتور محمد، اهلا وسهلا، ازي حضرتك؟ ايه الاخبار؟
عاش من شافك، شو اخبارك؟ ان شاء الله بخير.
عيش ربنا يكرمك. الحمد لله كله بخير والله، ماشي الحال.
دكتور Hanifi, how are you? Nice to see you.
Hello everybody.
Dr. Hayat, hello.
Yes, I'm there. How is everybody?
Alhamdulillah, fine. Nice to meet you, Dr. Hayat.
Pleasure, Dr. Sameh.
So, Dr. Sameh, you are the moderator of the session, so please, you can start the session as usual. I think all available except one. We will just have it soon. So the mic with you and the floor with you, please, Dr. Sameh. Thank you.
Okay, thank you very much, Dr. Muhammad. It's my deep pleasure and honor to participate in this session. I remember well when I attended the first QOIC. It was 8 years back. And I met Dr. Muhammad and we prepared well, I think. It was a very successful, prestigious meeting. And
you are the one who prepared the scientific program, by the way. Thank you very much.
Thank you very much. It's my pleasure and honor. Today, I'm happy meeting some old and new friends to start a pediatric session. Hopefully, it will be fine and you'll enjoy our scientific program. And I think we have to invite our first speaker, Dr. Dillon, for novel treatment approaches for amblyopia.
Yeah, thank you. I'll share my screen now and then you can I'll start my talk. Okay, I think you can see my screen now.
We can see it well, doctor. Thank you.
So I'm going to start. So I'm going to start with dichoptics and the treatment of amblyopia. This is the newest topic in the treatment of amblyopia. As we know, amblyopia is really a monocular problem, as it was thought it was maybe 10 years back. So it's not really a monocular issue. Amblyopia is a developmental disorder of the visual cortex that arises from abnormal interaction, be it strabismus, be it anisometropia, anything that occurs in the difference in the visual perception from the both eyes in early childhood, leading to cortical suppression of the amblyopic eye. So it is basically imbalance in the intraocular supply that favors the dominant eye, leading to decrease in the visual acuity. So the binocular functions are impaired, such as impaired stereo acuity. But the modern concept is that we need to look just beyond the visual acuity. Visual acuity is not everything. So the conventional therapy of amblyopia included patching or penalization or pharmacological penalization or mechanical penalization, which has been proven effective for children less than 6 years of age. So the amblyopia treatment studies conducted by the pediatric groups, they say that about 120 hours of patching can improve the visual acuity by 1 line in children who are 3 to 8 years of age, and the effectiveness decreases steeply with age. It's not always successful. It is not always seen to be successful in hyperopic anisometropic cases. Yes, it is successful in myopic anisometropic cases, to some extent successful in strabismic amblyopic cases as well, but there are compliance issues, there are recurrence issues, and it does not directly address the interocular inhibition. Dichoptics, on the other hand, is based on the push-pull protocol that recalibrates the interocular balance of the excitatory and the inhibitory interactions. So the push element, it excitants the weak eye, and the pull element, it inhibits the strong eye's perception. What really is dichoptics? So dichoptics, as you see here in the picture, there are two kind of picture illusions that are given to the eye. The dichoptic training reduces contrast to the fellow eye to rebalance the contrast within the two eyes. It promotes the treatment of amblyopia by promoting binocular vision. It reduces inhibitory interactions in the visual cortex, and it decreases the suppression and improves the stereo acuity as well. It forces both eyes to work together. It forces the brain to interpret the reaction from both eyes together, and therefore increasing stereo acuity in addition to increasing the visual acuity in the weaker eye. So a lot of studies in the recent times have been conducted. A study conducted recently in 2015 in China stated that there has been a visual acuity improvement of 0.15 logmar, which has been clinically significant, and 0.06 logmar compared to the patching group. The stereo acuity improved by 43% in the non-patching group compared to in the patching group compared to 34% in the non-patching group, and there has been reported improved contrast sensitivity as well. Recently published in 2019 in the American Academy, there has been a randomized controlled trial of dichoptic and digital therapy for amblyopia by Scott et al. And they say that at 12 weeks, amblyoptic eye visual acuity improved by 1.8 lines in the treatment group compared to 0.8 lines in the comparison group. Travi et al. Also suggested that dichoptic treatment of amblyopia led to a mean improvement in visual acuity by approximately 0.33 logmar, which has been visually significant. That is Snellen's visual acuity 20/63 to 20/32. And there has been reported a statistically significant decrease in suppression. Dichoptics is not just video games. There are also dichoptic movies coming in, recently published in JPOS in 2015. A dichoptic movie treating childhood amblyopia by Simon et al. Says that the visual acuity improved significantly, approximately 2 lines at the last outcome visit. So dichoptics is not just used for treating childhood amblyopia. It has been seen to treat adult amblyopia as well. This is the unique selling point of dichoptics. It has been noted that adults do not respond to conventional occlusion therapy, but it has been seen that the adults also have a significant degree of plasticity. Published in 2021, dichoptic training does enable adult amblyopic brain to learn as well. So significant improvement in visual acuity, specifically significant improvement in stereo acuity has been noted in both groups. And the stereo acuity has been greater than by a factor of 4. 2015, again, Indu Vedamurthy in India did see that there was improvement on an average in about 27% of the children who were treated with dichoptic games. And there was improvement in the stereo acuity. In addition, there was improvement in the reading speed and contrast sensitivity. Amblyopia therapy with dichoptics in adults, also using an AR headset also resulted in improved visual acuity from 0.58 logmar post-training, pre-training to 0.43 logmar post-training, with also an increased change in stereo acuity. So the newer concept that has come in is that we've always believed that the fellow eye of the amblyopic eye is normal. However, the recent concept says also from the histopathological changes, we know that the fellow eyes are also not normal in amblyopes. They do have oculomotor, visual, and visuomotor deficits in the fellow eye as in monocular as well as binocular function. So dichoptics has been an effective therapy to improve the binocular vision in the better eye as well as in the amblyopic eye. It has been seen in a recent article in 2020, it has been seen that when they were evaluating the acute effect of stereoscopic recovery by dichoptic stimulation, they recorded the electroencephalogram waves in the brain as well, and they saw that by dichoptic stimulation, there was stimulation of the beta waves in the brain as well. There was significant difference in the beta power spectral density in the primary visual cortex, and there was also significant difference in the middle temporal lobe region, where the specific region of the dorsal extrastriate processing stream was there, which led to a higher change in the mean visual acuity at follow-up, also a higher change in stereo acuity. So we need to also start thinking beyond visual acuity and beyond stereo acuity. In smaller children, younger children, we do need to focus on a holistic improvement in behavior, including visual behavior, which includes motor functions, fine motor skills, including manual dexterity. Very recently published in February 2023, we have this study that was published in JPOS by Birch et al. Saying that binocular amblyopia treatment, it does improve manual dexterity and manual dexterity skills in children, such as playing blocks, threading beads into a needle, or threading beads into a necklace. And children who have been playing video games with both hands, children have been seen to be more ambidextrous after 4 to 8 weeks of binocular amblyopia therapy in the younger as well as older age group, which when compared to age-matched controls were statistically significant. So I would like to conclude by saying that dichoptic training can improve and even restore stereo acuity in children with amblyopia, especially those with mild to moderate amblyopia. And we used to treat strabismus prior to strabismus. The only drawback here is that we need to treat strabismus before starting dichoptic therapy because it is a binocular vision therapy. So in cases of strabismic amblyopia, the child actually needs to go strabismus surgery first and needs to be corrected within 8 to 10 prism diopters. There are better results seen in anisometropic amblyopia compared to stimulus deprivation amblyopia. It is the way forward for management of adult amblyopia and younger children. It may not be very effective in younger children as they don't understand the game settings. So a combined approach with patching may be considered in the younger age group, less than 6 years of age. Thank you.
Actually, it's a very nice talk. Thank you very much. But I'd like to ask you a question about studies, because you mentioned it's much better in anisometropic amblyopia. But what about using different types of treatment of amblyopia, like in dichoptic training versus patching, according to the different types, like in after the visual deprivation amblyopia or
I agree with you. So in my personal experience and also in terms of the literature that is available, in visual deprivation amblyopia, to be very honest, none of the treatments seem to work very well. Like, we do not expect the visual acuity to be, we don't expect 100% recovery in the amblyopic eye. In those cases, I think patching would be actually a better option initially to bring the visual acuity to a level where the child can actually understand what a dichoptic is. So if a child is, say, finger counting vision or say 660 vision, we do need to encourage aggressive patching to bring the child's visual acuity to maybe say 636, 618 to about a moderate amblyopia activity. And then we can try dichoptics for that child. Even if it doesn't improve the visual acuity at that stage, it does seem to improve the stereo acuity quite as well.
Okay.
Yeah.
Thank you very much for, thanks again for this nice presentation. And now it's turn to invite Dr. Hayat Khan to tell us what's going on regarding myopia, progressive myopia. And he will tell us the management of myopia progression, current strategies. Welcome, Dr. Hayat.
Thank you very much, my friend, Dr. Jalal. Thank you, Qasimi Group and Dr. Amri for giving me this opportunity to make this presentation in front of the esteemed audience. So let me just see if my screen can be shared. I don't know if it, can you guys see?
Not yet.
So I think I'll have to do it the other way around. So share screen one more time. Are you able to see?
Yeah. Now fine.
Thank you very much. So I think I'll have to minimize this part. Okay. So we are living in an age where there is a huge number of patients coming to especially pediatric eye clinic with problems of myopia, that is short-sightedness increasing over a period of time. I see patients, they start with very small numbers, and within years you see them going at a huge pace. So globally this has become a pandemic, and global prevalence, as you can see, myopia as such is about 30%, and we look at by the year 2050 growing to more than half of the world population. Having said that, the number of people having more than -5 or -6 will be more than 1 billion people. So this is a pandemic. So I'm not going into the detail as what happened in pandemic and how the schools have adapted the near devices and what implication it had. But definitely we have seen since the year 2019 and 20, there is an increase in the progression of myopia in school age children's. If you see between 6 to 13 years, this study, you can see the graphs. There is an exponential increase in the after the home confinement, and following which, if you see, even this data came out, which was quite revealing as how the myopia increased over in the last few years, from 2020 onwards. Now, I'm not going into these busy slides, but I can definitely say there is some amount of evidence which now we are very confident that smartphones, near time, especially kids bringing the devices very close to our faces, having a direct implication in the increase in the myopia. That is the way behaviorally we are modifying our structures of the eye. So the question here is, how do we manage this pandemic? That's the question that I have to ask. So if we go to first, I will go one by one different strategies. First, I'm going on to the contact lens, where I would like to talk about the Blink randomized clinical trial, in which we found clearly that if we are able to have a peripheral raised defocus in front of the peripheral retina, we can contain the myopia, and that has shown to be beneficial in improving the myopia. So the peripheral right rays further focus in front of the peripheral retina if we use these contact lenses, which we give an add of a +3. So that strategy has worked pretty well, and there are very good results which are coming with this soft multifocal contact lenses with high power to slowing the progression. And we found this has come to as a good way in which we can get around. Now, myopia treatment, if I put it all together, can be divided into 5 or 6 different categories. So I'll go quickly one by one. The pharmaceutical category, in which we are talking about atropine. This is the mainstay of treatment at the moment that we are using on a daily basis in our clinics. Pyrazipine and 5-methyl-xanthine can be another strategy, but still under investigation. The results have not been still that confirmative. So for now, atropine is, I'm going to go into detail later, but atropine pharmaceutical therapy children with growing myopia is there. In terms of opticals, we can give spectacles, in which, of course, undercorrection of myopia, a lot of people thought that that can improve, but it came out, no, it does not improve myopia. So we should always give the full correction. Peripheral myopic defocus, progressive additive lens, which I had just discussed with the Blink study, and then executive bifocal base lenses. All these glasses and contact lenses, these are the mainstay. So of course, the soft bifocal dual focus lenses, and lastly, of course, the ortho K lenses, they are very important. So progressive add lenses in glasses, PAL, and bifocal contact lenses with an add of a +3. Both of these strategies have improved the chances of children not growing the myopia by up to 50%. Okay, so spectacles and contact lenses, both are there, different brands, different. There is, of course, this DIMS technology, which is there, which has also very promising results. As you can see, these are glasses. There are different, I'm not taking the name, but there are the different brands which are there. Some of them are not available at the moment in Dubai. We are trying very hard to get them. Some of them are there, and we can use these glasses, and they have some kind stellate little areas of peripheral defocus, which can bring it anteriorly and have found to be very effective. Going on to the environmental factors, very important. So of course, from Dubai context, it is a little hot now, but otherwise, bringing the kids outdoor activity 2 to 4 hours a day can go a long way, especially daylight has found to be very important in controlling the myopia. So a lot of parents ask me, well, if the kids can keep on wearing sunshades all the time, I give them reservations, no, because especially if they are myopic kids, that can be a big problem. And lastly, the behavioral, that a lot of kids bring their the mobile devices so close to their faces that can actually give rise to increase in the myopia. Giving breaks every 20 minutes or 10 minutes, a break of 20-30 seconds where they look far. If they have nothing far, at least close their eyes and give relaxation to their eyes can also go in a long way. And lastly, the most important strategy which I use, that's a combination of all these strategies put together. So I may start a patient with a pharmaceutical treatment of atropine, 0.01%, let us say, and I keep these patients on a continuous monitoring. When I say monitoring, I'm talking about 2 things. Their spherical equivalent myopia as well as their axial lens. So very important that we keep a look at our patient's axial lens. So let's say if somebody has an axial length of 25 at the start of the treatment, we have to see how it is progressing over a period of time. In certain cases where I would like to be pondering and doing a little more research, where I'm not having straightforward onwards, I will also be monitoring the corneal topographies. I may be monitoring their lens thickness also, because all these have a role in playing how emmetropization of eye happens. And wherever there is a defect in this process, that's where myopia increases. So as progression, usually the axial length elongation supersedes the other mechanism, and that's where you get it. Now, just to let all my audience know what is orthoketology, these are lenses specially designed RGP lenses, which are worn overnight to reshape the cornea and thereby temporarily correct the low to moderate myopias. Now, we have changed this. Now I am having the ortho-K lenses, which can go up to not only myopia of spherical equivalent of 5, but even till minus 7.5. But of course, it takes a longer duration for these kids to go completely glasses free. Now, going on different medications, I'm not going in. We're looking at high dose of atropine related to all other different methods of controlling strategies. And these are older, different strategies which were in there, but out of these, not all the strategies were so helpful. And outdoor activities, as I talked, definitely a positive impact. Undercorrection and spectacle lenses, all of these did not really contribute much in decreasing the myopia. So going further in the effectiveness of myopia control, we also looked in different concentrations. And a lot of publications are available where we're looking at different concentrations, 0.01%, 0.02%, 0.05%. And we're looking at what are the help that we are able to get and what will be the best concentration that can be effective. I'm not going much into the detail of ATOM2 studies and the LAMP study, where effectiveness of 0.01 atropine has been established, and importance of a long-term use of at least 3 years of these eye drops in children with practically very, very minimal side effects has established that as one of the key treatment strategies which we are using for now years in our clinic and here in Mediclinic Parkview hospitals. And we're looking at these studies. I'm not going into the details, the study, but of course, the study definitely came out and have given us a way in which we can treat our patients just with the eye drops every night, both eyes. Sometimes I combine this with use of ortho-K lenses. And in those cases, I'm asking the patients to use the drops in the morning, the atropine drops, and I combine to get a synergistic effect of treatment. Now, going further, we always have an algorithmic way in which we process our patients. We see the willingness of parents for the treatment. Once they have, we start them on atropine eye drops. We keep them on every 6 monthly monitoring in which we look at their spherical equivalent refractive error as well as their axial lens. If we get a good response, we would continue till about 12 years age, and then of course keep on tapering the number of how often we are following up these patients. And when of course we see that also when there is the children are 12 years, then of course we continue to monitor every year till we have the cessation of treatment. If these patients have a poor response, then we sometimes think about increasing the atropine dose from 0.01% to 0.02 or 0.05. But problem is it's very difficult to get these different percentages of atropine eye drops. So you have to formulate it, and you have to have pharmacy which should be helping you out in this. So now going further, there are different studies. Again, I'm not going much into the detail and doing the different comparison because of the constraint of time. In today's talk, it's only about 10 to 12 minutes, which I'm almost completing at the moment. So very important to inform about the axial length, that how the slowing of axial length is when we talk about ATOM studies 2 years, LAMP study. And what we found is that 0.01%, we have to think if really it is the correct percentage to improve the progression of myopia. And then of course, when we talk about 1%, it is very effective, but there is a rebound phenomena which we do not want. So when it comes to the axial elongation, sometimes the effect of 0.01% drops have not been so improved as compared to the other concentrations. But that is the one which is at the moment freely available in our hospital, and we are using it, and we are pretty happy over the last 5 years that I've been using. So there are different studies. Of course, as you can see here, I'm not able to see the whole this thing. 1 minute. This is not coming. So there is the MOSAIC study, which is a double-blind, placebo-controlled, randomized trial in myopia progression in children. And what we found is that the myopia controlled, especially in the Asian ethnicity, this was looked in, and this is looking in how well the effectivity and the safety of this 0.01% drop is. And what they found was that the 0.01%, if it can be changed towards prescribing 0.025 or 0.05%, that will, of course, that will decrease the amount of shift in terms of the progression. So we can always look in the Cooper Vision MySight daily wear contact lenses. That can also be another option instead of ortho-K lenses. So in conclusion, in our practice, atropine eye drops along with orthokeratology or multifocal contact lenses are good. Patients where they are not able to use orthokeratology and multifocal contact lens due to age or due to their personal preferences, a good option is to give multi-PAL, that is the progressive glasses, can be there. Of course, a good amount of patient education, family education is key to have good results. And that will go a long way in decreasing the myopia. In the end, I would like to tell that most of the results for 0.01% eye drop usage have been very promising, coming out of different parts of the world. Thank you so much.
Thank you so much, Dr. Hayat Khan. It's a very nice, condensed, heavy meal. Thank you for this presentation. And now let's move to the person I do respect, myself, Dr. Hassan Sabri. We didn't meet long ago, but it's a good chance to meet him again now to tell us what's about sixth nerve palsy.
Thank you very much, Dr. Sam. Do you hear me very well?
Yeah.
Okay.
Can you please start sharing your screen, Dr. Hassan? You'll find the icon down called share screen.
Okay. Share screen. Yes. Okay. Can you see it now?
Yes, now it's fine.
Okay. Clear. That's clear?
Very well.
Samah, is it clear? The screen is clear?
Yeah, very clear, Dr. Hassan.
Okay. I'm asked to talk about sixth cranial nerve palsy, abducens palsy. What I want to tell everybody that congenital abducens nerve palsy is rare. We have to keep that in mind. So when we have acquired case of incompetence dystropia due to abducens nerve palsy, it's a challenge for the doctor and for the ophthalmologist because we want to know what happened. And management starts by first finding and treating the cause. I'll show here 4 cases. This slide will show the pathway of the abducens nerve from its origin in the nucleus in the bones, going out through the pontomedullary junction, over the petrous bone, through the Dorello canal, and then through the cavernous sinus, superior orbital fissure, annulus of Zen to the muscle. It's a long way. That's why it's very susceptible to trauma and bruising, and that's why it's affected in most of the trauma cases. Case number 1 here, it's a child which is 4 years old, sudden onset of right eye crossing since 3 days only, and he was heavy user of smartphone. He was mentioned in the history that he was sliding on a slippery floor a week earlier and vomited and complained of mild headache. His vision was fine, and as you can see in the video here, that he has limitation of abduction in the right and left eye, and up gaze, down gaze, he was normal. This is the optic disc, which shows subtle edema, but when you do OCT, it shows definitely that he has started optic disc edema. So history of trauma with vomiting, headache, sudden onset of concomitant esotropia, possible diplopia, mild bilateral abducens nerve weakness, optic disc swelling. What's next to do is definitely MRI on neuroimaging. And the result came that he has abnormal MRI. There was a hematoma inside. And from that point, neurosurgical interference is a must. So traumatic sixth nerve palsy is very important to consider in a child who's having abducens palsy. Don't think it's congenital. And as I said, the trauma is due to that the nerve is tethered at the Dorello canal. So any pressure will stretch the nerve and causing what we call false localizing sign, because you don't know what happened exactly in the brain. And you have to consider that in your management. Case number 2, it's a lady, 21 years old, student, sudden crossing with diplopia since 1 day only before the visit. Her vision in right side was 20/25, left side was 20/100. So there is a change in vision, but with refraction, she has normal vision. She has also left esotropia with underaction of the lateral rectus muscle in the right and left gaze. And esotropia, when you measure it for distance, 18, for near, it's 9. So a major clue for decrease or incompetence and weakness of the lateral rectus that you have the patient showing some sort of divergence insufficiency. And with the examination of the fundus, the disc is edematous. And also OCT confirms that. So severe headache, incomitant esotropia, double vision, bilateral optic disc swelling. Also you need to go for MRI, which was normal. So the next step is to do lumbar puncture, see stepping to see the opening pressure, and refer to neurologist. They found that the pressure is high and started Sidamex for her to decrease the intracranial tension, and they asked her to reduce weight. So this is another issue that you have to decrease the pressure and consider idiopathic intracranial hypertension in case of normal MRI. And you can see the serial pictures of the OCT shows improvement gradually until she became normal after nearly 1 month. This is the photos of pre and post medication. So elevated intracranial pressure also will push on the nerve and cause a picture of abducens palsy. The same when the pressure is low after tabbing. It will also cause traction on the abducens nerve and cause the same picture. The same happens in children secondary to a variety of underlying causes like hydrocephalus, shunt failure, idiopathic intracranial hypertension, posterior tumor of posterior fossa tumors, venous sinus thrombosis, meningitis. All that will cause abducens palsy due to increased pressure and tethering on the pulling on the abducens nerve. Case number 3 is a patient, 7 years old, diagnosed as a Duane syndrome left eye. But the parents said that she has always taking left face turn, but the deviation increased. Recently, when you examine the fundus, it's normal. This is the patient, and she shows fixation with the right eye, left esotropia in the primary position. She has decrease in abduction of -4, normal adduction of the left eye, normal ocular motility of the right eye. She takes always face turn, and she has very subtle retraction of the eye on adduction. This is her picture. You can see that she has left esotropia, the first turn to the left, and the defective abduction. When we did her MRI, it came abnormal, and she has a tumor in the brain. And also neoplastic case is a neoplastic cause for sixth nerve cranial palsy should be considered when you examine the patient. Tumors account for about 20 to 45% of the sixth nerve in children, either the tumor itself or after surgery. And either it's a posterior fossa tumor or pontine glioma. So brainstem glioma is very common, and more than 80% arise in the bone. And onset is between 5 and 8 years of old, presenting also might include ataxia, disturbance of gait, unilateral or bilateral abducens nerve palsy. The location is very important to consider when you examine the child for sixth nerve palsy. You have to examine him as a whole, and you need definitely a neurologist to examine him also. And as I said, if the tumor in the bones due to tumor, it might be accompanied by horizontal gaze palsy or facial nerve palsy, hemiparesis, hemisensory loss, ataxia, gait disturbance. Case number 4, also another child, 10 years old. She has urinary tract infection and fever, and she came with first turn. There is no history of trauma. And as you can see, she has also defective abduction of her left eye with esotropia. For distance, 25% diopter, for near 16% diopter. So incompetence here is very indicative that there's something with the abduction. And when you examine the motility, there is left lateral rectus muscle under action -2. She takes the first turn to avoid double vision. And that's a picture showing the defect of the abduction -2 or -3. That's why she's taking the first turn. When you examine her chart, she came twice before the same condition. So the patient has 3 incidents of sixth nerve palsy, which is in this case post-viral infection and inflammation. So inflammatory and infectious disorder can cause abducens nerve palsy. Something called Gradinego syndrome, when there is infection of the otitis media that causes inflammation of Peter's bone, where the abducens nerve is closely passing by it, can also cause sixth nerve palsy and facial pain. If you have sixth nerve palsy with other nerve palsies, it might be the infection of the cavernous sinus, which should be also managed properly. So the sixth nerve palsy, most common ocular motor paralysis in adult and second most common in children. And as I said, the patient should be investigated properly to find out what's the reason. The presence of incompetence during measurement of esodiviation is very indicative that there is something wrong with the lateral rectus muscle. And in adults, most of the common causes is microvascular ischemia due to diabetes or hypertension, trauma, idiopathic, but there are other cases, other causes. I got patients with giant cell arteritis, multiple sclerosis, showing sixth nerve palsy. So in the prevalence of associated cranial lesion, the American Academy recommends obtaining MRI for all children presenting with acquired sixth nerve palsy, even in absence of focal neurological findings. So when you have a patient with a benign sixth nerve palsy, you want to wait until he's recovered. So diplopia is very annoying, and you can help him with a prism. You can put patch or occluder of the glass. Sometimes you can use buttocks. But evaluation for surgery after 6 to 10 months of no improvement depends on the amount of residual function of the lateral rectus muscle and presence of contraction of the medial rectus muscle. So when you evaluate, when you decide that this patient will need surgery, you have to evaluate the medial rectus and lateral rectus. If there is good function still of the lateral rectus muscle, you can do resection of the muscle accompanied by either buttocks injection of the medial rectus of the ipsilateral medial rectus or resection of the contralateral medial rectus. But if there is complete paralysis, at that time you need to do what we call transposition. We have various modalities of transposition, okay? And every surgeon prefers some technique. I prefer full tendon transposition with Foster technique. It gives me good results with the patients. But as I said, it's very important to evaluate the medial rectus before doing transposition, because if you have contraction medial rectus, it will definitely not give you a good result at the end. Thank you very much.
Thank you very much, Dr. Hassan, for this sixth nerve dish of salad. I think mixture of etiologies, different etiologies of sixth nerve, but I'll keep my questions till the end for the sake of time. And I'd like to take your permission to start my presentation, please. I just want to make sure if you can see my presentation now or not.
No, sir, not yet.
Is it clear now?
You need to reshare your screen, sir.
Yes. I think you can see now.
Yes, sir.
Okay. So I will talk today about bridging the gap between orbit and strabismus, because in strabismus, most of the time we can see cases presenting with deviating eyes, but the main etiology is almost orbital. So orbital abnormalities account for a small proportion of patients with strabismus, but in cases of strabismus due to orbital disease, it's important to recognize the disorders for several reasons. First, it may be important to do systemic and visual assessment for any consequences of the orbital problem. Second, if we want to do imaging studies for orbital problem, and we should accustom our treatment plan according to the pathology of the orbit. So our main strategies and targets in evaluating strabismus with orbital problem is evaluation of progress, decision of intervention, and how to predict our prognosis of strabismus. So let's go for our first reason of joining or bridging the gap between strabismus and the orbit is to identify the orbital cause. Like in such patients with thyroid orbitopathy, these patients have thyroid eye disease, they come with evident strabismus in the primary position with deviating eyes and other pathologies. So it may come to treat orbital problem first or strabismus first. Then the strabismus can result from some cause of orbital fractures, like the lady on the left, coming after fracture, blew out fracture of the floor of the orbit, of the right one, and left one came with traumatic picture of esotropia. So we have to differentiate, is it sixth nerve palsy or fracture medial wall of the orbit? Or other rare diagnosis is the torn lateral rectus. So it's very, very important to do imaging to differentiate between the causes so we can put our proper plan. Sometimes acquired Brown syndrome comes after orbital inflammatory disease, like this young lady coming with strabismus when she looks up and left after several attacks of orbital myositis, and she recorded some knee pain and rheumatological disorders. So before going for treatment of this strabismus, we should know the cause of orbital myositis and treat it properly if we can. Sometimes the orbital deformities, like this young girl with facial asymmetry. She has right exotropia, but for sure she has significant facial asymmetry that we can consider in treatment of our strabismus. Once more, we can find a different type of facial asymmetry in this lady coming with exotropia after recurrent attacks of deviating eyes, but she reported many strabismus surgeries. But before examination and treatment, we should know she has a deformity or facial asymmetrical changes. After treating facial asymmetry, we can go for proper orthotropia after surgery, but without counseling that patient, she has previous deformity from the start, we can be in a mess of claiming or complaining patient. So how to assess extraocular muscle improvement with orbital disease? Usually we go through strabismus cases with orbital problems in our usual examination strategy, like examination in the primary position to assess our muscle balance. Is it coming with hypertropia, hypotropia, esotropia, or exotropia? This is first. And this will give us a short clue about the deviation in the primary position that we are mainly caring of. So we are just looking at manifest deviations, which is tropia, using Hirschberg test or corneal light reflex test, doing it properly to know the exact angle of deviation in the primary position. Then we can assess the angle, which gives us a clue of improvement or worsening of the orbital disease if we didn't start yet treatment of strabismus. So the angle assessment is not only for correction plan of strabismus, but we can consider in our treatment plan for orbital pathology before progressing to our strabismus surgery. One more parameter we should consider is the limitation of motility, because in orbital disease, usually we have limitation of motility and incompetence. So we have to assess the improvement or worsening of the limitation. Is it coming better or not? And for assessment of limitation of motility, you have to record it first. Is it there or not? Then we have to measure it to consider the proper time to interfere with this limitation. Usually in concomitant strabismus, we use the prism bar to assess the proper angle of deviation of a strabismus using Kremesky test or Kremesky running prism bar test to assess the angle. And we can repeat it again using the modified Kremesky test, putting our prism bar on the other eye to know the difference between both tests. Typically in concomitant or commitant strabismus, they should be the same numbers. So using Kremesky and modified Kremesky test in assessment of the balance, we have to come out with equal numbers if we used Kremesky or modified Kremesky. This is not the case if we have orbital or incomitant strabismus for any reason, either extraocular muscle affection in paralytic strabismus or restrictive strabismus, or other restrictive causes of strabismus like orbital diseases of medial wall fractures or blue out fractures. If we used Kremesky test, we can measure the proper angle in this gentleman, but if we turn to the other eye using modified Kremesky, we'll find totally different numbers. Limitation can be calculated using usual ruler to see how many millimeters the eye can move. And there's a simple way of assessment of limitation of motility in our office. So we just keep the patient looking in the primary position, then we ask him to look at the maximal direction or the restricted direction, and we can measure how many millimeters he can maximally exert effort to move to. One more accurate type of measures is that Kirstenbohm glasses. It's a graded glasses with that balanced watermark in the middle part of the glasses to see how many millimeters, because each line of the distal bone growth equals about exactly 2 millimeters. So we can follow up our patients if he's undergoing treatment for thyroid eye disease, if he's taking injections or radiotherapy or systemic steroids, how many millimeters will improve or will be constant. In thyroid eye disease, it's very important to know the exact numbers he's improving, because we are searching for the Google guidelines that I will tell after a few slides, because one of the signs of improvement of thyroid erbitopathy is improvement of the movement of the eye. Like this gentleman with thyroid or thyroid eye disease, he has limitation of motility. One of the clues that can assess our improvement or worsening is using Hess screen, not for diagnosis of limitation, but just for grading is improving or not. And the very simple test, and I think it's available in many places, we can do a progressive assessment of ocular motility using Hess screen to know is it coming good or not. And we can again assess the secondary angle of improvement of the secondary angle after treatment of different strategies of thyroid eye disease in such patients. One more test is now available. I was trained upon this one in Germany maybe 4 years back, but they are using for a long time that test or Harms-Vand. It's combining the assessment of Hess screen with binocular sensory diplopia if the patient reported diplopia according to limitation, and it can correlate the diplopia measurement in relation to the limitation of actual motor motility, and it can compare his improving on both sensory and motor levels or not. Many publications came out, unfortunately not in English world, but in German and Sweden world, they're coming with new digital methods of assessment of binocular diplopia, improvement with Hess screen and Harms-Vand. Fortunately, we have now in Egypt this method of assessment so that we can follow our patients with thyroid eye disease if they are improving regarding diplopia or limitation or not. The way we do Harms screen is a very simple one. It takes about 20 minutes. And again, if we went for surgery for this patient, we can monitor our progression and improvement of the extraocular muscle motility, like this patient with his left eye limitation before doing surgery, and much improvement after doing strabismus surgery after going for the Lambert curve of inactive stage of thyroid eye disease. Then if he went through this Lambert curve, now he's fine for 1.5 years at least. He will not go for activity again, so we can operate. We can monitor our improvement not only clinically by limitation of motility improvement, but we can use our Harms-Vand and Hess screen to see how much it improved. One of the parameters recorded now in IGOGO of the European Group of Graves Ophthalmopathy Group, they came to put the limitation of motility, pain on movement of the eye, strabismus and primary vision as very, very precious clues in assessment of the scar scoring of the etiology before going for surgery, and to monitor our improvement after giving the proper chance, either preoperatively with steroids or intra-orbital injections, or after surgery after doing muscle recession. So how to assess extraocular improvement? We said identifying the cause, monitoring of improvement, and we can differentiate the paralytic from restrictive. It's very important to know, because mostly after having orbital disease like fractures or thyroid eye disease or orbital inflammatory disease, we can have some restrictive component of the muscle as a consequence of this inflammation or fracture. So we should go for proper history taking and proper examination and imaging when needed. This case is having defective elevation of the right eye. It's defective in all directions, so it seems limited elevation of the right eye. So we can think about all causes of monocular elevation deficiency that may be deadly extraocular muscle affection because of fibrosis of the inferior rectus muscle, or maybe paralytic due to double elevator palsy, or maybe orbital if we have any history of trauma, such a case. But we are luckily having positive Bell's phenomena in such patient, and it's moving very well with forceful closure of the right eye. So there is no limitation or restriction, and it is a straightforward extraocular muscle case of double elevator palsy. So nothing to do with the orbit in such a case. Another lady came with, but now she came with history of trauma after a car accident. She came reporting right hypertropia, defective elevation of the right eye in all directions. And in this case, we should ask for imaging, not like the previous one. Imaging here demonstrated right orbital floor fracture. So we should refer this patient to orbital surgeon to correct for the orbital fracture first. Then we can deal with the hypertropia and the limitation. Another case with severe hypertropia, but now the patient is coming non-thyroid eye disease. So we should arrange our treatment plan and management according to endocrinological intervention, and going for the steady lump curve, then we can go for surgery after that to treat it after dealing with the orbital surgery. One more case of recurrent orbital myositis. She came with acquired Brown syndrome. She's a young dentist. She's reporting diplopia on looking up, and after going for rheumatological treatment and giving intraorbital steroid injection, and improvement occurred, but very limited elevation is there. Limitation of elevation and abduction. Then at that time, we can go for treatment of the limitation by doing surgery for the limitation of by weakening of the superior oblique. Usually I do in Brown syndrome free tenectomy of the terminal fibers of superior oblique tendon. So it's very important to differentiate between the restrictive and paralytic causes of monocular elevation deficiency, because maybe straight paralytic double elevator palsy, maybe Brown syndrome, or maybe congenital fibrosis syndrome, fracture orbital floor, or thyroid eye disease. And we can sort out the cause starting first by force reduction test, or if we have Bell's phenomena, so it's clear double elevator palsy. If it's positive, if it's a limitation of doing force reduction test, or we don't have Bell's phenomena, we can think about other incompetent cases due to restriction, not due to paralysis. This is a case of a middle-aged man coming after aggressive surgery for treatment of orbital mass. It was a cavernous hemangioma, and he had severe proptosis. He went for many orbital surgeries, and he came again after finishing his orbital surgeries with this right hypertropia. And when I did force reduction test for him, it was very tight inferior rectus, and this is his picture after doing inferior rectus recession to relieve the effect. Thank you very much. Now, this was the last talk, but it's open now for anyone of you if you want to ask any question regarding the topics. I remind you with our prestigious speakers, Dr. Delon, Dr. Hayat Khan, Dr. Hassan Sabri, and myself. If anyone of the audience wants to ask any question regarding our presentations.
I have a question for thyroid patients.
Yes, please.
If you have restriction for inferior rectus, for example, so do you go directly for the surgery, or you just treat him medically first and then you plan your surgery?
Usually I wait for the Lambert curve, because if the patient, I am just following the guidelines of Igugu, they have the scar scoring. If the patient had a score of 3 or less, so now he's in the steady stage, so in a quiet stage. So if it's in active form, like then conjunctival hyperemia, pain on movement of his eyes, recurrent redness, changing the diplopia angle, changing the strabismus angle, changing limitation of motility on frequent visits, so I should never go for any intervention till he's in the Lambert curve. If he went through the Lambert curve, I'm sure if he had a score of 3 or less, now I'm quite sure he will never go through another attack before 1.5 years. So this is a proper time I can do my strabismus surgery.
So it takes time.
Yes. And it's very variable from one to another one, because it may take a few months, then may take years in some people.
Yep. You're absolutely right. Okay. Thank you.
Thank you. Dr. Hassan, I want to ask you again regarding sixth nerve palsy, because if you have a case is presented with neglected sixth nerve, So when you decide to do surgery for it and you found your force reduction test is positive, so it's quite evident we have contracture or limitation due to medial rectus contracture. Would you like to consider doing transposition surgery in whichever form, like Janssen or Hummelsheim or Nishida or any other transposition, and with the medial rectus recession, or you start with medial rectus recession first, then you consider transposition in a second intervention?
Actually, I didn't face such a problem before because I always don't wait for a long time for a patient to be neglected. If I decide to do surgery after 12 months from his incidence of sixth nerve palsy, I try to let him avoid contraction of medial rectus. But I do prefer to treat the medial rectus contracture first. If I have a chance to give buttocks, I give the buttocks injection and see how much the lateral rectus will move, because sometimes contracture itself will give you a false appearance of severe lateral rectus weakness and abducens palsy. So treat contracture first with buttocks or recession, and then manage transposition as a second stage. I do prefer that.
Okay, thank you very much. I'd like to ask Dr. Hayat Khan for using atropine in the dose of 0.01 or 0.1. Do you monitor in your cases the cycloplegic effect? Because usually it's written in literature, the 0.01 or 0.1 is a non-cycloplegic concentration of atropine. So do you face any patients complaining of accommodation problem after using this low concentration of atropine or not? Dr. Hayat,
busy.
Okay, so I don't think he is with us now. So any other one of the audience wants to ask any question?
So do you use atropine 0.01 or what do you use?
Yes, I use 0.01, but actually I didn't face any patient complaint, but with 0.1, some patients complained of accommodation problems in my cases.
For how long?
Usually according to the patient, but usually it's not more than 1 year at least.
Would that be enough to stop the progression?
Yeah, usually I follow. Actually, very few cases I use with them, but most patients go around doctors. So many of them disappear.
Okay.
Dr. Sameh, if you don't mind, we can conclude. You're already 10 minutes over the session.
Okay. Thank you very much. The conclusion
Thank you for you, Dr. Sameh, Dr. Hassan, Dr. Hanover, and Dr. Hayat. Thanks for all of you. Thank you very much.
Thank you, Dr. Muhammad, and thank you for all the speakers. See you again in other meetings.
Inshallah.
Inshallah. Thank you. Bye.
Assalamu alaikum, Dr. Muhammad.
Assalam wa rahmatullah. We can start directly, Dr. Safwan.
I will be the director, right?
Yes, please.
But I don't have the names of the doctors.
You can go to the scientific program in the scientific, please, page available. Okay, I will share with you. It is in this.
Just share it with me. I was calling you and asking you just because
it is available in the system. Dr.
I know that it's available in the system. Okay, so we can start. Good evening, everybody. This program will be the refractive session number 1. And we will start with the PRK. It's traps by Dr. Mahfoud Ittihadi. Please, Dr. Mahfoud.
Dr. Mahfoud Al-Hadi, he is not here now. We can go to another one till he join, please.
So who is available? Dr. Abdurrahim. Okay, Dr.
No,
Abdurrahim.
And Dr. Hasna is available, second talk.
Second talk. Okay, Dr. Hasna. So PTK and cross-linking in keratoconus, when and how? Dr. Hasna. Please, Dr. Hasna. Dr. Hasna?
She is recorded, please.
Ah, okay. So Dr. Hasna will show us the PTK and the cross-linking in keratoconus, when and how, recorded presentation. Please start.
Dr. Hasna, can you hear us, please? Hello, Dr. Hasna? Okay. Management, can you stop share, please, and give the chance for Dr.
Dr. Abdurrahman. Dr. Abdurrahman
Yes.
here.
Okay. Hello, everybody. How are you?
Okay. Dr. Abdurrahman, he will tell us about smile in daily practice, my ups and down. Please,
Okay.
Dr. Abdurrahman.
Is it okay?
Yeah, just share
Can
your
you-
presentation.
Are you seeing my presentation or not?
No,
not
you
yet,
need to
Dr.
share it.
Abdurrahman.
Okay. 1 minute, please. Yeah. Mhm.
Did you put your presentation on the desktop? First, put
Yeah.
it on the desktop and then
Yeah.
share.
Yeah, first. I think it's okay now, no?
But we are
Is it
not
okay?
seeing your presentation.
Mm-hmm. She's working, but
Okay, we can move, I think, to Dr. Mahfoud Hadi. Mahfoudi, you are there, Dr. Mahfoud?
yes.
Dr. Mahfoud here?
Yeah, they are all here. Anyone who's able to share screen, so we will not lose the time, please. We can go with Dr. Francisco. Can you share screen, please?
Hello, everybody. Thank you for the invitation for this prestigious meeting. I will share my screen. Okay, can you actually see me?
Yeah.
Yes.
We can see you.
Okay, so let me just try and remove this. Perfect. And
We have 15 minutes delay till
No
now.
problem. Okay.
Yes, Dr. Francisco, please, if you don't mind, just start.
okay, good morning, everybody. I think it's good evening out there in the UAE. I'm going to talk a little bit about post-LASIK ectasia, and the talk that was given to me was when the wind blows counter to what the ship wants. I'm from Brazil, I'm from Rio. I'm a refractive corneal and cataract specialist. And so let's begin. There are some things that what do refractive surgery and saline have in common? Basically, we have the seawater that we need to understand how it works to understand flotation of the boat, and we also have corneal anatomy. We need to know how cornea works if we want to do surgery. I'm having some trouble with some of the animations. I don't know exactly why. Is there any other presenter that can move on? Because I tested it before and I didn't have any issues. It will be probably 3 minutes for me to fix this.
3 minutes.
Yeah, 3 to 5 minutes. Is there anyone else that can take it? Because
Doctor,
I'm scheduled for the last
Abdulrahman, you can try again.
Yes, I will try again. Okay.
Can you stop share, Dr. Fernandez?
Is it okay?
Yeah.
Yeah.
Yes, Dr. Abdulrahman, if you can try to share the screen.
Yes, I'm trying to share again.
Yes, it's okay now.
I see my presentation? No?
No, we see the Zoom. Please, first of all, the things that you need to open the presentation itself, then share screen, then select it. Yes,
It's okay
now it's
now?
okay. Yes.
Okay, good. Thank you. Thank you very much. Thank you, everybody. Hi. So I don't have video. It's my video. Yeah.
We can go ahead, Dr. Abdulrahman. It's okay.
Yeah. Okay. So I will speak with you about my SMILE activities and in daily practice and ups to down. And for beginning, I will tell you about some words about SMILE. That's the first SMILE was performed by Zeiss 40 years before, and it's now considered to be the third generation laser treatment method after PRK and LASIK. And the main difference lies in the absence of a corneal flap cutout, and corneal integrity is thus more respected. So this is how to do a SMILE. And one word about the corneal innervation that is superficial in the cornea. And when we do LASIK or PRK, we obligatory touch the corneal innervation. And SMILE, action of SMILE is deeper than innervation. When we do a good SMILE, we are deeper than corneal innervation. And also when we are opening the cornea, we have only less than 4 millimeters. And LASIK, we have more than 20 millimeters for opening. So SMILE is better for integrity of the anterior part of the cornea. And we can now take account the new selection criteria. So for PK, all body were those okay, all okay. That's abstain for patient who will have a residual cornea less than 400 microns for PK. And for LASIK in the same, 100 flap and 300 for corneal posterior wall. But with SMILE, we can leave only 250 with posterior wall. That's why we can leave the total cornea, residual cornea, 350. And that's why we can do more myops and until 10 dioptry and until 5 ciliand for astigmatism. So let's one word about surgery. Surgery must be more predictable. And the main things, the main idea is how to identify the superior lenticle and the posterior lenticle. To identify the interface is very important for beginning and to be successful in SMILE. So these are the steps, and this is a SMILE of me. This is my own method for surgery. I start beginning my SMILE for opening the anterior plane. And after that, I attack the posterior plane. And after that, I come back to the anterior plane and start dissection slowly through the cornea. And I progress carefully through over the lenticle, and I can go through the limits of the lenticle for the anterior plane. And after that, you can start with the posterior plane, and and here you try to be only in the center to let the lenticule on place until the end, and after, in the end of the interval, the surgery, you can go to through the lenticule, and with the forceps, a special forceps, not very thin, but a good one, you can remove the lenticule. This is the perfect smile for me. And if dissection of the posterior plane is performed first, we have more difficulty to find the anterior plane and dissect it, and it will increase trauma to the cornea and cause complications. Here, for example, an early discovery of the false plane. Here, I think that I am on the anterior and then posterior, but during surgery, I realized that I was in false plane, and here as I start to dissect the anterior plane. So before I was in the posterior, and here you have always to begin with the anterior. It's more easier. And sometimes we have a late discovery of the fast posterior plane and the anterior plane. If we start surgery and we can stop and look for the anterior plane, like here, and after that it will be more easy to do the same work every time. And if we have no possibility of catching the anterior plane by anterior way, we can catch it with the Sinski instruments, and we can catch the anterior plane by posterior way. And after that, we can remove here the lenticule with the forceps, capsulorhexis forceps, in one like this. Huh? Okay. So let's see some tips and tricks during surgery. Here is my bimanual technique. I can take my lenticule with the left hand, and with the right hand, I can remove the lenticule. Yeah. And this is the capsulorhexis-like technique. If the lenticule is still attached in one side, you don't have you have to not to do this, but you can take the forceps and to go in the other side with the capsulorhexis, like capsulorhexis during cataract surgery, and it will be more easy to and here for my beginning and for the beginner, we can make the differentiator with the titanium instruments, and we can make once on the anterior and the second in the posterior, and in this way we can understand where is the anterior and the posterior plane. So something that we can have, management of loss of suction. It depends when we have its loss of suction. First step or second part of surgery. Here, there one case from one man, 30 years old, minus 350 and minus 250 myopes, and astigmatism 150, normal cornea, nothing. And here we have the femtosecond laser, who is acting with Visumax 500. And all thing is okay. First step, it's okay. The posterior plane is okay. So when he starts the section on the anterior plane by femtosecond laser, in the end of the surgery, we have the conjunctiva who comes there. So no panic. We are surprised, of course, with this incident. So we can to check the nomogram and to check all the specificities, the diameter of cornea, and we can do flex. Flex is the same that it's like smile, but it's like circle. We do like LASIK. So the femtosecond here, and sorry, yes, the cutting is here. And so for surgery, we consider that we are like smile. Huh? Donc we do surgery. Of course, it's more easier to maintain the lenticule on place and to do surgery like a smile, to avoid to go through the incision. And after that, you can do surgery easily, like here, and remove the lenticule in the end of surgery. Here you are seeing, you can, through the lenticule, completely detached, and you go like LASIK. Here are the parameters, and the result post-op 10, 10, 10, 10, and 1 month post-op and 3 months post-op. Excellent results. So the main idea is to succeed with SMILE in invited to recognize both planes of the lenticule and to prevent intraoperative complications. We must adopt the same strategy to dissect the lenticule from the center to the periphery. The use of the same technique during SMILE surgery is a safe and effective method. It must be reproducible for all cases. So let's see some clinical cases. Here we have minus 27 years old, minus 6.25, and 10 to 10 after SMILE. And this one, pachymetry 527, and good keratometry. In this case, we have 25 years old, minus 9.50, and 2-cylinder astigmatism. And the other eye, 6.75, and 2-cylinder astigmatism. You see the result is 10 to 10 here, down. Excellent results. The patient is very happy. This is the keratometry preoperative, 521 and 413. This one, 31 years old, minus 3.75, mounting 475, little astigmatism, and 10 to 10 after surgery. And this is a thin cornea, 452, only 452. And after we have 383. And the patient is very good, very, very, very happy. And this one, 46 years. And here we do a presby SMILE vision because we have dominant eye is the right. And the result is 10 to 10 with 9 to 10 with this correction, and the patient is very happy. This is the cornea before, thin cornea and become thinner, but the patient is very happy with this presby SMILE. So when we analyze, SMILE has a lot of advantages for precision refractive, for comfort, the patient, for dry syndrome, and biomechanic. Benefits as PRK and LASIK, wider optical zone, comfortable technique, no pain, fast recovery, no induced aberration, no burning smell, fast evening high myopia, using only one laser, no ACE, no hood issues, no interface syndrome, preserved by biomechanics and less dry eye. Limits requires perfect centering, requires an efficient manual dissection technique, less effective for irregular astigmatism, no topo guide treatments, not yet, no cyclotorsion except with VisuMax 800 SMILE Pro, no treatment for hyperopia except with VisuMax 800. Retouching by after PK LASIK, we can do circle or wrist SMILE, or PK, of course. The high cost of the procedure compared to PK or LASIK. How to optimize your SMILE? Achieve good refraction preoperatively. Minimum.
Dr. Abdurrahman, إذا سمحت لي دكتور عبد الرحمن, please, if you don't mind, 2 minutes more.
Okay, so I finish.
Please, if you don't mind.
Achieve good refraction preoperatively. Minimum energy allows faster visual recovery. Expert mode program is essential to clearly identify the anterior and the posterior plane. If decision to retouch, review the first surgery, help choose the technique to use. In conclusion, for me, it's Relax SMILE is the third generation refractive laser, and it's indicated in the first intention. We have to respect the contraindications. LASIK and PRK for certain specific cases, thin cornea with irregular or asymmetrical cornea, and do not treat the patients are at risk. Thank you very much for your attention, everybody.
Great, thanks, Dr. Abdurrahman. I think that we will move to my presentation. So I will present the lenticular extraction, smart SMILE. And please, Abdurrahman, just stop sharing if you don't mind. Okay. And I will share.
Is it okay?
Yeah. Yes. Now it's clear?
Yeah.
Okay. So I need to thank Dr. Muhammad to give us this opportunity. And hopefully that we can match the time. And I need to thank Abdurrahman that he makes my journey easier. And few things to comment that cyclotorsion is not present in VisuMax Pro 800 till now. So let us see, it will be announced soon, but it present only, the only one is Atos Schwintamar. So I will start with the Smart Smile 2023 Atos. And I will start with this movie and will show you what's the effect and the importance of the points that Abdurrahman showed in Relax Smile 500 that present here now in this machine. This is MS39. The registration is a pre-register with a full registration. So start with MS39 registration and centration. And then all the information will be transferred to the machine. That information mainly is the registration. So here, the importance of the centration. The green cross is the eye and the yellow cross is the machine. When matched, we will start with the torsional eye track system active. And that's why when we are saying that we can correct astigmatism, it's correctable up to -5 with the lenticule started definitely posterior and then anterior, as Abdurrahman mentioned. And then removing the lenticule was showing a lot of changes with easier and nomogram that gives the best outcome and recovery that will be real within 24 hours, because mainly centration. So if we will go to what's present now as an advanced technology, here we have the Atos on the left, and we have Pro 800 from Visiomax, and we have the Z8, and also we have it's just, sorry, the Elita, and Elita is not in the trade till now, but soon it will be in the trade. So if we will go to, as what mentioned by Dr. Abdurrahman, it's a painless surgery, high precision. The visual rehabilitation with the new, with our machine start to be almost equal to LASIK. So we can ensure the patient that he will have a good visual acuity post-op, and that's because of the centration, less coma, no need for a neural adaptation, less invasive than LASIK because there's no cut, better corneal biomechanic stability than LASIK, and that's shown by Dr. Abdurrahman, and we are running study shows depend on Corvus and comparing the PRK and the Smile, and shows that they have the same CBI post-op comparing to the LASIK, where it's the CBI is strongly effective. Less dry eye than LASIK, that's sure, and no flap-related complication, and there is wide optical zone. Now we are reaching up to 7.5, and the new software, it will reach to 8. Now I'm sorry that I need to move to see what's only one laser technique. And if we will go to the second, the centration, and as I said that the centration and track system is one of the advanced that announced in Atos from Schwint, that can correct and can exactly correlate the visual axis to the center of the optical of the lenticule that will be removed. And that movie shows, it's a real movie, shows how I'm reaching and targeting the center. Here I start to start the vacuum, and you can see that the green cross is not matching the yellow cross. because of the rotation. So the eye rotated, and this patient have a high astigmatism, minus 4.5, and it will be shown in the case that will be presented. So here we have two circles, the red circle and the yellow circle, and we need to target the yellow circle where we will be within 200 micron from the center, from the visual axis. So the rate of the post-op induced coma will be very low, and that's what I will show you. And the other things is that the periphery of the lenticule is 0, so this will it will control the post-op spherical abrasion, and it will not increase the existing spherical abrasion. Instead, in my cases, it's reduced, and I'll show you in the higher order abrasions for the same case. And that's the case. It's a high astigmatism, -2 myopia with -4.5 on 170 with the rule, and it's been treated in a precise, and you can see here, with this high astigmatism, with this platform, we could reach to -0.250 astigmatism because of the centration and track system. And here, the high order abrasions, you can see the pre-op high order abrasions, and here I'm highlighting the coma from 0.35 to, I think that it's a 0.4. I need to get out of the site. Yes, the coma was 0.35 to 0.4, and the spherical abrasion from -1.7 to -12. So it's reduced. So what's outlook in our side? The main issues is that hyperopic lenticule and the software for the suction loss. In spite of the presbyopic correction and hyperopic lenticule is the new software that will be announced once the Visiomax announced the hyperopic, because they have the right to announce it first. But what's the complication that Dr. Abdulrahman mentioned it in the suction loss? Sorry. Now, in suction loss, what we are doing, Abdulrahman shows that we can open the flap, or we can do a PRK, creating LASIK, opening the flap, or changing the nomogram. The nomogram change because when we don't have centration and track system, if we will duck again, we are not sure that we will return back to the same site, so we cannot do it immediately. That's why it needs time, and that time it was taking 3 months or 1 month at least, and changing the cup thickness to change the position of the lenticule, or changing the optical zone to change the thickness of the cup of the lenticule in a way that the surgeon will go to another dissection. But what's in our condition? We don't need that, because the centration is the same. So I can go immediately to the same nomogram. Immediately means that I was in the first case waiting for 1 hour. Now I don't need to wait for 1 hour. Now there's a software. That software will go to the points where we stop, deduct few seconds, and it will return back to that point and continue. But till now, I'm using 1 hour difference between the suction loss. This is the case, and this is a real time where I did the posterior, and then I start with the anterior. Unfortunately, patient was hesitate, and you can see the bubbles on the right side. Anterior started, and then suction loss. Then immediately we took the high resolution suction of MS39. It shows that the suction goes only on the posterior, and there was no even visualization to the anterior suction. So 1 hour later, when the bubbles disappear, I start again on the same nomogram, the same centration, because I went to the center of the visual axis, and to the same centration, I start and I did it. And you can see, this is a real time again, posterior, anterior, still the patient is moving. And then the side cut, here I used 3 millimeter. And then, as Abdurrahman mentioned, that we are starting with the anterior. I mark the anterior, then I mark the posterior here, separating it. But I prefer to go through the anterior first, as Abdurrahman said. I have a spatula that have a smooth surface, and the margin of it is a little bit widened. So from the periphery to the center, to the side periphery, and then posterior, here central, as Abdurrahman said, so in a way that I would not lose the flap, the lenticle, sorry. And then when I'm sure that the lenticle is start to be free, I have micro tying gauge 23 going through and remove the lenticle, then showing it. And here I'm showing the full peripheral part of the lenticle in a way that it's removed in circle 360. And this is 1 hour after the surgery. And that the high resolution suction post-op immediately. And great thanks for all. Now, is anyone ready to give his, I think that Hasna is ready, Dr. Hasna? You are mute, Dr. Hasna?
I'm here.
Yeah. Yes, my dear, Yalas, you can start. I will stop sharing, sorry.
Stop sharing
yeah, I will stop sharing. Just wait for me. It's unfortunately. Yeah, it stopped sharing, Mike. You can share. You can put your presentation and you can share. Is your presentation on the desktop?
Yes.
Okay, just press on share screen. The green button. The green button down. There is sharing screen.
Yes, I need that.
Okay, Dr. Hasna, we need to save the time, so we can go to Francisco if he's ready. Francisco, you are ready? Francisco, please unmute all the speakers, just to unmute, please. Francisco. He's not listening. So, Dr. Mahfouz? Dr. Hasna, you didn't find the sharing screen, my dear?
See, I find this, but I try to share my screen.
Yes, there is a button, green button down.
Oh, hello. Hi.
Yes, Francisco, if you are ready, just please share your presentation and start.
I can't hear you.
Okay, just wait. But I'm unmute. You cannot hear me?
Yeah, I don't have the share screen. I don't have the share screen either. It's not here.
Why? Dr.
No,
Muhammad.
it's not showing.
Dr. Muhammad.
Okay.
I think.
You don't have in your Zoom share screen?
No, I'm listening to you, but the button for sharing is not here anymore. I think I need to be authorized.
Okay, and Dr. Mahfouz also, he's not here?
Okay, Doctor, can you have one of the management, please, to help Dr. Hasna or Dr. Francisco how to share screen? Okay, Doctor, are you able to see down? Can you go down? Click down. So you will see there participant chat, screen, share screen. Can you see that or not? It will be disappear. Just click any place, put your icon any place, click on the, then you will see, yeah, any place in the screen, then you will see something down showing.
I can see the.
Yes.
Yeah, but the button is missing here.
No, it never can be missing. Maybe it's somewhere. Okay. Can you please do one thing? Can you go out and come back? Please just leave and come back. Yeah, disconnect. Okay, leave and and disconnect. Who is still there?
No one.
Francisco, can you hear me?
Yes.
Okay.
Okay, now.
Okay,
now
Dr. Hasna is now is good. Okay, Dr. Hasna, you can go ahead, please.
Yes, yes, Dr. Hasna.
You see my
yeah. You can click down. There is a TV-like button down. Just I can see it now.
Yeah,
down,
I can.
completely down. Dr. Hasna. Okay, you can start, Dr. Hasna. Okay. Okay. Anyone from the management, please, you can take over. Okay, now, please.
Done, sir.
Okay. They will click for you, please. You can go and tell next, they will click for you.
Hi.
Can you please raise your voice? Can we hear you, Dr. Hasna, please?
Do you hear me?
Yeah,
yes,
yeah,
we are hearing you. Please, you can start. Yes.
I can start. Thank you very much. Sorry for this. I'm very happy to be with you. I have no financial disclosure for this presentation. Keratoconus is a bilateral, non-symmetric and non-inflammatory progressive corneal dystrophy. Cross-linking is a minimally invasive procedure used for the stabilization of corneal ectatic disorders such as keratoconus. In this speech, we want to share with you our primary results for a prospective study with simultaneous topo-guided PRK and accelerated corneal processing. Our study is about 8 patients, 14 EAs, aged between 25 to 35 years. We only choose keratoconus stage 1 for the beginning, and the diagnosis is based on pentacam and the OCT. The keratoconus must be stable, and the pachymetry is higher than 450. The treatment was topo-guided transepithelial
or as you said, I don't know, 20 or.
And with maximal ablation.
Please, everyone can mute himself except Dr. Hasna, please. Everyone mute himself. Okay. Please,
our patient was treated by topo-guided transepithelial PRK based on pachymetry and subjective refraction. The maximal ablation was 60 microns. With the simultaneous, in the same time, we do accelerated corneal cross-linking, 10 minutes of riboflavin and 10 minutes of UV exposition. Our results was very nice because the uncorrected best visual acuity was less than 510, and it's between 510 and 1010 after surgery. The corrected best visual acuity was best after after surgery, and the subjective refraction is less than before. The astigmatism is also less, and we have flattening of the cornea with the mean keratometry between 26 and 42. The pachymetry also is less after surgery. The means on postoperative pachymetry was between 340, we add 400. And this is topography of patient before surgery and after surgery. We show flattening of the center of the cornea. And the second case also, we have flattening of the center of the cornea after surgery. Follow-up of our patient is from 6 months to 2 years. No complication, also 2 cases of haze, and including one with impact on visual acuity, loss of 2 lines of visual acuity. In cases of keratoconus, foot ablation was long time contraindicated, but there is many studies that show that there is no progression after treatment by PRK. That is improvement of visual acuity without worsening of ectasia after PRK on non-progressive stage 1 and 2 keratoconus. And there is improvement of keratoconus, and this is in 25 as is treated by PRK alone. PRK alone improves visual acuity, keratoconic indices, no worsening of ectasia. Is this protective effect of PRK? Is this a protective effect of PRK? The hypothesis is that PRK induced inflammation that stabilize the keratoconus. Propagated PRK is based on corneal topography, corrects cylindrical refractive error with normalizing the corneal profile by smoothing the corneal surface. PRK can correct 70% of refraction with the maximum stromal ablation between 50 and 80, and with the minimal residual stromal depth of 340 to 400. Corneal cross-linking can be classic or accelerated, can be simultaneous or sequential. There is no difference between all protocols. Combined PRK with cross-linking is the only corneal refractive treatment authorized in keratoconus. Several protocols are reported in the literature, but all the protocols have effective results. This is a meta-analysis of a French paper. There is 4 protocols of combined PRK and cross-linking with little differences between based on use of mitomycin, conventional or accelerated cross-linking, or the area of the treatment. We can combine PRK and cross-linking with other treatments when visual acuity is not satisfactory. The goal is to improve visual acuity as much as possible. We can associate it with the intracorneal ring. Classically, we begin by the intracorneal ring, and 6 months after we can do topographic PRK with corneal cross-linking if the patient didn't have before the cross-linking. We can also combine with phakic IOL to optimize the refractive result. We start with the intracorneal ring, followed by PRK and cross-linking. Then, when the visual acuity is insufficient, we can put phakic IOL to treat residual ametropia. The paper say that combined PRK and cross-linking is a safe and effective method to increase the visual acuity in the keratoconus. This treatment is for keratoconus stage 1 and 2, stable or evolutive. The objective and subjective refraction must be possible, and the patient have an insufficient visual acuity or intolerance to contact lens. Pachymetry must be greater than 450, and we can use this treatment even for the refractive surgery on suspicious cornea. This is the technique. This technique can be done when we have a stable keratoconus, or we have unstable keratoconus when the visual acuity is unacceptable. What about mitomycin? Very divided opinions. Some authors do not use it. Others use it routinely saying that mitomycin will prevent the onset of haze and reduce its intensity. The mitomycin modulates the healing process by blocking activation and proliferation of keratocytes. In cases of combined PRK and prosecuting, there is no relationship of haze for pachymetry or the amount of ablected stroma. So motors don't use it because the cross-linking in the anterior stroma reduce the number of keratocytes and therefore they reduce the haze. Sequential or simultaneous treatment, there is no consensus. Someone say that it's more effective to combine the treatment in the same time, and others say that there is no difference between combined and sequential treatments. Different studies show that is agreed that is a safe and effective method. It's give best quality of vision and stabilize the keratoconus. The effective, the maximum change is in the first year, then the parameters remain stable even after 10 years. The improved quality of life of the patient, and there is no specific complication reported by the authors. We can find classic complication of PRK, such pain, sterile subepithelial infiltrate, haze, epithelial healing delay, infection, dry syndrome. This French meta-analysis posted 9 studies that show that is the most frequent complication is the haze, usually spontaneously regressive. In this study, there is no complication. In conclusion, this is a safe and effective method. It's the only corneal refractive treatment of the keratoconus. We can use it when we want to do refractive surgery for high-risk cornea. Can be combined with other surgery, but we don't know what is the long-term development because the turnover of the stroma is very slow. Before ending, I want to invite you to our congress in Marrakesh. It will be by 2 languages, French and English, and also for the Mayom and pressmen. Thank you so much, and sorry for the problems.
Thank you very much, Dr. Hasna, for this excellent presentation. You make it very fast. I know you are running fast to give us a space of time, but it's comprehensive and very nice presented. Maybe we'll keep some questions at the end of the presentation. If we can have Dr. Francisco, if you can share your screen now. Is it okay now? Is it able for you to share?
I think so.
Okay, please. Yeah, we can see yours, please.
Okay, so my name is Francisco Bandeira. I'm from Rio, Brazil. I'm going to end the session of refractive surgery talking a little bit about the topic that no one wants to talk about, post-LASIK ectasia. When the wind blows counter to what the ship wants. So I myself, I like a lot sailing. So I thought of this lecture to be more basic, with basic concepts. So what are the things that refractive surgery and sailing have in common? So for instance, to understand how boat flows, we need to understand the seawater, the depth, as much as we need to understand corneal anatomy, the layers, the cells that are within it, and the tissue interaction that the laser will have with it. Much like the oceans, we have a lot of refractive errors. So we can travel at different seas, which have different particularities, and we can have safe travels within a certain range of refractive errors. And we might get into some trouble if we try to venture ourselves in more tough refractive errors. Regarding the ships are much like the refractive laser suites. So the technology of the ships also evolved, and our technology for refractive surgery is continuously evolving as well. But the most difficult thing to understand about sailing is how the wind works. And for refractive surgery, I think that we do have a similarity with corneal biomechanics. This is the most difficult thing for us to understand. And that's where the complications of ectasia lies. So for a surgeon, we are the ship's captain, right? So we need to ensure patient safety. We need to understand the diagnostic exams as much as the captain needs to understand his boats, understand the ocean that he's traveling along with, and all of the items that will make a safe travel. And both of us need to have deep knowledge of our expertise. Sailors, they use specific tools to navigate and to make a safe travel and to reach their destinations, like compass, rulers, navigational charts. We as surgeons, we also use a lot of instruments. We need to understand the corneal thickness, we need to understand corneal curvature, and now more than ever, corneal epithelium and corneal biomechanics. But we also need to have a plan. It's not just understanding the exams, understanding the impact of surgery and what actual surgery will fit to each patient to customize the treatment that we are actually offering. So is post-LASIK ectasia important? That's a question that I like to ask. The incidence of ectasia for LASIK is very low. In this recent paper by Morsvar, he shows that it's less than 1%. For PRK, it's even less. And for SMILE, it has been shown similar ectasia profiles to the PRK. So why is this important if there's so low incidence of this complication? The problem is what we're offering. What are the demands of our patient? Patients want to be satisfied. So they want to get out of the surgery seeing. It's a performance surgery. They don't want to see well for the first 3 weeks and then have a vision that will deteriorate. So we need to be responsible and we need to ensure visual quality. And we also need to continuously research to improve our results and have a safer profile for these patients. So here's where I think the surgeon and the sailor, they do have to be very, very responsible, and they have to know what they're doing when the situation changes. How do we manage unpredictable situations? The sailor, if he faces a storm, he will need to know what to do. And if we face a corneal ectasia, we also need to know what to do. Ectasia, I think this has been talked over and over. It's a biomechanical corneal failure with several findings, ultrastructurally and biomechanically. Basically, it's a deformation that will result in poor vision. So how do we do to not have an ectasia? First, we need to understand the risks, the risk factors, and to stratify them and to see which procedure can we do for these patients. Second is how do I diagnose ectasia? What are the findings that we have to look for? What do we need to pay attention to? And lastly, the treatment. If we are facing an ectasia, what can we do? How can we help these patients? So first thing is do no harm. We've learned this from med school with Hippocrates. And the first published papers come back to 1998 with Seiler. He had 3 cases above 10 diopters, and the residual bed was below 250. And then we understand a little bit more about the post-LASIK ectasia in patients that don't have a normal cornea, form fruus keratoconus, for instance. And later on, Professor Ambrosio, my colleague, and Stephen Wilson, they suggested a residual bed limit. And further, more recently, Santiago also talked about the percentage of change in tissue. These things, they will affect and increase the risk of corneal ectasia. So what exactly are the risk factors for ectasia that we have identified so far? Corneal weakness is one of them. Inadequate corneal thickness, thin corneas, incorrect technical surgical technique, thick flaps, excessive ablations, and intrinsic factors. We know that younger patients, they tend to have more risk of ectasia, patients that have uncontrolled allergy and itching, family history of keratoconus, and pregnancy is also a risk for LASIK ectasia. Well, if we compare the surgery of sailing, the misconceptions that we have about refractive surgery are the ones that can blow a ship off course. So we need to understand the surgical impact of all techniques to navigate the waters of refractive surgery smoothly. What do I mean by that? So it's the performance of LASIK is unbeatable. It's like a modern cruise ship. It gives the best results within the shortest period of time. But we cannot travel all waters with femtosecond LASIK. For PRK, it's an older boat. It's the first technique. It gives us better results, but it's not as comfortable as a modern cruise ship. With Smile, we can travel into different kind of oceans. We can adventure ourselves a little bit more with a more comfortable situation. But we also have the phakic IOLs, which will be the submarine. With the submarine, you don't have to worry about tides. You don't have to worry about the wind. You are sheltered. But you can't always do phakic IOLs. For instance, in shallow waters, in shallow chambers, you cannot use phakic IOLs. So certification risk is crucial for us to decide which technique we are going to opt for our patients. And we do have several tools with artificial intelligence. I won't focus much on this because it's too specific. But I want to show you that these tools we can use to rule out which surgeries we can do and avoid ectasia. So this is what I want to show. These tools are freewares. They are available online, and you can actually stratify your risks quite simply with these platforms, and they will give you some idea of which kind of trouble you will get into if you decide to do a LASIK for some kind of patient or a PRK. We don't have this for Smile yet. I don't think the developers and researchers are working on this yet, but it's quite simple, and it gives you an idea, and more than that, it gives you information that you can share with your patient, and you can put him on board about his risk situation. So this for me is it's quite important that the patient will understand that some surgeries will put him at risk. But once you perform the surgery, you also need to know what's happening. Where are you after surgery? How do you know if you're getting an ectasia or not? So this is my rationale for maintaining your ship on course. First thing, you need to emphasize the importance of adherence to follow-up schedule with your patients. I always tell them that they need to check the retina forever until they do their cataracts. So they will need to come at least once a year. Risk counseling and complications. If you decide to operate a patient that has a strange cornea or maybe a borderline situation, they need to understand that maybe they will need further interventions, and they might suffer some visual loss. You also need to have a program. You need to schedule these visits and monitor patient progress. If you see some changes, some different things in the exams, you don't need to keep up with the previous scheduling. You can shorten, you can reduce the space between consultations, and always try to get a corneal exam, tomography, topography, pachymetry maps, if you have the chance, because you don't know when these patients are coming back. And more importantly, if you see these changes—
1 minute, please, to conclude, if you don't mind.
I'm almost at the end. So, so when you are following these patients, the first thing that will show is the increase in myopia and astigmatism, and you will also have changes in keratometric findings, in pachymetry and elevation maps, and more recently in biomechanics. So, if you face a storm, the goal is to stay alive, right? We do have some options, but none of them are currently meet patient primary needs. We have corneal cross-linking, which we can associate with refractive surgery, PRK or PTK. We have contact lens, but they're not free of risks, and patients do want surgery to get rid of the lens. ICRS, accuracy is not so good. They require minimal thickness. There is risk of extrusion, and they do have some side effects. Corneal grafts, I don't even want to go down this way because it's the worst thing that can happen, and we don't want that for patients. More recently, we can add tissue, and there are some studies coming up that this might be a better solution for corneal ectasia. So my take-home lessons for post-LASIK ectasia are that refractive surgery is a high-performance surgery, and the expectations are really high. Determining risks and disclosing them to patient is, to me, the most important thing when dealing with borderline cases, high myopias. And if we decide to go along with these high-risk profile patients, they need to be on board. They need to understand the situation. And we need to make sure that these patients don't get lost along the way. So we need to keep calling them. You need to have responsibility. I think this is what I had to say. Thank you for this invitation. And that's it.
Thank you very much, Dr. Francisco. This is very nice and excellent presentation. And your matching between the sailing and the refractive surgery, ectasia, it's a great cooperation between them. So I think Dr. Al-Hadi is here, Mahfouz Al-Hadi. Okay, I think we need to we have another 4 minutes. I know we are 15 minutes after our timing, but we will take 4 minutes, so they will start in 8, the next sessions. If there is any question from anyone of you to another one, so for example, any question from Francisco or Hasna to Dr. Abdurrahman, he was talking about SMILE with Dr. Safwan. Dr. Hasna, she was covering the keratoconus, and Dr. Francisco, he was talking about post-basic. So any question from anyone to another one or not?
Yeah, the first one is, did you have any ectasia cases with SMILE?
No.
Okay, man.
Yeah, no. I am a SMILE user from 10 years now, but I never have the ectasia. No, because perhaps I do good indication. Perhaps
yeah, sure.
I got good seller. Yeah, no ectasia, no ectasia in my hand.
Okay. Dr. Hasna, you have any questions to Dr. Abdurrahman or to Dr. Francisco? Unmute yourself, please, Dr. Hasna. Okay, any question about keratoconus to Dr. Hasna? Dr. Abdurrahman?
This was very nice.
I think most of you are satisfied with the presentation for everyone. So I think we need to conclude our session. I would like to thank you all, Dr. Abdurrahman, Dr. Francisco, Dr. Hasna, for this excellent and comprehensive talks that you present in different diseases in cornea and refractive. And also thanks for Dr. Safwan. He left already because of some things that he wants to do. Thank you very much, and we'll see you inshallah in another session. Thank you, Dr. All of you. Thank you. Bye. Thank you to Francisco, Hasna, and Abdurrahim. Thank you. Bye-bye. And now I will handle the mic to AbbVie, I think, Symposium, Dr. Karina. Please.
Good evening. Thank you so much, Dr. Mohammed, for your kind invitation, and thanks to AbbVie for organizing this symposium on dry eye. And I will start sharing my screen because I know we are already late. Okay, I think you can see it. So wait a minute.
It is down, please, down. There is an icon down. You can, yeah.
Yeah, here.
One, yeah, that one, yes.
Okay, so again, thank you so much for this invitation. As you might know, I am not coming from cornea. I am an uvea specialist, and the more I know about dry eye, the more I feel this disease is going to be like the most common inflammatory eye disease, although this is surface, this is inflammatory eye disease, but it's part of inflammation the more we know about it. So what's the problem with dry eye? Dry eye has a global prevalence that can vary from 20 to 50% worldwide. And it's involving now not only older individuals, as it was at the beginning, but also office workers and high school students. And this is mostly related to our changing lifestyle with the incorporation of digital devices in our daily life, and also with the extending practice of refractive procedures, as you were just talking about. There is also importance of dry eye associated with autoimmune diseases, and we know more and more autoimmune diseases with the advance in medicine, with hormonal changes, and with systemic drug therapies. Dry eye disease has a marked negative impact on the physical and psychosomatic well-being of patients, with depression, anxiety, and stress being reported in the setting of dry eye disease. And you can see here two references, one from Korea with an association between dry eye symptoms and suicidal ideations, and the other one in a cohort also from Asia of patients with depression. And many of these patients were suffering from dry eye disease. So the problem is expanding and it's involving different subspecialties apart from ophthalmology. Dry eye disease has a substantial economic impact, the management of these patients. The average annual direct cost of ophthalmologists managed care of one patient with dry eye disease can go from $270 in France till $1,100 in the UK. And here we are not taking in consideration the loss of work productivity by these patients. In the US only, the annual direct healthcare cost of dry eye disease is around 4 billion, while annual loss of productivity can reach to 55 billions. So what's the definition of dry eye? The first definition comes from 1903 from Schirmer, and he was pointing towards the concept of tear deficiency. He was the one who described the test for tear production. In 1933, this concept was even enlarged, and we were talking about conjunctivitis sicca, which is a marker of acute tear deficiency. For many years, this was the definition of dry eye disease. In 1995, the National Eye Institute talked about dry eye as a disorder related to deficiency of production of tears or excessive evaporation, which causes damage to the interpalpebral ocular surface and was associated with symptoms of ocular discomfort. And here many concepts are being introduced to the definition. In 2006, the Japanese Dry Eye Society talks about a chronic disease of the tear film and the keratoconjunctival epithelium associated with ophthalmic discomfort and abnormal visual function. And this is a very important incorporation in the definition, because we know that now we know that dry eye disease is an important cause of of low quality of vision. For the Japanese Dry Eye Society, the diagnostic criteria were assessment of symptoms, qualitative or quantitative disturbance of the tear film, and keratoconjunctival epithelial damage. So we can see how the definition is evolving till the present one from the Tear Film and Ocular Surface Society Dry Eye Workshop in 2017, defining dry eye as a multifactorial disease of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play a etiological role. So here we can see the complexity even from the definition of the disease. So tear film instability and hyperosmolarity has a key role in the disease, and it will increase the ocular surface inflammation. This inflammation will cause ocular surface damage and further neurosensory abnormalities that will result in turn in even less tear production and more tear film instability and hyperosmolarity. And this is like a very simplified way of showing the vicious cycle of the dry eye disease. Back in times, we used to differentiate clearly between aqueous deficient dry eye and evaporative dry eye. In aqueous deficient dry eye, we have all those conditions affecting the lacrimal gland function. These patients, they cannot produce enough tears. While in evaporative dry eye, what we have is an increase in tears evaporation. This can be related to problems in the eyelids, for example, meibomian gland dysfunction or problems related to blinking, or related to ocular surface, for example, contact lens related. However, we know that many of our patients are in between, and we have a group of patients, a majority group of patients falling in the evaporative dry eye group, and a minority in the aqueous deficient dry eye, but we have patients in the middle where it's not very easy to classify them in one category or the other. Regardless which is the etiology, our management is oriented to restore the homeostasis of the ocular surface. In this flow chart, you can see that whenever we have a new patient, a patient for dry eye, it's very important to understand if there are symptoms or not. Symptoms are a key part of the diagnosis of dry eye. If the patient is asymptomatic, but still we find signs of ocular surface disease, we can eventually decide to treat the patient. For example, a patient who is going to have refractive surgery. We know that it's important to manage the ocular surface before the refractive surgery procedure, or even before a cataract surgery, without refractive purposes. If the patient still is asymptomatic and we find signs of ocular surface disease, we can question the presence of neurotrophic conditions that produce a dysfunctional sensation of the ocular surface and still start treating this patient. In the case of symptomatic patient, whenever there are symptoms and signs, we are going to consider this as a pure dry eye patient, and we will start the treatment. We will start managing the patient. But if there are symptoms and no signs, this can be neuropathic pain. And maybe this patient is suffering from neuralgia, for example, and not from an ocular condition. If there are symptoms and there are no signs, we can try a treatment for the patient and see if the treatment will improve these symptoms. But again, the management is aimed to restore the homeostasis of the ocular surface. What about the epidemiology of dry eye? It's complicated to find clear data for the epidemiology of dry eye because of a failure for standardized definition and diagnostic criteria. Most of the studies are coming from Asia and Europe, and we have few data from south of the from the south of the equator. The prevalence of the disease with and without symptoms can vary from 5 to 50%. We know that Asian race is a risk factor for dry eye disease, and most of the knowledge is coming actually from Asia. We know that symptomatic disease and signs of dry eye will increase with age, that women will be naturally more affected than men. And for risk factors, we have 3 categories: consistent risk factors for dry eye disease, probable, and unconclusive. The consistent ones are related to age, sex, race, the presence of meibomian gland dysfunction that we will see further in the presentation. It's a very important problem in dry eye disease. Connective tissue diseases, for example, rheumatoid arthritis or any rheumatologic disease, Sjögren's syndrome, androgen deficiency or estrogen replacement therapy, contact lens wear, extended computer use, hematopoietic stem cell transplantation, environmental conditions like pollution, low humidity, sick building syndrome, and use of medication. For example, antidepressant or isotretinoin. Refractive surgery, interestingly, is here as a probable predisposing factor. Although what we see in our daily consultation is that patients who underwent refractive surgery, they have more symptoms and more signs of dry eye disease. Dry eye disease occurs more frequently in women than men, and there are numerous sex-related differences identified already in the eye. The ocular surface is not the same in a woman than in a man. And this is mostly related to androgens. Androgens has an important role in the regulation of the ocular surface and the ocular anexa. Whenever we have androgen deficiency, we will have lacrimal gland dysfunction, meibomian gland disease, the development of both aqueous deficient dry eye and evaporative dry eye. Still, we do not know the prevalence and severity of dry eye disease in youth and children. Still, we don't know ethnic differences in the development of the disease, the impact of modifiable risk factors, like, for example, electronic device usage or face mask. We have witnessed an increase in symptoms and patients' consultations during COVID times with the use of face mask, and the impact of climate and environmental and socioeconomic factors. And for this, I think we are in a very privileged area of the world because of our work, of our weather conditions, and because of the extensive use of electronic devices we have here in the Middle East. About the pathophysiology of the disease, the key point here is the evaporation-induced tear hyperosmolarity. This tear hyperosmolarity, for different reasons, it will cause direct damage to the ocular surface, and it will trigger inflammation. Inflammation itself will produce inflammatory mediated damage to the ocular surface. And this is the very classic vicious cycle representation, where we can see the key role of evaporation. This evaporation, this increased evaporation of the tears could be related to low flow, which means the lacrimal gland is not able to produce enough amount of tears, or high evaporation, increased evaporation. Why? Because the tears are not stable enough, probably related to meibomian gland dysfunction. But whichever is the initial insult, it will result in tear hyperosmolarity, and tear hyperosmolarity will start the vicious cycle involving inflammation, globed cell and glycocalyx mucin loss, epithelial cells damage, apoptosis, more tear film instability, and more tear hyperosmolarity. So what about aqueous deficient dry eye? This is the pure aqueous deficient dry eye is the minority of the patients with dry eye, but these patients still, they are there, and if you are practicing, for example, along with the rheumatologic practice, you will see a lot of these cases. It's mainly related to an inflammatory infiltration of the lacrimal gland, and this is the cause of the decrease in the production of tears. This is what we usually see in autoimmune disorders, for example, rheumatoid arthritis patients. Another important cause, as I said before, is low tissue androgen levels that may cause secondary lacrimal gland inflammation, chronic abuse of topical anesthetics, trigeminal nerve damage, and refractive surgery procedures, mainly LASIK. The other group, the larger group, is related to evaporation of the tears, and the most important, the most common cause is meibomian gland disease. Whenever we address meibomian gland disease, we have two different scenarios: cicatricial versus non-cicatricial meibomian gland disease. In cicatricial meibomian gland disease, we have a submucosal conjunctival scarring that drags the meibomian orifices, the terminal ducts, and the mucocutaneous junctions posteriorly. Here we have a common example, which is trachoma, but also in uveitis, we see many times ocular cicatricial pemphigoid, and these are the two classic examples for cicatricial meibomian gland disease. In non-cicatricial meibomian gland disease, which is the most frequent presentation, we have a hyperkeratinization of the terminal ducts. We know that after the age of 50, there is a physiologic dropout of meibomian glands, regardless cicatricial or non-cicatricial, and this is what we call primary meibomian gland disease. Also, if there is a fall in bioavailable androgens, we will have meibomian gland disease. Very important and very common in our practice here in UAE is the treatment with cis-retinoic acid, which cause meibomian gland atrophy and meibomian gland disease. The use of glaucoma medication, mostly topical timolol and pilocarpine, is a common cause for meibomian gland disease, and skin disorders like acne rosacea or psoriasis. What will happen to these meibomian glands whenever they are affected for these different factors? There will be a decrease in the meibum delivery, and most important, a change in the lipid composition of the meibum. Tear film will become non-stable with increased tear evaporation and then the evaporative dryness. There will be inflammatory changes around the affected glands, and we will see these signs of inflammation at the lid margins. And these inflammatory changes will make the glands to produce inflammatory mediators. And these inflammatory mediators will, with altered lipids, abnormal lipids, are going to be released into the tear film and onto the ocular surface, producing further epithelial damage and contributing to the inflammatory component of dry eye. It's very interesting because years ago, we were differentiated between aqueous deficiency and evaporative dry eye, and inflammation was associated to aqueous deficiency. Now we know that inflammation is present, whatever the primary etiology is for the dry eye. In the tear film and avoiding tears evaporation. And this main layer of a mix of mucous and aqueous, where all the inflammatory and the growth factor mediators are in. This mucoaqueous layers is in close contact with the glycocalyx from the epithelial cells, and it's very important to have homeostasis of these layers to preserve the cells that are beneath. So how we evaluate meibomian glands? We have the meibomian gland disease questionnaire pointing towards discomfort, pressure sensation, dryness, foreign body sensation, burning sensation, redness. The most common clinical evaluation is the tear film recap time that I think we all do during the consultation. There is a way of measuring the tear lipid layer thickness with the ocular surface interferometer. We can see the appearance of the meibomian glands at the slit lab examination, evaluating irregular lid margins, presence of telangiectasia, plugged gland orifices, or mucocutaneous junction shifts. It's important to evaluate the quality and the quantity of the meibum, the secretion of the tear of the meibomian gland. It's important to register if we have clear cloudy or cloudy that can be expressed after more than moderate pressure, or even no meibomian expression with hard pressure over the eyelid. This is a very interesting device to put it in evidence meibomian gland loss. It's infrared meibography, and you can see here in A, the appearance of normal meibomian glands, while in D, we have atrophy of the meibomian glands. I don't have experience using this device, but I feel it's a very useful one in measuring objectively the atrophy of these glands. For the meibomian gland disease diagnostic criteria, as per the meibomian gland disease working group, we need lid margin abnormalities and signs of meibomian gland occlusion in order to diagnose meibomian gland disease in dry eye. How to treat meibomian gland disease? Traditionally, we tell the patient to use warm compresses, eyelid hygiene, and eyelid massage. If there is an associated infection, we can go for a short term of topical combination of antibiotic and steroid ointment. We can perform intraductal meibomian gland probing, lipid flow thermal pulsation system to improve but short course, oral supplementation with omega-3 essential fatty acid in order to improve the quality of the meibum, and cyclosporin A 0.05% topical in order to address the inflammatory component that is frequently present. This is a very interesting medication. We do not have it here, and I don't have experience. Its name is diquafosol. I don't know if any in the audience, they know this medication. It is available in Japan, for example, and the diquafosol sodium will stimulate P2Y2 receptors present in the conjunctival epithelial cells, in the conjunctival globate cells, and in the meibomian glands. So these receptors are present in the three main components for the production of a healthy tear film. So in theory, because as I said, I don't have experience on this medication, it will increase the fluid secretion from conjunctival epithelial cells. It will increase mucin secretion from conjunctival globate cells, and it will increase lipid secretion from meibomian glands. So it will improve, in theory, the three layers of the tear film. Another way of treating meibomian glands is the intense pulse light therapy, IPL. This treatment will need at least 3 sessions. There is significant improvement after the treatment on the quality of the meibum, on the expressibility of the meibomian glands, the lid margin abnormalities, the tear film breakup time, and the ocular surface staining and the ocular surface disease index. We know that whenever there is inflammation because of dry eye, the cytokines in the tear film, they change, and there is an increase in pro-inflammatory cytokines. After this treatment, they saw a decrease, they witnessed a decrease of many pro-inflammatory cytokines. And for example, interleukin-6 and TNF-alpha levels correlates with meibum expressibility. So if the quality of a meibum changes, it will be easier to being expressed and being discharged onto the ocular surface. Another interesting medication is revamipid. This medication, if we use it systemically, is used for the treatment of gastric ulcers and lesions associated with the gastritis, because the medication can increase the production of gastric mucins. So when it is topically applied in the form of a suspension, the medication increases corneal and conjunctival mucin-like substances and improves corneal and conjunctival ulcers. Again, I don't have experience with this medication. I think it is in use mainly in Japan, but apparently can improve signs and symptoms of dry eye disease and can improve also other ocular surface disorders like superior limbal keratopathy and persistent corneal erosions. A very interesting point in dry eye is pain and sensation. It's very common for us to hear the complaint of the patient with dry eye as pain in the eye. And pain in the eye and in dry eye disease is actually transmitted through peripheral axons of the trigeminal ganglion neurons innervating the cornea and the conjunctiva. There is a subepithelial nerve plexus whose branches ramify within the surface epithelial layers. Functionally, these sensory nerves belong to three different neurons: polymodal nociceptor neurons, pure mechanonociceptor neurons, and cold thermoreceptor neurons. And we can see here how ocular surface dryness and ocular surface inflammation will stimulate both of them, polymodal nociceptors and mechanonociceptors, that will stimulate pen sensation, tearing, and blinking. Ocular surface dryness will also stimulate cold thermoreceptors with the same results, but interesting, ocular surface inflammation will block these receptors, and this we do not understand clearly, which is the role of ocular surface and the interaction with these thermoreceptors. However, we know there is organic pain related to dry eye, and pain can be nociceptive, which is the physiological pain response following the activation of nociceptors at the level of the striatum on damaged tissue. For example, there is dryness, so these nociceptors will be activated at the level of the ocular surface immediately in response to dryness. Then, if the stimulus is persistent enough on time, there will be neuropathic pain, which means an abnormal neuronal excitability with decreased pain threshold and hyper-responsiveness to the stimuli. The patient will feel much pain than we expected for the ocular examination we are performing. And finally, if the process is long enough in time, there will be neuropathic ocular pain, which means pain can be generated from secondary and tertiary neurons that connect the ocular surface to the brain. This means pain without the stimulus, and this is something very important to keep in mind because at this stage, the pain is more difficult to be treated. So dryness is a cause of eye pain and should be managed medically. Finally, inflammation in dry eye disease. We have seen through the previous slides that inflammation has a central role in dry eye disease. Inflammation both triggers and results from chronic dry eye disease. It's important in early patients to look for an underlying inflammatory component, to rule out Sjögren's syndrome, to check for graft versus host disease in cases of patients who have been submitted to transplants. If hyperosmolar stress on the ocular surface triggers the release of inflammatory mediators, among them interleukin-1 beta, TNF-alpha, and matrix metalloproteinase 9, which we can measure in the Inflamma-Dry test. This is a qualitative way of measurement the presence of this ocular surface inflammatory marker and to support even more the need to treat this patient not only with artificial tears, but with topical anti-inflammatory medication. Several agents can be used to target inflammation in dry eye disease. There is an important role, an important response to topical corticosteroids. However, we know that topical corticosteroids is not a medication we can keep for a long time. And then we have non-corticosteroid.
Dr. Karina, if you don't mind, we are already over the time, if you don't mind.
Well, I will try to finish.
If you can conclude, please.
So we have cyclosporine and lifitegrast. Cyclosporine has been shown here to improve the quantity of the tears and also the symptoms of the patient with a very fast start of action of the medication, with 73% of the patient feeling better symptomatically in the first 1 to 3 weeks. Finally, I will not take more time to talk about iatrogenic dry eye. This is just a representation of how we use diagnostic test for dry eye and how we can differentiate between evaporative and aqueous deficiency. And the most important thing is to keep in mind where is the problem and try to orient our therapy towards the most affected tear film layer in the specific patient. Take-home messages: dry eye disease is a complex, multifactorial socio-medical condition. The understanding of the fundamentals of dry eye disease is constantly expanding. New diagnostic tests are needed to evaluate some aspect of the disease, such as, for example, the presence of nerve dysfunction, and individual patients should be subcategorized in terms of underlying pathophysiology and clinical severity, and their treatment should be tailored with objective tests used to follow therapeutic response. Thank you so much for your attention.
Hello.
Yes.
Hello.
Hello.
This is Hossam Ziada. Assalamu alaikum.
Yes.
Actually, it's at the time of the session one, the cornea session, right? Dr. Mahmoud, ازي حضرتك؟
اهلا وسهلا دكتور حسام وعليكم السلام.
فندم, this is the time to start this. Dr. Hamid Amri, how are you?
السلام عليكم دكتور حسام، شو اخبارك؟ دكتور محمود، مساء الخير.
اهلا وسهلا، مساء النور، ومتشكرين يا
سعيدين
دكتور
بوجودكم معنا، شكرا جزيلا.
شكرا يا باشا.
الله يبارك فيك.
شكرا يا دكتور محمد، الله يكرمك.
الله يعطيكم العافية. I will check Dr. Usama to join, please. 1 minute.
So he's joining, so.
Sit. دكتور رئيس، أخبار حضرتك إيه؟
اهلا وسهلا.
أخبار حضرتك إيه يا فندم؟ عامل إيه؟
ازيك يا حسام باشا؟
الحمد لله يا فندم، والله بخير خير. يعني سعيد إن أنا مع حضرتك النهارده، وبنشكر دكتور محمد يعني إن جمعني مع حضرتك النهارده.
تعيش يا حس يا جامد.
الله يكرم حضرتك يا فندم.
اخبار الشغل ايه؟
الحمد لله رب العالمين، تمام.
كانوا بيقولوا لي منى عايزاك تشد حيلها شويه في موضوع المؤتمر بتاع يناير بتاعنا.
You can hear me, Dr. Majdi. You can
اوكي،
start.
هو انا بس منتظر. انا سالت الشركات اللي هم كلموها، قالوا لي ان لسه ما فيش اخبار منهم. لكن
تمام.
انا اوريدي متواصل عندنا، ومتواصل مع الانترناشونال سبيكرز. هم عاوزين واحد او اتنين، فانا رتبت يعني في متاح بيكون معانا دكتور مازن، ويكون معانا نمارتا
السلام
شرما
عليكم.
from India.
السلام عليكم.
اتفضل يا
السلام
فندم.
ورحمة الله.
خلاص يا
دكتور
أهلا
نانسي،
دكتور
ازي
حسام.
حضرتك؟
دكتورة
عاملة
نانسي،
ايه؟
مرحبا، كيف الحال؟
الله أهلا وسهلا، كيف
دكتور
الحال؟
أسامة شوية he's having some little bit delay. 1 minute he will join us. So we don't want to be late. If you don't mind, we can have the first talk. I would like all to welcome you to the cornea sessions on behalf of Dr. Osama. Welcome Dr. Nancy, Dr. Mahmoud Ismail, and Dr. Hussam. And I think we will have also Dr. Bernardo Cavalotti. He will join us soon. So if you don't mind, please, we will start with Dr. Hussam, and he will give an overview of infectious keratitis. The floor for you, Dr. Hussam. Thank you.
بسم الله الرحمن الرحيم. Thank you so much, Dr. Muhammad Al-Amiri, for your kind invitation to be with these great cornea surgeons, my professors and my dear colleagues everywhere. So I will share my screen.
The screen already shared, Dr. Hussam. You can just make it in a play or in a.
Okay.
Just make it on slideshow, please.
It's okay now?
Yes.
So the session today is about the microbial keratitis, and all of the speakers will cover all the points related to this issue. So I will start to run over the entity, which is still one of the difficult and controversial and debatable up till now. So we'll start first with the corneal ulcer definition. It's a discontinuation of the normal epithelial surface of the cornea and associated with necrosis of the corneal tissues around this defect or around this inflamed area. It could be bacterial, like in the hypopyon ulcer, fungal, viral, protozoal, or there are a lot of other causes of corneal ulcers, but not infective, so I didn't include. The risk factors could be the contact lens, wearing cases of the fungal or and I will mention occupational ulcers, which maybe are working in the field of where there is a lot of corneal foreign bodies, and they are behaving very randomly and very wrongly. They are dealing with these foreign bodies by their selves. So they are coming to our clinics very late with a lot of the mixed corneal ulcerations or infective keratitis, I mean. Trauma with vegetable matter, it's one of the close signs and risk factors which will lead us to think about the fungal keratitis, especially the woody and vegetable foreign bodies or injuries. Immunocompromised diseases, one of the risk factors, especially the uncontrolled diabetes, especially also the other patients on steroid therapy or immunodepressing drugs, they are more prone to get this infective keratitis. I said now the diabetes, especially the ankle, and the hot topic. All the world congresses are talking today about the dry eye disease and ocular surface disease and their importance in relation to the refractive issues, also the infective keratitis issues. So we have to take care and to pay our attention to the ocular surface disorders. Also adnexal disorders, like the dacry cystitis, lid problems like the chronic blepharitis, especially the ulcerative blepharitis, also the leg of thumbs. So we have to take care and examine our patients very thoroughly and carefully to define these risk factors. And finally, the hygiene, which is very as well. The common positive agents and bacterial ulcers could be the Staphylococcus aureus. I arranged them in this order according to this. Then Pseudomonas Streptococcus pneumoniae, E. coli, Neisseria gonorrhea, and the Clearmtheria. In the total filamentous or yeast, filamentous like Fusarium and Alternaria, Penicillium, and Aspergillus. There are a lot of viral keratitis types, but the most common, the herpes simplex virus keratitis, which is known as epithelial keratitis or herpetic or dendritic ulcer. The herpes simplex virus type 1 or the protozoa, and most common cause is the Xanthamiba keratitis. The pathophysiology, mostly in the all types of the invasive infective ulcer, infective keratitis, but it will be referred here as a bacterial pathophysiology. There are 4 stages for the corneal ulceration. The first stage is the stage of progressive infiltration, where there is a huge number of lymphocytes infiltrating the epithelium and the subepithelial layers with necrosis of the surrounding tissues, and the start of necrosis in the stage 1, then stage of active ulceration. After the necrosis is going more and more around, there is a defect in the anterior part of the cornea, including part of the stroma and the epithelium, where there is a stage of the active ulceration. Grayish infiltrates with circumcorneal hyperemia, hypopium formation, and the smatocyl in the advanced stage or advanced moment of this stage. Then the stage of regression, if there is a good and proper control and treatment of this ulcer, it will not complete to be complicated with a perforation or other disastrous complication like the corneal melting, and it will regress at that time with the phagocytosis, and then the ulcers begin to heal. Finally, the stage of cicatrization, which is the end of this corneal ulcers, especially in the deep ulcers, which is not treated early and properly with the cicatrization. Epithelium covers this ulcer, and then the formation of scars and opacities elsewhere in the cornea. There's an example for the bacterial ulcer, which is commonly called the hypodefinite, is not a special sign for the bacterial ulcer, but it's actually one of the commonest presentation signs with the bacterial ulcer, but it could be with the fungal and with other corneal ulcers. But as you see here, there's diffuse infiltration with epithelial defect, with circumcorneal hyperemia here and hypopyon, but it's not apparently clear in this patient. The pathophysiology in the fungal keratitis, you will find severe inflammatory response around this cold patch of the cornea with the stromal necrosis, which is always silent necrosis. Usually we don't expect we cannot predict the perforation in the fungal ulcerations, but definitely as we know, the most commonly perforating ulcer is a fungal ulceration, unfortunately. Filamentous fungi can penetrate the intact Descemet's membrane, so it's very I mean that the filamentous fungi are more strong than the other types of the fungi, so it can penetrate very. The common presentation are the common symptoms in the bacterial, fungal, and the viral keratitis. You will find pain, except in the viral keratitis, you will find in advanced stage of the viral keratitis, you will find that there is corneal anesthesia, which is one of the close signs to differentiate the viral keratitis from the other types, to examine the corneal sensation. But the pain is a hallmark in the bacterial and fungal keratitis. Also, the acanthamoeba keratitis, but there is here a very important sign. You will find that there is complaining and from very severe pain, but when you examine the cornea, you will find no insignificant infiltrates in the peripheral part of the cornea. So you will deny first that there is a problem related to the or other types of infective keratitis. All types blurred vision, especially if the ulceration extends to the central or the paracentral part of the cornea. Discharge in the bacterial and the fungal, but the viral keratitis, you will find a watery discharge. Foreign bud sensation in all types, watering in the viral, and redness in all types. Science is a little bit different between the four main types of the viral keratitis. In bacterial keratitis, you'll find the swelling of the eyelids, blepharospasm, conjunctival chemosis, hyperemia, ciliary congestion, grayish-white circumscribed infiltrate, yellowish-white oval or irregular area of ulcer. But here, as I sign them by these lines, the hypopyon and corneal perforation is late signs. Also, the endophthalmitis, if the infection extends to the inner part or to the inside of the eye. In fungal keratitis, you will find that there is dry grayish-white stromal infiltrates with elevated roll-out margins. So the fungal keratitis is different than the bacterial and some expressions, as the fungal is more silent than the bacterial. The eye is not angry in fungal like in the bacterial keratitis, and it's one of the deceiving signs. Elevated roll-out margins, satellite lesions all around, infiltrates around the main ulcer, yellowish-white infiltrates, dense separation, which is somewhat viscous than what could be found in the bacterial. Also the hypopyon, as I said before. In the viral keratitis, you will find punctate epithelial keratitis, one of the presenting signs, there is punctate epithelial erosions, early sign of the dendritic ulcers, also geographical ulcers in immunocompromised or mistreated ulcer, misdiagnosed and mistreated with the steroid. Virus-laden cells at margin of ulcer stained with rose bengal stain. So the dendrite stem line will be stained with the fluorescein, and the virus-laden cells at the edges of this dendrites will be stained with the rose bengal bengal stain, and this one of the signs to differentiate between the dendrite of the herpetic keratitis and the dendrite of the pseudo-dendrites of the traumatic ulcerations. Also reduced corneal sensation, as I mentioned before. The protozoal ulcer, you will find that there is irregular and grayish epithelial surface with epithelial pseudodendrites. And so you have to differentiate between the viral and the protozoal in this case, that the viral could be somewhat mid-peripheral or central, superior or inferior, but the protozoal is commonly present around the temporal periphery of the cornea, as I saw in many patients. Focal anterior stromal infiltrates with radial keratoneuritis, which is the cause of the severe pain, which is unmatching with the clinical signs you may find in the cornea. Enlargement and coalescence of infiltrates to form the ring abscess. Here, I have to say that the ring abscess could be present in both hypopigmean ulcer and protozoal ulcer, but it will be different in the onset before the ring abscess. You can differentiate between both of them by the history. Between them. Sclerites may develop, yes, and the corneal melting
Dr.
and stromal necrosis
Dr. Hussam,
at the end.
if you don't mind, the time is crossed more than 20 minutes, almost. If you can conclude, please.
Okay. The slides are not moving now. There is some technical error, I mean. Yes.
From your side, just click next. Okay.
So I will skip all these slides because I have described them in the table. Geographic ulcer, satellite, grading of the corneal ulcer could be mild, moderate to severe according to the size of the ulcer itself, from 2 millimeter to 5 millimeter in the moderate and more than 5 millimeters in the severe. Depth of ulcer, it's not important here. You will find that the grading of ulcer, grade 0 if there is no aqueous flares, grade 1 if the mild, grade 2 in moderate, and grade 3 in severe. So I will finish with this slide. The treatment will depend upon the diagnosis. The bacterial, you will start with the topical antibiotics according to the culture and sensitivity. But until you get the culture and sensitivity results, you can start with the broad spectrum antibiotics, or you can guess what's the expected organism in this ulcer. We'll start with the ciprofloxacin, vancomycin, ofloxacin, and the moxifloxacin. Oral antibiotics will help in the infiltrating ulcer and severe form. Also, we can aid our patient with the mydriatics to relieve the pain, like atropine and cyclopentolate. Topical steroid, at the end, after complete treatment of the organism, I can decrease the scarring with a topical steroid, but under control. In the fungal keratitis, removal of the epithelium, but could be cautious in such step. and it needs medical legal controlling issues. Topical in the filamentous, you will start with natamycin, iconazole, amphotericin B, or miconazole. In the candida, the natamycin also okay, but iconazole is more effective than the others. You can start topical and inject subconjunctivally, and also systemic antifungals with itraconazole and voriconazole. Here I will say some important point. We have to take the decision in the proper time to shift from the medical treatment to the surgical intervention. If there's no response and you are worried about this cornea to perforate or to go in melting, you have to take the decision to do therapeutic keratoplasty in such patients. Also, the varikeratitis antiviral topical and systemic as well. I'm going there
because we are very late, more than 25. It's 12 minutes. Just thank you, please, if you don't mind.
Thank you so much. Thank you so much.
Sorry, Dr. Hassan, but it's too much. Too long. Okay, sorry.
I'm sorry. I'm sorry for that. Thank you so much.
Thank you.
Thank you, Dr. Hassan. That's very good, comprehensive cover. I know it needs a lot of time to cover all aspects, really.
Yeah. Okay. Okay. Actually, it's hello.
Yeah, نسمع فيك. Can hear you.
Yeah. Okay. Yeah. Overview about the microbial keratitis is very big intensity in the cornea. So it needs a very long time. Yes. Okay.
Yeah, but it will help.
I'm sorry for.
But would help other speaker to go straight to the subtopic now. So our next speakers will be recorded. It's Dr. Bernardo Calvanti from Brazil. He is the president of Brazil Society, but he will present a recorded talk. We can play the talk, please.
Good evening, everyone. My name is Bernardo Cavalcanti, and I would like to thank the invitation to be presenting here. A really interesting topic. There is acanthamoeba keratitis. I have no financial interest when I'm going to presenting today. I would like to acknowledge two very important people concerning my work on acanthamoeba, which is Dr. Pedro Hamra, which is my mentor for all the confocal studies that I have performed, and also my really good friend, Dr. Denise de Freitas, that helps with all the practical part and challenging cases that we see every day, and she's the professor of the Federal University of São Paulo, Unifesp. Acanthamoeba keratitis was first described in 1973. It's a rare infection with periodic outbreaks and usually leads to chronic and vision-threatening condition from a free-living acanthamoeba on soil or water. As you can see here on the images, a typical ring infiltrate that we can see on the slit lamp of those patients, a culture plate that shows the cyst and also the trophozoites, and here a confocal microscopy that shows the an image of a cyst. The major risk factors for these conditions are contact lens related, either to the use of the contact lens itself or to the cleaning cases and solutions that we use, that these patients use every day. So we need to avoid these patients using, for example, basic saline solution that doesn't have any preservative and a high rate of contamination. Other significant conditions are trauma or bathing or working on contaminated water or soil. This is an interesting comment that was published in 2021 on the Microbe and the Lancet, showing the incidence that can vary from 1.5 to 2 cases per million per year of this condition. In India in 2006, a report showed that 1% of all cultures were positive for acanthamoeba. And there is an interesting outbreak in 2007 that was associated with a solution, a multi-purpose solution called Moisture Plus. And interesting, after this solution was removed from the market, still we were able to identify increase of incidence of acanthamoeba over the years. That's interesting because it shows that this condition is growing and it's of concern of all ophthalmologists. In these outbreaks, the incidence of the keratitis can jump from 17 to 70 cases per 10,000 contact lens wearers, which is a very high incidence for this disease. Usually the clinical presentation that we have on these conditions are chronic inflammation and infection of those patients. Those patients are usually non-responsive to previous treatments such as antibiotics or antivirals. They usually refer a very severe pain that doesn't match what we see in the slit lamp. And the most common slit lamp findings are ring infiltrates or the keratoneuritis, as we can see here in the pictures, the ring infiltrate on the top left picture and the keratoneuritis in the bottom left picture. Interesting, bilateral conditions like this can appear in 7 to 10% of those cases. This is not a new work, but is a very important one because shows how usually we can see the clinical findings on those patients. Shows, for example, that when the patient has limbitis, usually it appears on the early stage and it can last over 2 months of the disease. Also shows that keratoneuritis, which is one of the main clinical findings, usually appears more in the early stage and decreases over time. And in the opposite behavior, we have the ring infiltrate that usually we don't see a lot in the beginning of the disease, but it grows once we go over 2 months of the disease. The diagnosis usually are clinical, but we also use culture from corneal scrapings. Usually, they still are the gold standard for today. They are invasive technique. They take weeks to grow the acanthamoeba, and they have a low sensibility. Also, we can do corneal biopsy, which is also an invasive technique, and also we can have the simple error if we take a part of the cornea that doesn't show any acanthamoeba. It doesn't mean that the patient doesn't have. And also we can use PCR, which is a more sensitive test, but it's also invasive, expensive, and it's not commonly available in most of the places. So a different approach can be performed using in vivo confocal microscopy, which is a non-invasive technique. It can give us the same day result and help us to follow the patients during the treatment period. The two main structures that we can see using the confocal microscopy are the cysts, as you can see in the image here, several high reflective circular double-walled bodies, and also the trophozoites, who usually are these egg-shaped hyperreflective structures. The cysts are smaller, they range from 10 to 20 micron, and the trophozoites usually they range from 40 to 100 micron. Clinical treatment are challenging. Sometimes we have to use eye drops every hour for several days. Biguanides is one of the main drugs that we use, the PHMB being the principal one that varies the concentration from 0.02 to 0.06%. And it makes alterations to the cytoplasmic membranes, lead to the loss of the cellular components and inhibition of necessary enzymes for the acanthamoeba to live. Also, diamidines are another drug that we can use. The concentration usually 0.1%, and the most common ones are the propamidine, and they have the therapeutic effect by altering the permeability of the cell membrane, and that having the naturation of the cytoplasm of those acanthamoebas. Other two conditions that are common to be used are neomycin. That was the first line of treatment a long time ago. Today we use mostly to prevent bacterial superinfection and to reduce bacteria that are used as food for the trophozoites. Antifungal are very limited use in vivo, but in vitro studies with voriconazole, for example, appear to achieve very interesting cysticidal levels. So we have a really difficult condition to treat, and we have three very important comments here that shows that diamidines and biguanides, when they're used individually or in combination, the efficacy of this topical treatment can vary from 35 to 86%. 39% of the patients with acanthamoeba keratitis will fail the initial therapy. And individuals that have a more severe disease at the beginning and the history of the use of steroids before the diagnosis are more likely to fail the initial treatment. Surgical treatment are important. We can make use of the epithelial debridement, which can take off the load of acanthamoeba that are on the surface of the cornea and can also increase the drug penetration. Therapeutic keratoplasty also can be performed Usually we avoid to do that when we have a very inflamed eye, unless we have some conditions like cataract, a fulminant corneal abscess, perforation, or neovascularization. And also we can have different approaches using cross-linking and pack cross-linking that I believe is going to be talked a little bit more in the next lecture. So this is a case to illustrate a little bit what was said. This is a 29-year-old female that came with severe ocular pain with progressive reduction of vision in the past 5 months on her right eye. She had a corneal ulcer 1 year ago. There was treated with antibiotics and healed well. And in the past 5 months, she has been coming back to the ER with several corneal abrasions. She has been in with different treatments in the past 5 months, like acyclovir, moxifloxacin, ciprofloxacin, and dexamethasone. And when she came in, she was using fortified antibiotics hourly. This is the picture that we saw her the first time. She has a vision of 2400. She's a long-term contact lens wearer for myopia, and she appeared with this dense ring infiltrate. And when we performed the confocal scans, we were able to see the trophocytes here on image A, and also cysts in an isolate way or in forming clusters, as we can see here in the picture below. So this patient was treated with propamidine 0.1% hourly for 30 days and tapering it over 30 days. PHMB at 0.02% concentration, also hourly, and taper over 4 months. She healed well, and she ended up with a scar like this in the image, and with a best correct vision acuity of 20/40. Unfortunately, she was fine for 30 days, and then she came back referring again pain, photophobia for the past 3 days, and her vision decreased to light perception. We can see here in the image there is a new ring infiltrate. At this time we performed again a confocal microscopy, and we were able to still see cysts, and this was done monthly to follow up this patient. And here you can see at 1 month we still see it, at 2 months, and we still see it in this patient. So that's the challenge, how we treat those patients, how we follow up. Especially this patient, she was treated with propamidine again on 0.1% hourly and taper over 30 days. And an increased concentration of PHMB was used for the first 3 months. As she was being performed scans with confocal microscopy regularly, we started to reduce as soon as we saw less cysts on those patients. And then PHMB at 0.02% was used until we got 2 consecutive negative confocal. And that's when we decided to stop medication for this patient. And she is doing well now, over 2 years without any medication and any recurrence of the disease. But it took at this time 9 months of treatment to get her rid of this condition. This is very important, as was mentioned by Hammer and Lee at the Cornea Society meeting, the benefit that we can use the confocal and get better results for vision when we have diagnosed and confocal guided patients. So this shows how we end up with better vision when we have confocal as a tool to address this condition. It's a very challenging condition, as we mentioned. This increases because we have even more patients using contact lens these days. So we need to keep pushing for improved lens materials, improved cleaning solutions. And also we need to make more common the diagnosis of this condition, even to try to differentiate from very common conditions such as fungal herpes and bacteria infection, and also they use the confocal that can have a same-day result, but still needs a skilled operator that are used to the device. Also, treatment represents a very difficult period for these patients, as we are very challenging to get rid of the cysts. We have increased drug resistance with this condition, but we have new horizons, such as new drugs therapy that have some cysticidal effects, such as the use of anti-diabetic agents, and maybe nanoparticles, and all this new advance in technology will help us to deliver better drugs to the exactly tissue that we needed in a high concentration of those medications. And also new surgical procedures such as back cross-linking may play an important role in treating these patients well. I would like to thank everyone, and I hope that the message that I talk now help to give enough information for the ophthalmologists that are participating here in the meeting, and we will increase the discussions on the sessions. Thank you again for the invitation. Hope you guys have a good time.
Thank you very much. That's very interesting talk, and I wish you next time it will be physical also, not only to virtual. If you don't mind, Dr. Mahmoud Ismail, Dr. Nancy have to travel, so if she can give her talk before you, if you don't mind.
Of course. You're welcome, Dr.
Thank you
Nancy.
very much. Thank you. So it's a pleasure to introduce my colleagues, Dr. Nancy Ragad. She will be talking about viral keratitis. You can share your screen. So Dr. Nancy, she is a consultant ophthalmologist, head of corneal specialty Royal Medical Service of Jordan.
Yes, thank you for the invitation and the introduction, and I'm happy and proud to be among eminent colleagues and friends. My talk will be about viral keratitis, and I will concentrate about the herpes because it is much, and Dr. Hussam Ziada, I think he agrees with me, it's a much underdiagnosed disease in our community. So I'm going to be talking about the herpetic dilemma. Now, before we start talking, I want to present about the herpes, an ID card. It's a DNA double-stranded enveloped virus. It's a herpes simplex virus type 1 is the leading cause of infectious corneal blindness in the industrialized nations. Simply, it invades cells. There's a lytic stage that disrupts the cells because of direct invasion. And there's a latent stage that causes sensory and autonomic ganglia latency and stays in them. Now, highlights of my talk will be about transmission, the triggering factor, the presenting scenarios, post-herpetic sequelae, including neurotrophic ulcer, and treatment options, whether they are medical or surgical. Now, let's start with how it moves around. Now, herpes simplex virus is transmitted through mucosa to mucosa contact or by secretions from an infected person. Now, it's very important to know that once infected, it can never be eliminated. So it stays dormant in the nervous system of the eye. And most primary infections, they occur in childhood. And we should always emphasize on the idea of oral ulcers, mucosal ulcers that happen, like cold sores that we call, and these are all herpes simplex virus infection that become dormant in the body, and they can be triggered anytime later in life. Now, what triggers it? Actually, the most important determinant of herpes simplex virus keratitis infection is the genetic composition of the person. So the genome or the previous episodes are the most important determinant of a trigger. And then comes the other factors, which include the fever or cold, trauma, ultraviolet light, stress, surgery, psychological stress or psychological problems, immune suppression, hormonal changes such as menstruation and pregnancy. And these are all factors that play a role in triggering the herpes. So it's very important that you educate your patient and take preventive measures. I usually tell my patients who have more than one episode of recurrence of herpetic infection to have the flu vaccine every year, so that to decrease the rate of also recurrence, because of that triggers the risk of infection. Now, what about clinical presentation? We are talking about two disease entities: the primary herpetic disease, that's very simple and easy to treat, and the more important, the secondary herpetic infection. Now, primary herpetic disease comes with a wide range of symptoms. It comes as a blepharitis, conjunctivitis, sometimes corneal epithelial keratitis, and pain is most striking because there is a direct invasion of the cells, and there will be swelling, stretching of nerves, and lysis. Photosensitivity, redness, watering, and decreased vision. They're all part of the clinical picture of primary herpetic disease. Now, epithelial disease, as we said, it comes as punctate keratitis, usually lasts for 24 hours. And then when the cells coalesce, they cause this dendrite, the beautiful, unfortunately, the beautiful dendrite keratitis, and the edges are all virus-laden cells. Usually, the epithelial disease is self-limiting in around 12 to 15 days, but we don't leave the patients for that long. The treatment is usually with acyclovir or ganciclovir ointment or drops. If not available, we can debride it to decrease the bulk of virus-laden cells in the epithelium and give it some time to heal. And we might give oral acyclovir, famciclovir, valacyclovir, but they are not as effective as topical agents in the primary epithelial disease. Let's talk about reactivation, which is more important, and what exactly happens. Usually it's a triad. There's an immune inflammation from previously antigen-exposed CD4 cells, there's an active viral invasion, and there's a cytokine inflammatory response to the direct viral invasion. Now, and the secondary form comes in multiple forms. First, we have a recurrent epithelial keratitis, which is simple. Usually it's unilateral, and when it happens usually after 10 years of the primary infection. So a child that is 4 or 5 years gets this primary infection, and the mother or the family, they forget. And all of a sudden, when he's in 20s or 30s, the patient comes with a corneal edema that nobody knows what's that, or an epithelial keratitis. And we always forget to ask the patient if he had a history of a previous exposure in childhood of herpetic keratitis. And this is very important because I will highlight later how it affects our management. So a patient comes with a unilateral recurrent epithelial keratitis. Usually it is associated with haze. Stromal inflammation is the other clinical picture, and it is most common. This is what we most commonly see. Usually the epithelium is intact, and there's no actual virus here, but they are viral replicas that come and invade the stroma, and there's an immune response that is CD4 T cell related. So the cornea is edematosed, and there is haze in the vicinity. Now, when we talk about stromal necrotic keratitis, we're talking about the same mechanism. It is a reactivation, but in addition to that, there is a direct invasion of the virus. The direct invasion of the virus means that there is a more virulent inflammation. The symptoms are more severe. Usually, epithelial defect is associated, and the stromal progression, and there's a rapid stromal thinning, and there's a rapid progression to perforation in these cases. So it's very important once we spot a reactivation to differentiate between stromal necrotic keratitis or just simply a necrotic keratitis or endotheliitis that happens in the secondary stage. And the picture is usually resemble bacterial infective keratitis because of the presence of a hypopyon. And this is what we see most of the time referred to the clinic of patients being treated as bacterial keratitis for a long time, and then they're not improving, things are getting worse, and they are referred to our clinic with the late sequelae. Now, the fourth form is the endotheliitis. It is a direct infection of the virus with secondary inflammation. It causes an inflammatory reaction inside the eye. The cornea usually is edematized with distant membrane folds, cells, KPs in the vicinity. And this is what we call usually the triad of herpetic keratouveitis. So there is a herpetic keratitic precipitase, there's a decimate membrane fold, there are cells in the anterior chamber, and usually it comes in a disc-like manners and what we call disciform keratitis. It's very important, and I always teach my residents and fellows not to miss a herpetic keratouveitis, because sometimes they think this is a corneal decompensation and treat it with NaCl or hypertonic saline, and they do not. The patient gets worse, and they do not pay attention to their KPs in the vicinity. And if you look well and ask in the history, you will know there's a history of herpetic keratitis in the past. So, and there's a stromal edema, and this, as you said, triad of herpetic keratouveitis is associated with iris changes or cells, or sometimes it could be an endothelial involvement, and we have to act immediately. Now, I like this table. It's so simple, and especially for the young ophthalmologists to keep in mind that HSV keratitis classification comes in 4 terms. We have the epithelial keratitis, the stromal with ulceration, stromal without ulceration, and the endothelium. The epithelial keratitis comes in the form of dendritic or geographic if there's an adverent use of topical steroids, and the basic treatment is only topical antiviral, sometimes or debridement. Now, the stromal keratitis with ulceration is interstitial keratitis, and it is merely an immune stromal keratitis, and the whole mark of treatment is topical steroids with oral antiviral cover. Now, the stromal keratitis with ulceration is usually, which we call necrotizing keratitis, is very aggressive, and we have to give oral antiviral in therapeutic doses with topical steroids. In the endothelial keratitis, which is the disciform type, we give also oral antiviral in therapeutic doses as well as topical steroid. And then we come to how to treat. Now, stromal involvement without ulceration needs steroid under antiviral cover. While necrotic stromal keratitis, we need a therapeutic dose of antiviral agents, which is half the zoster dose. And I give my patients 400 milligram of oral acyclovir 4 times to 5 times daily until the inflammation is curbed. And then I go to the maintenance dose, which is very important in these cases of stromal keratitis. Because once the patient has stromal keratitis, this means he is at risk of recurrence, and we have to decrease the recurrence 50% by giving at least 1 year of antiviral agent. Now, if the epithelium is then intact, we can add steroids topically. And I like the fluoromethalone rather than Lotimax in this case. If the epithelium is breached, then we treat as the epithelial keratitis, and you wait and give the patient some time to heal for the epithelium, and then you kick in steroids because inflammation is very aggressive in these cases. When you see endotheliitis or herpetic keratouveitis, we give the therapeutic dose as well, which is 400 by 4 or 400 by 5 milligram for oral acyclovir. And maintenance is mandatory, as I said. It's important to listen to your patient because signs of reactivation could be subtle. Sometimes my patients say that I just feel funny. And when I come to the clinic, I discover there's reactivation of the virus. So it's very important not to under-treat these patients with a previous history of herpetic keratouveitis or herpetic keratitis. Now I'm going to talk about the post-herpetic sequelae. What we see in the clinic, we have after the inflammation and the infection subside, you see vascularization. And what is important about vascularization in post-herpetic keratitis is that usually the patient develop a one large caliber vessel. Usually it's one, not more than one, that bridges the cornea, and then they start exudating and causing crystalline or lipid keratopathy. It is usually segmental and with a wide bore rather than diffuse, not the one that you see in such as in chemical burns or stem cell deficiency. And the treatment options are: you have to keep the patients on antiviral and maintenance dose, you have to give steroids, and you can also obliterate these vessels using either cauterization alone. It is not sufficient. I give subconjunctival Avastin and sometimes or anti-VEGF or sometimes intrastromal in these cases to control the opacity. And these patients usually need therapy, not visual PKP, penetrating keratoplasty. And it's very important to obliterate these vessels before you go and hit the theater. Now, let's talk about some cases. It's very important to prioritize your management plan. So if the patient has a history of previous red eye, you have to ask him if this is a patient who came to the clinic with a perforation and she has never been treated before with for herpetic keratitis. So it's very important to ask if you had a history of recurrent red eye, and she said yes, I did, but she didn't undergo any treatment for herpetic keratitis. So she came with a late sequelae of perforation. It's important first to kill the virus, then seal the hole, then decrease the leak and help the tissue fight the break, and then give some hints with caution for the patient. So kill the virus, we give the therapeutic dose of oral acyclovir, which is 400 by 5. Seal the hole. I usually put a contact lens. I don't go to put a patch graft in these cases of active inflammation because the tissue is very friable. I usually give a contact lens and give the patient some time for the eye to heal. Sometimes it seals and I don't have to do and interfere with any grafting. I decrease the pressure on the breached descendant membrane with giving anti-glaucoma drugs like Timolol and Diamox to decrease the aqueous flow. And sometimes I give topical steroids, especially if there is no active ulceration. It depends. If it's only a perforation with no ulceration, I do give topical steroids. If not, I do not. I give only topical treatment with antiviral. Again, with prioritizing, this is a patient who came with a neurotrophic ulceration, a KPs, a segmental loss of iris tissue, and he is always treated for months. And the glaucoma, he was treated for months for the ulcer, for getting the whole inflammation in the eye. He came also with a hypopyon. So the first, now a patient who has an ulcer for weeks, you will not treat it in one or a few days. So it's important to treat the underlying mechanism, even if there's an ulceration. So it's important to kill the virus, to give a high dose of antiviral. You need to decrease inflammation. So I do give, even if there is an ulcer, in this case, it's not an active ulcer, it's a neurotrophic ulcer. I give a steroid in this case because I want to control the inflammatory phase of herpetic keratitis. I minimize the surface agents because I want to surface epithelium to heal. So bombarding it with a lot of anti-glaucoma drops and a lot of drops and antibiotics is of no use. بالعكس, on the contrary, it will harm and make the corneal epithelium more sick. And it's very important to use preservative-free drops, and we enhance epithelialization by using doxycycline, which is anticollagenase, and sometimes oral vitamin C that helps this to heal, and also to decrease the pain with either cyclopentolate drops. It's very important not to give these patients any non-steroidal anti-inflammatory drops, especially in the case of breached epithelium, because you will treat it and also perforate it in the next day if the one at the same glance that you give the patient non-steroidal anti-inflammatory drops to these patients. And I do cover the surface with a bandage contact lens just to help the drops that swim around the cornea while it heals. It's important also, one of the important things to watch for, especially in dealing with the patients with herpetic keratitis, and I always tell my patients it's a long-term relationship between the doctor and the patient, because they always bombard your clinic in ups and downs and flare-ups. So when you give antiviral medications, it's important to stop in pregnancy. If there's an impaired kidney function, you have to also stop it and monitor the kidney function after 6 months. If the patient is under immune suppression, because sometimes there is a thrombocytopenic purpura and hypersensitivity reaction to acyclovir, and you have to manage yourself with the topical antiviral agents. Now, what about neurotrophic ulceration? Neurotrophic ulceration is a very important topic. I'm not going to go thoroughly over it, but I want to mention it because it's important, and it is associated with herpetic eye disease. First, it is hyposthesia or anesthesia from corneal nerve damage, and it could be segmental or diffuse, and usually the related factors are dryness or damaged basement membrane of the epithelium or toxicity from other drops. Now, it starts as punctate epithelial erosions or epithelial defects and established defect with small droll edges. This means that it has been chronic, and you have to do more than just give lubricants in order to heal it. Now, what about HSV or herpes simplex keratitis neurotrophic ulceration? And there are three, it comes in 3 stages. Stage 1 usually is mild. It's not specific signs and symptoms. It's exactly the same as a non-healing defect after PRK, let's say, with punctate epithelial erosion, dry spots on the epithelium, that's stained with tholorsine. Stage 2 involves a non-healing corneal epithelial defect surrounded with epithelium becoming loose. The descendant membrane develops fold as the stroma swells and becomes edematous, and the effect forms a punched out oval or circular shape, and the edges become smooth and rolled with time. And there's no way, no matter how hard you try, at this stage to heal efficiently. Stage 3 often ensues if stage 1 and 2 are not treated appropriately, and stromal venting might ensue, leading to perforation. Okay, what do we do if we want to treat HSV and neurotrophic ulceration? First one is to stop unnecessary drops. It's very important to help the corneal epithelium heal instead of bombarding it with more drops that make it sick. Second thing is switch to preservative-free drops. Third thing is lubricate generously. One of the things that I want to mention is that patients with HSV keratitis and neurotrophic ulceration are patients who have glaucoma, and they use anti-glaucoma drops. And usually anti-glaucoma drops have a lot of preservatives, and this will cause the eye to become worse. If you are not at the luxury of having preservative-free glaucoma drops, what I do for only that period of time that I want to treat the cornea and to decrease how I rely on the anti-glaucoma drops, I have 2 options. I either give them oral acetazolamide to decrease the intraocular pressure while stopping or just abstaining from the oral of the anti-glaucoma drops that are preserved. And I give the patient sometimes the drops to be used sublingually. They just, instead of putting it on the eye, they just put it under the tongue, whether the Timolol or the Azopt acetazolamide drops. It gives I instill 2 drops or 1 drop twice a day of the anti-glaucoma medication in the under the tongue to have some absorption rather than in the eye. Just to give it some time to heal, and then I go back and give it in the eye as well. Stage 2, we have to provide cover to the bare epithelium. So I use a bandage contact lens, which is oxygen permeable, and this is very important. Sometimes Botox or tarsorrhaphy in order to just close the eyelid. Excuse me, amniotic membrane graft also can be used, but avoid amniotic membrane transplantation in cases where we have, Avoid amniotic membrane transplantation in cases where we have active infection, because you will make the things worse, not better. I'm talking about addressing neurotic ulceration after the infection has subsided, and then you can help the epithelium heal with transplanting an amniotic membrane. We do add antibiotic drops in order to help the cornea not catch an infection, and send aids, which are vitamin C and doxycycline, a high dose of vitamin C of 3,000 milligram daily, and doxycycline 100 daily orally, of course, helps in the healing of resistant epithelial defects. What about the perforation? I said a perforation, if it comes with only a perforation, I can seal it with a glue, I can do LML graft, and I always continue to support it with antiviral medication, decrease the intraocular pressure to draw it away from the site of the hole. And when the time is perfect, you can do a full thickness penetrating keratoplasty, but you have to keep the patient antiviral medication for some time. I think this, I'm going into the end. When to operate? I have a lot of referred cases from my colleagues asking me when to operate on a patient who had a history of herpetic keratitis, or if I have any recommendation for them. And I always answer, it depends on your surgery. And I do at least 3 months of flare-up free visits. I see the patient first, and I ask him to come the next month, the next month, and the third month. And I make sure that it does not flare up at all in the past few months, with on maintenance therapy of 400 milligram acyclovir twice daily, especially if I want to do a PTK for the surface opacity, or a PRK if it's a laser. And if it's a PRK, I usually go for a longer period of 6 months of flare-up free, and I give the patient a high dose, which is a half booster dose, 1 week around the surgical time. If it's a phaco or an ICL or a penetrating keratoplasty, I don't have to go that much. I do make sure that it is flare-up free for 3 months, and I load the patient, especially if he's undergoing phaco or PKP, with high dose of acyclovir preoperatively 2 to 3 days, and I continue for 1 week. And after 1 week, I just go down to the maintenance dose, and then it goes for a few months later. Corneal transplantation is important also, because the corneal transplantation in cases of viral keratitis or herpetic keratitis is not as easy as in patients of keratoconus. There's scarring, there's lipid keratopathy, there are vascularization, and there is a risk of flare-up. So you have to target your challenges, address the vessels at first, boost the antiviral dose before surgery, expect rejection, so put the patient on immunosuppression, and educate the patient that this is a long-term relationship, whether for the herpes or the graft, and they have to show up in any sign of discomfort they might feel in order to reverse any rejection or reinfection that might appear. And thank you very much. Thank you for the time, and thank you for the invitation.
Thank you, Nancy. That's very good talk, comprehensive one. I know it's also take a long time because it's very wide and big topic to cover. It's really a pleasure to have Dr. Mahmoud Ismail. He's a professor at Al-Azhar University, and he's the current president of Egyptian Society. And sorry to keep him waiting. And I'm looking for his talk for fungal keratitis. It's all yours. You can share your slides, Dr. Mahmoud.
Bismillah ar-Rahman ar-Rahim. First of all, thank you very much, Dr. Osama Bey. It is my pleasure, first of all, to see you. And we go back a way long together. And it's a very nice opportunity that we share with you some of the scientific work. And actually, we have to think together how to combat such infectious cases. الحقيقة, this is the fungal stria, and they look very beautiful, but actually they are very vicious, very, very vicious. And I think Dr. Hussam Ziada have gave some hints about it. And my role today in a comprehensive 9-minute talk, how to emphasize on the clinical points, on how to diagnose it just by looking to the slit lamp. Because as Hussam have said, and as our Brazilian colleague have told us, that diagnosis might take, the sample diagnosis and culture might take weeks. to conclude the diagnosis. So to start with the fungal keratitis, we have several types of them. The most vicious one is the fusarium, which is have a long hyphae, and it's very easy for it to spread from one point to another. That's why it looks feathery, and that's why it gets migrated from one place to other. Comes next the candida, and the candida, why it's very vicious, because at the beginning it looks like a red eye only. It does not declare war except after a few weeks even. Third, and it's not the least, the asparagus. Thank God that it's not very common in our country. It comes in a cauliflower appearance, and that's why the feathery appearance of a case of fungal keratitis with a white base, could be the asparagus because of the cauliflower type of infection. This is a typical case of viral keratitis, where you can see the pyramidal hypopyon and the feathery infection, and this is some sort of satellite spreading. And as Dr. Hussam have said, look for an implant origin trauma or abrasion. And the consolidated hypopyon or the pyramidal hypopyon with the feathery aspect and the late declare of war. It takes days and days, even weeks, to declare the war on your patient. This is how it looks on the slit lamp, and the typical pyramidal hypopyon or consolidated hypopyon. If you move the head, the consolidation means if you move the head of the patient from one side to another, the hypopyon keeps its shape and its architecture. Also, there is a typical form, which is when it comes to candida, this is the undermined. This is the ulcer, and the undermined in ulceration. It means that the ulcer is not confined to the such area in the front, but it's undermined and it goes behind the declared area of ulcer. Also, the satellite. This is a case of fungal keratitis following LASIK. As you can see, this is the LASIK flap, and this is the satellites. This is a patient who was misdiagnosed at the beginning, but as you can see, it's very clear, and this is the fungal satellite following the infection from a vicious unclean blade of microkeratome. So also it can mimic, and this is very dangerous. This is the appearance of a satellite of giving a picture of dendritic ulcer. And actually, the only difference between the dendritic ulcer and a fungal herpetic or dendritic ulcer, that the interlacing areas are hazy. In case of dendritic or herpetic ulcer, the interlacing areas are completely clear, and this is the only difference. Sometimes it comes with a stromal keratopathy and a very tiny ulcer somewhere here. Yani the whole cornea does not get stained, just a small ulcer, but it's the intrastromal keratopathy, and this is some sort of immune reaction following this is the ulcer. Imagine this is the ulcer, and this is the whole keratopathy, and this is a fungal keratitis following just a pinpoint penetration with a plant origin foreign body. And this is very vicious, and it took me a while to treat this patient because at the beginning it was not so clear. To treat cases of fungal keratitis, we have the original antifungal treatment, the family of the conazoles like fluconazole and itraconazole and the voriconazole. The fluconazole and itraconazole, they are already in the market with commercially used. The voriconazole, you can use it prepared. natamycin is in the market and amphotericin B. If you think that or you suspect that this patient is candida, the only treatment is amphotericin B. So, however, in our country, sometimes you don't find adequate antifungal eye drops, topical and drops. So you can start with neomycins and chloromphenicols. They have some sort of antifungal treatment. And this is as an aid till you either to use them as fortified. If you want to use the voriconazole, you can use the voriconazole in a fortified chloramphenicol eye dropper, and by removing 30 drops of the chloramphenicol and adding 1 milliliter of voriconazole, you have it readily prepared. So to conclude, it is not easy, and this is the highlights because we are running out of time. I shortened my presentation, Dr. Osama, because we are running out of time. The Egyptian Society of Ophthalmology welcomes everyone of our region to attend in our meetings. We hope to see you next year, Osama. You should come.
Inshallah.
And we will consider your invitation from us, please. And we will love to have you in the cornea session, as you are interested in cornea as we are. Save your date. It is April 24th to 26th next year, Dr. Osama Basha.
Inshallah.
Once again, we thank our dear Muhammad Al-Amri. Thanks to Muhammad Al-Amri, he gathered us all in this nice meeting. Thank you, Professor Osama.
Thank you very much. That's very good, comprehensive, cover all aspects of fungal, which is really very hard to treat and to diagnose. Is really the challenge also. Thank you very much.
شكرا أستاذ العزيز دكتور محمود على البرزنتيشن الرائعة. To the point presentation as usual.
And if you allow me to excuse myself, I have another Zoom meeting.
No problem. It's really a pleasure.
شكرا يا أسامة باشا. والله احنا مفتقدينك يا أسامة.
تسلم بالعكس والله أكثر. تسلم كثير. منورين.
شكرين يا أسامة.
تسلم.
شكرا يا باشا. شكرا.
So I will share my one. I'm going to talk about can we unshare, please? I'm not sure. Is it Dr. Hussam or?
Yes, sir.
I will share my presentation. I will try to just give it a quicker one also.
Yeah, okay.
So is it on now?
Yes.
Sure. Sorry for that.
Yeah, it's visible now. You just yeah. Yes.
Is it moving now?
Yes.
So basically, I'm talking about something which not common, but I think it's started to be. We are aware of it more. What you call microsporidia. As microsporidia is emerging in ocular pathogen, I think we are aware of it more and we diagnose it more. It's a tiny microspore which obligate intracellular protozoal parasite is belonging to Phylum Microsporidia. Recently, they reclassified as fungal, and there's at least 14 species, 8 genera, and this attack a human in different, usually causing intestinal problem, but also can ocular, sinus, pulmonary, or even renal diseases. And the predisposing factors, immune deficiency, like AIDS, trauma, contact lens, topical and steroid use, exposure to contaminated water or muddy water. And that's why you could hear about some outbreaks, and more common in area where they have recent seasons, and where there's a low socioeconomic and poor contact, poor hygiene in the water. And there's a reported outbreak in India, Singapore, in Far East. But I really start seeing them in our area in Dubai. I think there's a lot of, sometimes we misdiagnose them. So ocular manifestation microsporidia, first reported case was 1973. So it's not a long time that aware that microsporidia affecting the eyes. And it's considered as a rare, but I think it's, we are seeing it more and more, especially a lot of water park. There's some outbreak in water park in America, for example. So we can see it more in the pool area of contamination. And they're usually, they have different pattern. The commonest one, what you call superficial punctate keratopathy, which is common representation. Stromal keratitis is less, but it can also involve sclera and can cause also endophthalmitis. Superficial punctate keratoconjunctivitis, really, when you look to it, is really there's a punctate stain, is a race, of course. It's not like the adenovirus. It's like if really elevated. It's not like the adenovirus and stuck out appearance. Really, when you see it, it will stuck in your brain and become very clear sign for this microsporidia. But later on, it formed like a nummular keratitis, like the adenovirus. The other variety, what you call stromal keratitis, which is a deep, it happened in immune competent patient, but it's very slowly progressive infection, like a fungal. It can be focal or multifocal, deep infiltrate with or without ulceration. It could be mimic fungal, a typical mycobacteria or low virulent bacteria. The other presentation can be uveitis, corneal neovascularization, even can cause perforation, but it's very slow. And it tends to have very poor prognosis, the stromal keratitis. Diagnosis, really, the most important way to diagnose is corneal scrape and staining. That's the most important. So any corneal ulcer, typically, as Dr. Sham say, we need to do corneal, take a scrape and we do staining. But for this microsporidia, we always, if we suspect it, it's better to ask for specific stains. Modified trichrome stain, because that's more effective. QOIC or cauliflower, also very sensitive. Z-Nielsen stain is 96% they're positive. Gram stain, it can also, and GIMS, it can be detected in 80 to 77%. The other modality, which now popular, we use it for even different corneal ulcer, we can do PCR, which is very specific. If you had confocal microscopy, that's also very helpful test, biopsy, but it's difficult to grow this organism. The only way to grow this organism in cell culture, so it's not really practical. And you can use a confocal microscopy PCR to differentiate different type of microsporidia. A treatment is for keratoconjunctivitis is usually self-limiting disease. Topical antiparasitic, same as acanthamoeba, chlorhexidine, BHMB, brulin, fumigaline, all effective. You could use also topical antibiotic, hexamidine, one of the commonly used, but neosporin also, like netamycin, is also can affect it. Also for generation quinolones, it can affect it in microsporidia keratoconjunctivitis. You could use topical antifungal agent, voriconazole, netamycin, with or without systemic, and the systemic usually use albendazole, but also you could use itraconazole. Patient with stromal inflammation infection, you need to may need to use a steroid to reduce the inflammation, and usually resolve it in a few weeks without sequential. However, stromal keratitis, as we say, is more difficult to treat. It's also, you could use all the combination we mentioned before, BHMB, chlorhexidine, brulin, fluoroquinolone, but you need to use oral medication. Albendazole is the commonly used one, 400 milligrams twice a day for a few months, or itraconazole, but really the response is not as great, and many of these patients ended with corneal graft. And the Miller graft show they have high risk of recurrence, so many of the patients have been treated keratoblastic. This is one of the reported cases, 34 cases of microsporidia keratitis. And this is one message here, there's a lot of misdiagnosis, like 27% of them diagnosed as herpetic keratitis initially, 18% they diagnosed as fungal keratitis, and the corneal scrape, it wasn't just 47%, they have the staining. But however, if we did biopsy, 92% of these cases diagnosed microsporidia. So the diagnosis really sometimes very challenging, because you cannot, it's not the growth culture, the staining and the biopsy, that's the most likely yield. Although I think the BCR nowadays, it have very good potential. So if you suspect it, it's good to ask for BCR for microsporidia. Conclusion, microsporidial keratitis we are aware of it more. It can be happening in a healthy individual. High index of suspicion will help the diagnosis of this uncommon keratitis. if you do corneal scrape and corneal biopsy, please ask for specific stains and ask if you suspected, ask the pathology that you're looking for this. Keratoconjunctivitis, they have a specific raised coarse epithelium staining, and that's easy to diagnose, and really they respond well with treatment and could be self-limiting, take a week or two. However, stromal keratitis really could mimic HSBC, fungal or slow bacteria infection. It has slow prognosis and difficult to treat, and many they ended with corneal graft. And thank you very much. This, as I mentioned, this is a short one, and it's my pleasure really to have Dr. Hussam again to talking about back cross linking, which to close. If we don't solve the corneal ulcer when need treatment, I think we go for back cross linking now. So good to hear from Dr. Hussam any update on how to deal with this.
Thank you, Dr. Osama, for your very informative presentation. And I was with you in the last Emirate Society meeting in Abu Dhabi. Thank you so much. It's my pleasure to be with you. So let me to share screen because I know that the time is it is. And I will be on time this time. I hope to.
No problem, because we have last session. There's another session A. We joined them after.
So we have shown all types of the infectious keratitis, and now we are in the treatment. One of the new era in treatment options for the infective keratitis, which is the PAC cross-linking or corneal collagen cross-linking. I have no financial interest, but actually, as a quick run over on the cross-linking, initially developed in Germany and Switzerland 2003 to halt the progression of the conus. So it's based on the riboflavin drops and 365 nanometer ultraviolet A light, a combination of them. So there is an activation of the riboflavin, which will increase the cross links in between the corneal lamellae of the collagen fibrils of the corneal stroma. So because riboflavin acts as a chromophore and releases free radicals and creating new bonds between these collagen fibers and proteoglycans. This is the issue, and this is the base of why cross-linking is considered now in treatment of infective keratitis. Because this cross-links increases the biomechanical bonds and strength of the cornea, and also they have found that this photoactivation has anti-infective role, so it's now considered. So I will be fast. So the back of the cross-linking at the 9th cross-linking Congress in Dublin, a new term was introduced to be considered as a new indication for the cross-linking, which is the PAC. What's the PAC? PAC has a potential to eventually become an interesting subject to as an add to the standard antibiotic therapy in treating infectious corneal disorders, and may help reduce the global burden of the microbial resistance to antibiotics and other therapeutic agents. Let me to know what the word PAC stands for. It does stand for the P of PAC to photo, A to activated C chromophore, and K for the infectious keratitis, which is keratitis. So photoactivated chromophore for infectious keratitis. What's the story? So this slide shows the story of the PAC, the combination of UV light and riboflavin, causing to only strengthen the cornea, but also capable for killing the living cells and organisms, including keratocytes and the pathogens. So it's a new innovative concept added to both infectious keratitis and the cross-linking technology at the same time. One of the new era and options for treatment of the infectious keratitis and a new indication for the cross-linking. So initially advanced infectious melting ulcers resisting standard microbial therapy. Subsequently, the cross-linking was also used to treat bacterial keratitis as the first line therapy without the use of the concomitant antibiotic therapy. So let's say that the CXL technology is used for treatment of the infectious keratitis, not only the ectatic disorders. And I will summarize the whole story in this summarizing slide. The BACXL is riboflavin with the uveolite, increasing the cross-linking, so no melting, and also antimicrobial effect, which is the PAR, which is the photoactivated photoactivation of riboflavin antimicrobial issues. And we have to say that it can be used as an adjunctive therapy or sole treatment, and I will show that in the coming. The original idea of the cross-linking or the riboflavin activation, light activation, that the photoactivation of the riboflavin has been used before for many years in photochemical pathogen inactivation technologies for the fresh frozen plasma. So the idea came from this history. It was used as a sterilizer for the blood samples and in the lab. So the donor blood was treated for various pathogens by this PAR, which is photoactivation of riboflavin. The risk of infection for blood recipients was significantly reduced by this way. So the PAR's antimicrobial effect is applied in the cross-linking for corneal infectious disease, a new treatment modality. I will show here the clinical trials, but also for the sake of time, I will summarize the clinical trials in this slide. In 2000, Schnetzler and Seiler conducted a study about the non-infectious corneal melting. They enrolled 4 patients with sterile melting. And finally, 3 out of 4 patients, the melting stopped and didn't complete. And they saved the cornea from this melting. And the remaining one, the melting continued to happen because this patient was immunodeficient patient. There was another factor to increase the burden for this melting. Also, in 2008, Ezeli et al. Conducted the first study for using the cross-linking for infectious keratitis. And they enrolled 5 patients with infectious corneal melting. 3 of them was mycobacterial and 2 were fungal. And actually 4 patients out of 5 saved from corneal melting, and they could complete the other ways of treatment and surgical interventions. And finally, in 2011, McDomi conducted the first study on 16 patients with infectious keratitis with different pathogens. But McDomi used the cross-linking as a sole treatment, the first line of treatment without antimicrobial at all. And they found very, very encouraging results that 95% from these patients showed a surprising response to the cross-linking without antimicrobial treatment. And they started to prove at that time and stated that the cross-linking has antimicrobial effect by the photoactivation of the riboflavin. So recently, the Zurich group and Farhat Hafizi works with his team about a lot of works regarding this issue. So what I will show here a lot of clinical examples with the different protocols. So let's talk firstly about the protocols used in these clinical trials. The Dresden protocol, which is the conventional protocol, 3 milliwatts per cubic centimeters for 30 minutes, which is the conventional treatment for ectasia and infectious keratitis, all types of the infectious keratitis. Then the Zurich group recently announced about these protocols with accelerated Q1. Q1 means keratitis 1 protocol, 30 milliwatt for per cubic centimeters for 4 minutes. The total dose was 7.2 joule per cubic centimeters, per square centimeter, sorry. So sterile melting and with fungal and bacterial keratitis. This dose was enough to stop melting and to hold the progression and deterioration of the cornea with fungal bacterial keratitis. But they didn't use this protocol in the sterile non-melting or in ectasia. But they used this K2 protocol, which is keratitis 2 protocol, 30 milliwatt per square centimeters for 5.33 minutes. The total dose was 10 joule per square centimeters. And they found that it's very helpful and they showed a good response in cases of ectasia, sterile melting, and also infectious melting, including the fungal and the bacterial keratitis. And you will ask me why I'm saying bacterial and the fungal, and I didn't mention the viral. I will show at the end. This is an example for cases with the bacterial keratitis. A is pre-treatment, B is just 2 weeks after treatment, and C is for the 3 weeks after treatment. Done the same for both, and D is for 6 weeks, and finally after 2 months from treatment in E, and finally the surgical management of this corneal opacity by keratoplasty in F. Fungal keratitis, day 0, day 7, and then as you see, the back XCL in different kinds of the fungal keratitis. Central one in the upper photos, and peripheral one in the down photos, and as you see, showing a very surprising and very encouraging results. And finally, the geographical viral keratitis is limited use of the cross-linking in the viral keratitis, but it may be used in the fungal, in the geographical, to hold the progression of this surface expansion of this keratitis and the stromal invasion as well. Here is before on my left side, on your right side, and after treatment, around 2 weeks after treatment in the left side. So the conclusion, here the PAC CXL can provide an alternative adjunctive treatment option in the management of corneal ulcer, especially those caused by bacteria and associated with superficial infiltrates. The use of cross-linking in the fungal and acanthamoeba keratitis seems to be controversial, but many studies provided positive data about its use as an adjunctive treatment in these infections, not a sole treatment. We need more research, especially using appropriately powered randomized controlled trials to assess its true value, and they are working on. It will also be important to use well-characterized protocols, including case definition, inclusion and exclusion criteria, the outcome measures. Furthermore, it will also be important to publish both positive and negative results to show the truth. Finally, remember that CXL can do that by 2 mechanisms. By 2 mechanisms, the PAR antimicrobial effect, also the prevention of corneal collagen degradation to halt melting and persist collagenolatic enzymes. And thank you so much.
Thank you, Dr. Hussam, very much. Thank you all the speakers. It was very good cover for all this everyday problem we're facing in our clinic. And thank you for that attendee to stay with us late. As we know, we're running late. Thank you, everyone. And we conclude
Dr.
this
Osama.
session. Thank you very much, and hopefully see you very soon, inshallah.
Inshallah.
Thank you,
Thank
everyone.
you so much.
Thank you, and
Thank
good
you,
night.
Dr. Osama. Thank you, Dr. Muhammad Al-Amiri, for the invitation. And see you physically here in Egypt and there in Dubai, inshallah ta'ala.
Inshallah, inshallah. Thank you, everyone. Thank you, and good night for everyone. Thank you very much. Thank you.
Assalamu alaikum. Bye bye.
Assalam.